Good morning and warm welcome to the city of Nawabs. I, Dr. Madhu Kumar, on the behalf of Organizing Secretary of UPCYTOCON 2023, Department of Pathology, King George's Medical University, Lucknow, welcome to all delegates, speakers, guests from across the state of Uttar Pradesh country to this great academic feast in the UPCYTOCON 2023 under the aegis of Indian Academy of Cytologists UP chapter. I am immensely grateful to the faculty, delegate, resident from the various institutes, universities, state of medical colleges who have come to participate in this conference and workshop on LBC and square cytology. The enthusiasm of budding pathologists is reflected by the fact that we have received high number of registrations for the liquid-based cytology workshops and the variety of paper and poster abstract presentation. I, along with the organizing committee, extend a warm welcome to all these speakers and extend my sincere appreciation who have graciously agreed to share their expertise and insight with us. I am sure this conference will enrich knowledge of one and all and help us in giving better and more accurate diagnosis and aid in the better patient care. This conference serves as a platform for the sharing knowledge, excellence ideas that will contribute to new perspective to the challenges in the diagnostic cytopathology. It is indeed a matter of pride that the very first UPCYTOCON was also organized by KGMU, and this year we ensured that event happening on the same date as 10 years ago. And with this, we begin with the academic session. I hand over to the Dr. Himadri. Himadri, please. Thank you.
Thank you, ma'am. We first begin with 3 slide symposiums on ocular, bone and soft tissue cytology that would be taken up by Dr. Vaishali Walke ma'am, Dr. Chanika Kala ma'am and Dr. Nishat Afroz ma'am. This would be followed by a question answer session. I now request our chairpersons for this session, Professor Arun Chaturvedi sir and Professor Anurag Gupta sir, to please join us on the dais. Dr. Arun Chaturvedi sir is a professor in Surgical Oncology Department, KGMU, Lucknow. His research interests include head and neck cancer, gallbladder cancer, and clinical epidemiology. Sir has shown genuine interest in the clinical pathological meeting that held our department and always actively promotes such activities. He has been the past president of Indian Association of Surgical Oncology and England Fellow, USA. Dr. Anurag Gupta sir is a professor, Department of Pathology at RML IMS. His research focuses on oncopathology, breast pathology, and cytopathology. Sir is the president of IAC UP chapter and fellow of International Medical Science Academy. Thank you so much, sir, for joining us. I request our chairpersons to please introduce our first speaker.
So, good morning to all of you who have reached the venue of this exciting scientific meeting so early in the morning. And let's start with the first presentation, which is by Dr. Vaishali Walke, who is Professor and Head, Department of Pathology and Laboratory Medicine, All India Institute of Medical Sciences, Bhopal. She has wide teaching and research experience with about 40 publications and many presentations at various state and national platforms. Her areas of interest are cytology. Her areas of interest are cytology, neuropathology, and oncopathology. So may I invite Dr. Vaishali to kindly come to the dais and make a presentation.
Thank you, chairpersons. At the outset, I wish to extend my thanks to the organizing team UPCYTOCON for this invite and to share my little experience of ocular cytology. I have chosen this topic of ocular cytopathology here because this area is challenging and we rarely encounter cases of this rare variants, and this orbit or ocular conditions. They have unique locations and they consist of variety of specialized tissue, and accurate sampling, processing, knowledge of the diagnostic modalities will collectively help us to arrive at to give a quality diagnosis. So what kind of the specimens we encounter with ocular cytopathology are generally very small. There is a little scope of repeat and it demands meticulous allocation of appropriate ancillary test. So when we talk about ocular cytopathology, the common conditions which we encounter, they can be categorized as surface epithelial lesions, palpable ocular tumors, or there may be some non-responsive conditions like endophthalmitis or posterior uveitis. So in this category of lesions, which we can get, there's direct smears which consist of breast cytology, scrape smears, or impression cytology. If a palpable lesion we get, then we may try with FNAC, which may be guided or unguided, and this vitreous fluid examination can be a modality when we have this non-responding cases of posterior uveitis. So with this brief introduction, I'll start with the cases. So this first case is a 50-year female, and she has this diffuse ulcerated swelling of the eye, and she also had a history of loss of vision of around 6 months. Now on examination, we could see this lesion which is involving both the upper and lower eyelid, and there is some excoriation and induration also. So the scrape was tried from this excoriated region, which was not a good quality material. So we tried this needling from this indurated lesion. And what you can appreciate here is that on the screen, that these cells are, the smears are cellular. We can see the small groups of cells, scattered cells, and the background of some of amorphous material. Now on higher magnification, the cell have indistinct outline, but you can see pale pink cytoplasm, enlarged nuclei, high NC ratio, and some nuclear pleomorphism is also appreciated. Now, bizarre cells apart from mitosis is also evident, and what is the speciality here on GIMSA is that we can appreciate the background. So lipid-rich background along with these pleomorphic polygonal cells with enlarged nuclei, and the cytoplasm was also showing this vacuolated, multivacuolated texture. So with this features, that is a ulcerated lesion which was treated previously, which has not responded to the conventional treatment, which has involved with gradually both the upper and lower eyelid with loss of vision. Any possibilities in this case? Yes. Yes, very good. So what clues or what are the pointers here is that, so also I'll discuss. So also we call this patient and we have re-examined, and we could see a small lymph node submandibular location, and this FNAC from this lymph node also revealed a similar morphology. So later on, the investigations in the imaging findings were also provided to us. So it was an intraocular region, a swelling in the intraocular region with a destruction of the floor and medial wall of the orbit, and it was also extending to the nasal cavity. So sebaceous carcinoma, as you have said, is the most likely diagnosis, but we need to know, rule out the other common conditions in this region. Can be a basal cell carcinoma or a squamous cell carcinoma. So basal cell carcinoma generally yields tightly cohesive clusters, uniform basiloid cells. You may appreciate peripheral palisading, hyperchromatic nuclei, and scant cytoplasm. While when you talk about squamous cell carcinoma, they are generally also the polygonal cells, but we may see evidence of keratinization, and these cells will have a dense eosinophilic cytoplasm. So that is a character in contrast to what we get in the sebaceous carcinoma. Subsequently, this lesion was biopsied, and we could see ulcerated lesion, and with a dense inflammation in the area of ulceration and the subepithelium, we could see the nest of tumor cells. So pagetoid spread we could appreciate, So the pointer is giving you this. So this is a pagetoid spread we can appreciate, and the nest of tumor cells with a large pleomorphic nuclei, multivacuolated cytoplasm, and this is what we came to as a diagnosis of. So these are the clues for this diagnosis, and so it arises from the meibomian gland and or the tarsal plate and the glands of this in the eyelashes. This ocular counterpart of the sebaceous carcinoma is frequently masquerades and with a less aggressive lesion like chalazion and blepharitis, and it is responsible for the delayed diagnosis and poor outcome. So that is why the early diagnosis is imperative in this case. Now another case I'll be discussing is of a palpable superficial mass, and it belongs to the lacrimal apparatus. The lacrimal apparatus consists of a lacrimal gland, and we have this lacrimal sac, this canalicula, and this is a nasolacrimal passage. So this case is a 48-year male who presented with the medial canthus mass of around 7 months, which was gradually increasing. There was also an evidence of euphoria and it was on local examination shown as a firm, mobile, and overlying skin was tense. So it was 4 by 4 centimeter mass. Now, when we look at the smears are very cellular. We could see the thick fragments, which are tight clusters and small groups of cells also. And on GIMSA, we could also appreciate this endothelial fragment and the cell clusters adherent to these endothelial fragments. Along with that, we have these small groups of cells also. So these cells basically are oval to spindle cells with elongated wispy cytoplasm, monomorphic nuclei, and with fine chromatin. So these cell features or nuclear features are better appreciated here. So this pale wispy cytoplasm, monomorphic nuclei, fine chromatin, inconspicuous nucleoli, and no mitosis, no necrosis. So any possibilities in this case? So this is spindle cell neoplasm, and these 3 possibilities we thought of, whether we are dealing with a benign fibroblastic tumor or whether it is a low-grade monophasic annual sarcoma or we are dealing with a meningioma. So with this thought process in mind, further investigations, we revealed that there is a homogeneously enhancing mass in the lacrimal sac causing the dilatation of the nasolacrimal duct and distendation of globe. So the thought process was there was a neoplastic origin, and so this is what we can see. This is a mass located into the lacrimal sac. So what we that time we could think about, and so we did this stain on a de-stained smears of GIMSA, and the CD34 was done on this de-stained smear, and we could appreciate this cytoplasmic positivity for CD34. So the localized tumor situated in the lacrimal sac, monomorphic spindle cells adherent to the endothelium, pale wispy cytoplasm. This is CD34 positive. So we thought of solitary fibrous tumor. Now subsequently the lesion was excised. It was a nodular mass, grayish white. The largest size was 3.6 centimeter, and we could see also some areas of hemorrhage that you can see. This is the specimen. And here on histopathology, we can see this well delineated lining epithelium of the lacrimal sac, columnar epithelium goblet cells, and this is a well defined circumscribed mast, and you can see this spindle cells with forming various patterns, and this with slit-like blood vessels. So again, this pattern is well appreciated here. We can see whorls and storiform pattern, and we can see some amount of blood vessels here and there. So these cells, again, they are oval to plumb to spindle cells with monomorphic nuclei, fine chromatin, and with no marked atypia and mitosis and necrosis. So with this morphology, the conditions which we thought of, whether we are dealing with SFT, that is fibroblastic lesion, synovial sarcoma, meningioma. So CD34 positive that we have also seen in cytosmias favored this solitary fibrous tumor, and or whether there is a benign fibrocytoma or a DFSP, which is even though very rare. So to rule out synovial sarcoma as such was very less likely. So to exclude a meningioma, we have done EMA and PR, which was negative, and TLE was not done as the possibility of synovial sarcoma was less likely in this case. So this CD34 was well illustrated as a cytoplasmic positivity in tumor cells, and we could also do STAT6 in this case, which is a diagnostic hallmark of this. So to with this all these features, we consider this as a solitary fibrous tumor. So as we all know, it is more common in pleura, but in the head and neck it is seen, and oral cavity, sinonasal tract, soft tissue of orbit and skull, and lacrimal sac is as such an unusual location. And because it is superficial palpable lesion, it could be easily aspirated as on FNAC, but however still with us only the cytology diagnosis, accurate diagnosis in cytology is challenging. We need to have the radiological findings, ancillary tests to arrive at a definitive diagnosis. So it is what literature says, that alone the morphology is not predictive of the prognosis, that is metastasis and recurrence. So we have to take into account the tumor size, age, the tumor size, mitosis and necrosis to give a score to predict the recurrence. So this this NAB2 STAT6 gene fusion is a hallmark of this disease, and for this STAT6 is a surrogate marker, and which can be has a very high sensitivity and specificity to detect or diagnose solitary fibrous tumor. So even though the repeat aspiration is not possible and the cellular cannot be made, we can make this staining of this STAT6 or on the de-stained ICC smears. So this is the follow-up of this case. So after 1 year of follow-up, there is no recurrence, and patient is doing well. Slight epiphora is there. So this third case is of intraocular fluid cytology. So this 65-year male who presented with diminish vision, and he of a gradual onset, and he presented with these symptoms, and there were multiple consultations, and patient had no relief. He was also put on these topical steroids, and there was no response. So they thought of whether this is a non-responsive posterior uveitis or vitreitis, and they advised a B scan. So on B scan, they could see this vitreous membrane, and they planned, the surgeon planned for this vitreous biopsy. So we received 2 ml of clear, colorless, thick vitreous fluid in a fresh state in the syringe, and these are the smears. We can see this is a cellular smear, dispersed population of monomorphic cells. This is GIMSA and PAP. And on higher magnification, we could see these cells are relatively large. They are pleomorphic. Some amount of cytoplasm is appreciable here and there. And they have a convoluted configuration, nuclear membrane, but we could not appreciate a very conspicuous nucleolus. This some amount of amorphous material is also seen in the background. Still on higher magnification, we could see this large cells with this better morphology here, and this crushed and smudged nuclear material because of degeneration was also one of the feature we could see. And looking at this clinical picture and morphology, we thought of whether we are dealing with so steroid non-responsive vitreitis, B scan with vitreous membrane, cell-rich smear showing this monomorphic large cells, pleomorphic nuclei, smudged and crushed nuclear material in the background. We thought of this, that where we're dealing with a lymphoproliferative disease, that is NHL. So we are highly suspicious kind of morphology. So this was the diagnosis we offered. Now the imaging was advised, and on the very month, it didn't reveal any abnormality. After 2 months of follow-up, patient presented with a complaint of forgetfulness and headache, And ocular examination that time was within normality. There was no recurrence of the vitreous membrane. So then patient lost to follow-up. Then he again reported to the institute in the trauma and emergency with a history of aphasia and hemiparesis. So what we could appreciate here is that this is relatively defined enhancing interaxial mass, quite large in the periventricular region, and which is extending to the hippocampus and parahippocampal region, which is causing mass effect with evidence of some herniation. So this was the MRI in the month of December. So and so when he reported to the trauma emergency, he was operated there, and he what we could see, the excision of the mass was done, and what we could see this beautiful images showing this monomorphic, diffusely involving this tumor cells with this large cells with scant to moderate cytoplasm, enlarged nuclei, close to chromatin and prominent nuclei. We could also appreciate some mitosis here and there. So this was the morphology. And we could do this, they were CD4 positive, CD20 positive, so this is a large B-cell lymphoma. So vitreoretinal lymphoma, if we talk about, it is said that it is a rare variant of primary CNS lymphoma, which is a high-grade and aggressive disease, and about 50 to 90% of vitreoretinal lymphoma patients presents with developed CNS lymphoma in a period of 16 to 24 months. So close follow-up is required. These patients of vitreoretinal lymphoma can also have a concurrent CNS involvement in 16 to 34 patients, 30% of patients. And 15 to 20% of all primary CNS lymphoma can have a coexistent vitreoretinal lymphoma at presentation. So diagnostic of this kind of pathology is challenging. We need to have this because it masquerades as a uveitis, so as a treatment-resistant uveitis. So the vitreous examination is said to be a gold standard in this case. And this patient, if the facilities are available, you can go for this IL-6, IL-10 ratio, which can also help you which has a high sensitivity to arrive at a diagnosis. This patient is put on high-dose methotrexate, systemic chemotherapy. So to summarize, when we're talking about ocular cytopathology and diagnosis, high index of suspicion because of deceptive clinical presentation, understanding the best modality of sampling, the preparatory methods, which is the better, we have to take the judgment. And in case of when you are getting this intraocular fluid cytology, a close conversation with the clinician or a surgeon is important, so to prompt analysis of the specimen. So the evaluation of ocular masses needs a multimodality of approach, balance between the strength and weaknesses of each modality. And this ophthalmic cytology is a specialized area which demands expertise and experience to offer a prompt diagnosis. So thank you.
So thank you very much for showing such interesting cases, and I think we'll have some questions later on. So thank you very much for a very nice presentation.
Thank you, sir.
Thank you so much, ma'am, for such an intriguing session. I now request our chairperson to please introduce our second speaker, Dr. Chayanika Kala, ma'am.
So I would like to invite the next speaker for this session, Dr. Chayanika Kala, who is currently Associate Professor in the Department of Pathology at GSVM Medical College, Kanpur. And she has many publications, both national and international. And she has given multiple presentations at various conferences. And she has received multiple honors in various subjects. And she has guided and co-guided many theses as well. She has completed a few projects with the IIT, DHR, ICMR, etc. And she has interest in the oncopathology and gynecopathology. Yeah, you can start.
Thank you, sir, for such a brief and crisp introduction. A very good morning to all of you, and pranam to my Gurujans from my alma mater. The topic given was bone cytology. The bone cytology is not widely accepted as a diagnostic tool for the diagnosis of bone tumor. The low diagnostic yield inadequacy, variable overlapping cytomorphological features, variability in reported sensitivity and specificity in various literature. These are the few factors which limits the role of FNAC as a diagnostic tool in bone cytology. But still, it is used as a diagnostic tool in developing countries. As far as the incidence, we talk about the incidence, the metastases are more common than primary bone tumors, and primary bone tumors account for only less than 1% of all malignancies, and in childhood, it accounts for less than 5% of all the tumors. But the incidence of advanced malignant tumors with bone metastasis is very high, and the incidence ranges from 30 to 75% in various studies. So here I am presenting few interesting cases which primarily present as primary bone tumors, but later on subsequent follow-up, they come with very interesting and very unique diagnosis on cytology and histology. So the case one is, she was a 50-year female presented with swelling over right side of upper back for 2 months with no other significant history. Her CT scan showed a bony lesion in right scapula with significant soft tissue component. So we did FNA, and FNA smears were quite cellular, revealed diffuse population of predominantly round to oval cell. On high power view, we can appreciate predominantly plasmacytoid cells having finely granular chromatin, occasional prominent nucleoli, and eccentrically placed nucleus and amphophilic cytoplasm. On further high power view, we can appreciate few multinucleated tumor cells along with few binucleated tumor cells and abundant amphophilic cytoplasm. So on the basis of cytology, we made a diagnosis of malignant tumor with plasmacytoid morphology. The possibilities suggested are plasmacytoma, and along with plasmacentric or plasmablastic cells, we also get some round cell. So we suggest a possibility of metastasis from some another place. So we offer electrophoresis for patient. Her electrophoresis was normal. So we came back to patient, and on repeated questioning, patient told that there was a history of difficulty in swallowing for last 5 months. Her ultrasound revealed 1 centimeter mildly vascular ill-defined nodule in left lobe of thyroid, and her serum calcitonin levels were high. So patient underwent total thyroidectomy, and her biopsy specimen revealed infiltrative growth comprising of nest of tumor cells separated by fibrous septa with some eosinophilic material in between. On high power view, the tumor cells are round to oval, having finely stippled chromatin and forming ill-defined rosetoid-like structure at places, and the tumor cells were positive for calcitonin. So finally, we made a diagnosis that it is a metastasis from medullary carcinoma thyroid. So what is the takeaway message from this case? Not every plasmacytoid cell in bone is plasmacytoma. It can be a metastasis from metastasis from thyroid, breast, or metastasis from plasmacytoid variant of urothelial carcinoma, or it can be a metastasis from gastrointestinal tract. And one should always rule out lymphoplasmacytic lymphoma as a differential diagnosis of a plasmacytoid tumor. Now coming to the case number 2. He is a 55-year-old male presented with swelling right side of a thigh for 8 months. There was a history of pain and redness also for 2 weeks. History of trauma was present, and on examination, diffuse bony swelling on lower end of thigh measuring 7 by 7 centimeter. Her routine tests were within normal limit. His X-ray, CT scan, and MRI show a lytic lesion in the lower end of femur. We did a FNA smear were cellular, reveal mixed population of lymphocyte plasma cells, occasional neutrophils, and fair number of histiocytes, along with few large pleomorphic bizarre cells. Here we can appreciate these pleomorphic cells. Here we can appreciate these pleomorphic large cell. And the smear also reveal fair number of imperipolysis. Here we can appreciate these imperipolytic cells. Now talking about the large pleomorphic cell, these are large pleomorphic cells. Few are multinucleated, having Pac-Man-like appearance. Few tumor cells are showing imperipolysis with incurved lymphocyte in their cytoplasm. And here we can appreciate a large pleomorphic cell. So on the basis of cytology, we suggest a possibility of some histiocytic neoplasm with possibility of histiocytic sarcoma, malignant Langerhans histiocytosis, or dendritic cell sarcoma. A wedge biopsy shows similar sheets of tumor cells which are large polygonal, having central vesicular nucleus, prominent nuclei, and abundant eosinophilic cytoplasm. We did some immunohistochemistry on that block, and the tumor cells were positive for histiocytic marker CD4 and CD68, while the tumor cells are negative for Langerhans cell marker like CD1A and dendritic cell marker CD21 and 23. So finally, we made a diagnosis of histiocytic sarcoma. So histiocytic sarcoma is a rare neoplasm of histiocytes, often presenting as a disseminated disease involving skin, lymph node, liver, spleen, or GIT. And primary bone involvement is very rare in this case, in this disease. So sometime a systemic or multi-system disease may present primarily as a bony lesion. So always be skeptical, and thorough workup is recommended if you suspect some histiocytic neoplasm. Case 3, she was a 35-year-old female, presented with back pain and low-grade fever. Clinical diagnosis of pot spine was made, and the patient was sent for FNAC. We did FNAC, and FNAC smears were quite cellular, revealing small basaloid cells forming sheets as well as gland-like structure, acini-like structure. At places, these acini are lying back to back with central eosinophilic to amphiphilic basement-like material, giving a adenoid cystic-like appearance. At many places, the tumor cells are surrounding basophilic or amphiphilic hyaline globule or spheroid-like material. So the diagnosis was straightforward. It is a adenoid cystic carcinoma. But from where? So we again back to patient, and patient gave a history that she was operated 5 years back in a small nursing home in a village where histopathology was not done. And further workup revealed a renal mass also and multiple lung metastasis. So basically it was a case from parotid adenoid cystic carcinoma metastasizing to bone, lung as well as kidney. Her CT scan shows a renal mass in right side of the kidney, and histopathology shows compressed renal tissue on the right upper side and left on left lower side. We can appreciate the adenoid cystic carcinoma. So the final diagnosis was metastatic adenoid cystic carcinoma. So adenoid cystic carcinoma is a tumor of major as well as minor salivary gland. The rate of local recurrence and distance metastasis ranges from 16 to 67%, and lung is the most common site of metastasis, while bone is less common site of metastasis. And one must keep this fact in mind that many a time patient may present with metastasis years after removal of primary tumors. As in this case, the patient presented after 5 years of removal of primary tumor. Case 4, He is a 48-year-old male presented with right-sided chest wall swelling with no other significant history. On examination, diffuse bony swelling of 5 by 5 centimeter on right side of chest wall. His X-ray revealed a lytic lesion in 7th rib. So we did FNA of the case, and the FNA smears were quite cellular, revealing sheets of round to oval cells as well as small acini-like structure. So these cells show minimal pleomorphism, nuclear overlapping, and moderate to abundant amount of cytoplasm. And at many places, these tumor cells are lying back to back, forming acini-like structure. So we made a diagnosis of metastatic adenocarcinoma, and possibilities suggested that it could be from prostate or it could be from renal origin. So further workup revealed PSA, which was raised 48.6 nanogram per ml, and his ultrasound shows a hypoechoic mass in the prostate, and his biopsy revealed back-to-back lying prostatic glands with variable amount of prostatic stroma in between, and most likely it's a Gleason's grade 3 pattern. So final diagnosis was it's a metastatic adenocarcinoma from prostate, and prostate carcinoma is one of the most cancer metastasizing to bone, and whenever in FNAC we get monolayered sheet like a sheet of fibroadenoma, we always suspect metastasis from prostate. So I conclude my presentation with a quote from Steve Jobs: "Don't let the noise of other opinion drown your own inner voice." So whenever you suspect something fishy or something doubtful in a case where clinical presentation is like primary bone tumor, but you suspect there is something fishy, something outside has penetrated the bone, then always listen your inner voice. Thank you very much.
Thank you, Dr. Chenika, for presenting such a beautiful cases. I think we will continue with the same session and I would like to invite the next speaker for this session, Dr. Nishat Afroz. Is she there? Yes.
Please welcome ma'am.
Dr. Nishat is a professor of pathology at JV Medical College, AMU. She has more than 70 publications, and she has delivered multiple lectures at various conferences, and she is a reviewer of multiple journals, and she has completed one project. Her area of interest is histopathology and cytopathology of various organs. She will be speaking on soft tissue cytology.
Yeah. A very good morning to all dignitaries and respected seniors and dear delegates. So with the two very interesting sessions already over, I'm going to present this on the soft tissue pathology cytology. So the soft tissue pathology is always a nightmare for many of us, and so is for me also, since the soft tissue is just like not any single organ. It is present all throughout the body, be it brain or head and neck or chest or abdomen or extremities. Soft tissue is everywhere, so the tumors are everywhere. So it would be, I would not be doing justice if I cover all the things and this thing. So I'll just highlight a few interesting cases which may be so challenging on cytology, and we will, as we move on, we will come to know how to deal with these tumors. So with this, Soft tissue lesions. Before we go on, we should always remember that what points are to be considered before we diagnose a soft tissue tumor on cytology or even on histology. First of all, it is the clinical details of the patient. The clinical detail is a must. If you do not have clinical detail, do not diagnose any soft tissue lesion or tumor. So the clinical includes age of the patient, whether it's a child, it's an adolescent, it's an adult, or it's an old age patient. Now the site is so important that if a tumor, if it is confined to like viscera or some hollow cavity, for example, oral cavity or nasopharyngeal or some urinary bladder, the diagnosis is straightforward. If you have history of 10-year-old male child presenting with the grape-like masses in the paranasal sinuses or in the vicinity of the oropharyngeal area, you could have easily diagnosed though that it is going to be an embryonal sarcoma or rhabdomyosarcoma. So the site is also important because some tumors are they are definitely inclined to more, some sites. Now, duration of the lesion, whether is this a slow-growing or a fast-growing tumor, or the tumor presentation is also important, whether it is a painless or painful. So the tumor which grows very rapidly and is painful is going to be benign, and maybe just a benign lesion or a pseudosarcomatous lesion. A tumor which grows for a long period or a short period, but it is not painful and the patient does not have any major complaint apart from a swelling or mass, then the tumor could have been a malignant one. So the clinical details are as mandatory as other things are. Now, as we go on after clinical details retrieval, we should always go for an X-ray and ultrasound if it is abdominopelvic mass, or CT and MRI is important. Now, of the CT and MRI for soft tissue, MRI is always preferable because it gives a fine detail of the different compartments of the soft tissue, and it gives very good post-contrast enhancement, and the MRI is always preferable over CT scan. The biopsy we can obtain if it is approachable, the core needle biopsy, or if it is intra-pelvic or it is a deep-seated lesion, then always a guided FNAC or core needle biopsy is suggested. So the ISC, most of the time it is not that like we apply one marker, ISC marker, and we are able to diagnose any tumor straight away. We have to use the marker judiciously, and also we should use a restricted number of markers, and we should not throw like 10, 12 markers and get nothing out of it. So the knowledge of the appropriate ISC markers is important, and do not apply all the secondary markers, so you have to really design first line marker, lineage specific marker, or the second line markers. Now the molecular analysis would be required in few difficult cases where no clue is possible even after the extensive ISC. So coming to the case 1. So case history was like a 45-year-old male presented with a slow-growing soft tissue mass in the right gluteal region of 4-month duration. It was a painless mass, but it had off and on dull pain and tenderness in the gluteal area, but no fever or other complaint, just to rule out any inflammatory or infectious pathology. Now USG abdomen pelvis revealed nothing. X-ray showed soft tissue shadow density in the gluteal region, but no calcification was seen. Now MRI scan of the gluteal region on T1 weightage image showed where the arrow points out on an isodense lesion. Can I have a marker, please? The pointer is showing a well circumscribed area, the mass, which is iso-intense with the adjacent gluteal muscle. So there is no difference between the gluteal muscles which are going up, and there is a well circumscribed mass. The arrow is pointing toward that. So the next step would be to go for T2 weighted image. And in the T2 weightage, in the first image, you show there are fine lines of septation. The septa are there, and it is hypo-intense. Now, when you do the post-contrast T2 weightage image, you see some degree of hyper-intense intensity as compared to the gluteal muscle, which is there on the top. So the MRI scan reveals a lot of knowledge that whether the tumor is well circumscribed or it is infiltrating or invading, and whether it is having heterogeneous appearance, which indicate that it is having a necrotic. Change it. Yes. And for highlighter. Yes. Highlighter. Okay. So the tumor is like this. So the workup will always include the MRI followed by CT guided FNSC, since it was a deep-seated lesion, so we could not have performed, we should not perform the direct FNSC. So CT guided FNSC were performed using 22 gauge needle, and we prepared the smears for MGG and for PAP, and we fixed the two smears in the 10% buffered formalin. Cytological features showed cohesive clusters. I mean, first of all, first thing we should look for is the cellularity of the smear, whether the smear is cellular, hypercellular, or hypercellular. So it was a moderately cellular smear, and it has got the cohesive clusters of varying shape. You know, some may be having a fascicular appearance, or some may have a trabecular or cord-like clusters. Now, the important thing to mention is that it had the pink collagenous stroma, and if you see it on MGG smear, you see there is a cohesive cluster. The cohesive cluster, they have very closely packed, bland-looking cells with the spindly to oval nuclei, and they have got a background material which is supposed to be maybe a collagen. So it is a very tightly cohesive cluster, and the cells look so much bland. So on seeing this smear, we could have said that it could be a benign nerve sheath tumor such as schwannoma, or some other benign lesion can be there. However, we are not sure what type of lesion it could be. So the further on PAP smear, we see that the cells are also discohesive with scattering of the cells. Cells are having minimal amount of wispy cytoplasm, and they have short spindle nuclei. On the right side, the cells are arranged in a loosely cohesive pattern. They are arranged like just haphazardly. They are not forming any structure or organoid kind of thing. They are just haphazardly distributed, but they look benign. So on first impression, it is a benign spindle cell neoplasm. So further, PAP smear also showed the similar thing, but in the background you see there is some pinkish collagen-like material. So it is a benign tumor which is having spindle cell morphology on cytology, but also having some pinkish background material also. So we can have a 2, 3, or 4 differential diagnosis on the basis of clinical history as well as on cytological appearance. So the diagnosis could have been, we could have rendered like a benign mesenchymal tumor or a spindle cell neoplasm not otherwise specified if you are not sure whether what kind it be, or you could give a differential like benign nerve sheath tumor. It could have been a schwannoma, or it could be a solitary fibrous tumor, or a spindle cell carcinoma. You always have to rule out, and the low-grade sarcoma. So these are the 4 possible differential diagnoses after seeing the cytology. Now, on histopathology, obviously, first thing to do is to get the core needle biopsy before the resection is performed. So we got very limited tissue, and the diagnosis rendered was benign nerve sheath tumor. When the resection was performed, the scenario was totally different, and we saw tumor which was heterogeneous in appearance, means some areas showed cellular area, some areas were myxoid, and some had very, typical staghorn type of blood vessel. So what we see here is that there is a abundant collagen in the background, and there is patternless pattern of bland spindle cells without prominent pleomorphism or obvious mitosis. So the mitosis is not there, and in the second image you can appreciate that the cells are just they are forming some whorls, but actually they are not forming some story-form pattern, or some pattern is not there. You cannot call it a pattern, so it is a patternless pattern. So the next set of images will show that there is a heavy collagenization in the background. There is a hypocellular area, and the collagen is very much obvious, and you see the bland spindle cells traversing through the collagen. There are no mitosis, and the necrosis is not visible. On the right side of the image, you see the prominent blood vessels which are dilated, and they have perivascular hyalinization. So the hyalinization plus myxoid change and the collagen, they all give you a clue to a final diagnosis. The next slides, they are showing the staghorn, the dilated branching staghorn type of blood vessels. Earlier we used to call it hemangiopericytoma like blood vessels. So these are the dilated staghorn type of blood vessel. You will appreciate in not all but some of the areas if you examine it thoroughly. So though we went for the ISC workup, and what is highlighted in yellow, they came positive as CD34 diffuse and strong cytoplasmic positivity was there. And then we worked up to rule out other spindle cell neoplasm, like we went for epithelial markers and for smooth muscle origin tumor and for neural tumor, and we got STAT6 positivity which was strong. And Ki67 was less than 5, since there was no necrosis, no mitosis, no pleomorphism, so it was expected that Ki67 will be low. So the CD34 was strongly and diffusely positive in the cytoplasm of all cells. Ki67 was less than 5%. And the STAT6 on the resection specimen shows diffuse and strong nuclear positivity, so thus confirming the diagnosis of solitary fibrous tumor. So along with CD34 and STAT6, it is SFT. However, the STAT6 is fairly specific surrogate marker of NAP2 STAT6 fusion, but still it is positive in some other mesenchymal tumor. So all alone, without histomorphology and cytology, you should not, just by seeing the STAT6, label it as SFT or solitary fibrous tumor. You have to take into account the clinical details, the cytology, the bland cytology, collagenized tissue in the background, staghorn type of blood vessels, and the overall morphology, which is having a patternless pattern of arrangement of cell, and also CD34 positivity in absence of other markers. So a negative marker is also a positive finding. So in case of soft tissue tumor workup, and STAT6 is positive. So it's a solitary fibrous tumor, so we have to diagnose whether it is a benign or malignant. So WHO has set some criteria to differentiate, like age, site, and necrosis, mitosis, etc., for the prognostic group stratification. So already told you that benign SFT has got well circumscribed patternless pattern, bland spindle cell in sheet, fascicles, collagenous stroma, staghorn blood vessels, thick walled blood vessels, hyalinized blood vessels. However, the malignant SFT would have, first of all, infiltrative margins, even on radiology or MRI, you could have noticed, you would notice that there are infiltration all around. The adjacent organ or nerve or blood vessels are involved. And on histopathology or cytology, you will see the hypercellularity, pleomorphism, necrosis, mitosis, more than 4 per 10 high power field. So not going to detail though already cytology, I have told that they have got bland cytology, cohesive spindle to epithelioid ovoid cells with little pleomorphism against collagenous background gives you a clue on cytology that it could be a SFT. However, you have to rule out the other spindle cell neoplasm of benign nature by working it up. So I'm skipping this slide. So the diagnostic challenges on cytology, FNA cytology is prone to sampling error. Everybody agrees with that. Since if a high-grade areas are present and we have not sampled it, then we could miss the high-grade area or de-differentiated areas. Non-specific cytological features, you can see these type of cytological features in benign nerve sheath tumor, and even a smooth muscle tumor can have the similar cytological appearance. So the benign mimickers are nerve sheath tumor, cellular fibrous histiocytoma, low-grade spindle cell malignancy, or spindle cell type of squamous cell carcinoma. So these are the diagnostic pitfalls, and we really find it difficult to rule out on FNA samples. However, we have to go to work up it in stepwise and to come to a conclusive diagnosis. Now, case 2. This is a 28-year-old male presented with slow-growing soft tissue mass on the lateral aspect of right hand for 6-month duration, painless mass, often on paresthesia, tingling, numbness, and tenderness present. X-ray right hand showed the soft tissue density on the right aspect of the hand, and you see the density do not have any calcification, no bony erosion is there. Only a very well-defined soft tissue mass we could appreciate on X-ray. So it is not going to give you much clue which type of tumor or lesion it could be. So we went for MRI hand, and we saw that in T1 weighted images, we saw that the tumor is well circumscribed and round fascicular, and it does not have any infiltration around. So it is a well circumscribed tumor, but it is not having any obvious encroachment upon the adjacent structure. What we saw on cytology, it was the smears were moderately cellular but loosely cohesive cluster. Just contrast to SFT, here the clusters were very loose, and we had the scattered atypical nuclei. Some of the cells had wreath-like multinucleated cells with wreath-like nuclei with minimal cytoplasm. Nuclear pleomorphism was obvious, necrosis was present, and on cytological impression, we gave a diagnosis of like pleomorphic sarcoma or atypical fibrous histiocytoma. So direct FNAC was performed because it was accessible to FNAC. It was hand swelling, and we had this type of cellular smear which on low magnification showed some very abnormal cell and very atypical cell having hyperchromatic pleomorphic nuclei. So we went for, it was a very hemorrhagic smear, so we could find some good clusters. And you see the cell cluster are having multinucleate type of cells, having some garland-like arrangement of nuclei, and that had this thing, see this thing is there. So we diagnosed this as a this case. See the multinucleate giant cell, and the resection showed this type of diffuse sheet of cells having pseudo-alveolar appearance, and the cells were obviously abnormal. And what I wanted to show you here, the some of the cells in the center had the pink cytoplasm. So they have eccentric nuclei, and they had pink cytoplasm in here. So they are giving some clue to us that they are having the rhabdomyoblastic differentiation. So again, the similar kind of cells with pink cytoplasm in the center, you could see rhabdomyoblastic differentiation is there. So resection performed, and we found that CD99 was positive, but it was membranous and patchy. Myogenin positive, desmin positive. So the diagnosis was like, what is the diagnosis? So alveolar rhabdomyosarcoma, hand. Now I will quickly go through the case number 3. 25-year male patient with mid-thigh swelling, and X-ray showed soft tissue shadow in the mid-thigh. No clear diagnosis could be made on X-ray. MRI scan showed single circumferential mass of 13 into 12 centimeter, and it had on T2 weighted images, they had hyper-intense heterogeneous shadow appearance, and on T2 weighted with contrast had heterogeneous density, which was hyper-intense, but the bone involvement was not there. The bone is spared. See, the femur is there and the bone involvement is not there, but the tumor was circumferential and involving all the compartments of the thigh. FNAC performed showed the very cellular clusters, and you see, if you could appreciate, there were mitosis in the round to oval cells were there, and the 3 to 4 mitosis were there in the cytology smear as well. So here we see that the cells are clinging to blood vessel. This spindle to oval cells clinging to blood vessels, and the cells are having these short spindle nuclei, and they are having clinging to blood vessel. So this was like having a short spindle cell neoplasm, which appears to be quite bland, and it does not show very much malignant appearance. Again, the similar thing. And some may have microcalcification in some areas. We had this thing. So FNA diagnosis was as like low-grade sarcoma or synovial sarcoma or low-grade MPNST or leiomyosarcoma. So the histopathology on core needle biopsy, we applied multiple markers of these. TLE1 was positive, and the resection had a very dense cellular type of sheets or diffuse sheet of spindly cells. And ISC workup, whatever highlighted in yellow, they were positive. EMA was positive, CK719 positive, S100 focal, CD99 patchy, BCL2 patchy, nuclear, TLE1 nuclear strong, and the newly discovered SS18 SSX antibody had very clear nuclear staining. So TLE1 and CD99, you see it is not as crisp as you see CD99 in the Ewing sarcoma. So it was positive. So histopathological diagnosis and the ISC, they suggested synovial sarcoma. And if you want to give a diagnosis, a final look, you should go for the FISH analysis, and the probe is for SS18 SSX. And you will see the fusion. There are fused genes are there for the SS18 and SSX. So with this, monoclonal antibody is a breakthrough development in the synovial sarcoma, because we were always confused whether a round cell type of synovial sarcoma could have been this Ewing sarcoma or Ewing family of tumor. So this antibody has brought a lot of good news, and we are now into this. So I'm not going into details of the differential diagnosis. Thank you very much for your patient listening.
Thank you, Dr. Nisha.
Any question we'll take up
later. So the gist is, these are all difficult areas, especially when we are dealing with the secondaries. It is relatively easy to diagnose, but when we are dealing with the primaries, then you need adequate experience and good knowledge background of histology. Then only you can reach a correct diagnosis, especially when you are using ancillary techniques with cytomorphology. Thank you so much. And now we can take few questions from the audience.
The second speaker, there was a case, metastatic prostatic carcinoma. Why did you keep a differential diagnosis of metastatic RCC? Because cytologically they are poles apart, and the cytology of RCC is fairly characteristic, even if the primary is not known.
Sir, so whenever tumor cells show minimal pleomorphism, as many of the renal carcinoma, they show minimal pleomorphism. And also they form SNI. In this case also the tumor cells are forming SNI. That's why we keep a diagnosis. The primary diagnosis was it could be a metastasis from prostate, but a remote possibility a metastasis from renal also may. So that's why I put a differential, not a definitive diagnosis of prostate. Yeah.
Sir, I wanted to add that we have seen some cases of hypernephroid type of adenocarcinoma of the prostate. So some of the cells do resemble the RCC cells. So there is also one variant of acinar type of prostatic carcinoma which look exactly the similar to the. Yes, sir. So we need a complete workup of the patients, whether the primary is present. Yes, 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 sir. Thank you. Yes, sir. Thank you.
Any more questions, please? I think if there is no question, we can move ahead with the next session. Thank you so much.
I now request our chairpersons to please give a memento to our first speaker, Dr. Vaishali Walke ma'am. I now request our chairpersons to please give memento to Dr. Chanika Kala ma'am. I now request our chairpersons to give memento to Dr. Nishat Afroz ma'am. Now I would like to request Professor Nuzhat Hussain ma'am to please felicitate our chairpersons. We now invite you for a short tea break at banquet hall. Thank you, sir. Thank you, ma'am. We now invite you for a short tea break at banquet hall ground floor. We will resume with our next session at 10:30 a.m. And I request everyone to please be back on time as we have back-to-back session. Thank you. 10:45. Okay, the timing is 10:45.
नहीं है इसकी
नहीं नहीं ज़रूरत है, मैडम ने कहा है।
आ रहा है। नहीं, ऊपर का चला गया।
तेज़ बोलने की ज़रूरत नहीं है। ठीक है, ठीक है, चेक चेक, ओके फाइन। We are just waiting for some audience to join, and then we'll soon be starting with our session. Welcome back, everyone. We will now begin with our next set of sessions. The World Health Organization and the International Agency of the Cancer Research, International Academy of Cytology, have come together to create a reporting system for cytopathology. For this discourse, Dr. Nusrat Hussain ma'am, professor at the Department of Pathology, RML Lucknow, will take us through the reporting system of the cytopathology. For this session, I request our chairpersons, Dr. Abhinav Arun Sonkar sir and Dr. Harish Chandra sir, to please join us on the stage. Dr. Abhinav Arun Sonkar sir is a professor and head at the Department of General Surgery, King George's Medical University. Sir has various awards to his credit. Sir has research interest including the hepatobiliary malignancies and head and neck cancers. Dr. Harish Chandra sir is a professor at the Department of Pathology and Lab Medicine, AIIMS Rishikesh. Sir is an alumni of KGMU and has been awarded with several fellowships, including the American Society of Hematopathology. I request our chairpersons to please invite the speaker, Dr. Nusrat Hussain ma'am, and introduce
a very good
her.
morning to all of you, and hope you have a normal sugar level so you can have a better take of what a madam is going to say. Introducing Professor Nusrat Hussain is like introducing Adit to the recent ISRO mission which has been sent to in the orbit. She needs no introduction rather. I have been her student and many people are her student. And you talk about her achievements, you will not be able to listen to the talk actually probably for the whole day. More than 350 publications, a good number of H-index, CYTOCON, ma'am. You have been a director of RML, she has been dean of RML, probably still she is doing, she's dean and she's doing very good work, magnificent work. And probably we should follow her in her academic pursuits also. It will be a good thing for us to listen. She has been a very good pathologist. Ma'am, most welcome. We are honored to have you here. And you were part of KGMU. Probably you are also still a part of KGMU.
Very much.
You are like Voldemort. Something is still sticking on this KGMU. You are part of this. Ma'am, I would request you to start to talk, please.
Thank you. Thanks. So thanks for your warm introduction. Both the chairpersons are my students, so thank you very much for being there, and a very warm welcome. I can see the cytology conference has been really very well organized and great representation here and wonderful speakers. We had a very good session this morning, and what I will present to you is the new WHO IARC and the IAC. They have come together, as the introduction was there, and they have come up they will come up through the process with new reporting systems for cytology. So reporting systems are not new to cytology, and we are already following various systems like started with the Bethesda for cervical cytology, you have the Bethesda for thyroid, you have the Paris system for urine. So you have a lot of systems, you have the Papanicolaou systems, and so you have a lot of systems in place. But then what this WHO does is that finally it takes over everybody and gives you a standard like they did for the tumors. And now they've moved on to handshake those blue books with these purple books, which are going to be the cytology books, okay? So what I present before you, I will acknowledge that a lot of this material has been taken from the US CAP presentations. There was a 2-hour workshop there just on the new WHO classifications. And because not a lot of this material is available even like online otherwise, so I will give you some which is coming directly from the US CAP. And the lung and the pancreaticobiliary books have been published, and these are now available online, and it is very easy to actually purchase them. I just did it like a couple of weeks back, and it's just 50 euros. You have to go online and you kind of pay, and you have access to all the cancer books as well as to the cytopathology books online for 1 year. So how are these systems different from what has already been given by the Bethesda, by the Paris, by the Papanicolaou system for pancreaticobiliary? How are these different? Initially, I had titled my talk, Old Wine in a New Bottle, but somehow I think Madhu thought that was not quite right, and she made it just this much. So it's not really old wine in a new bottle, because it is still, there's a mixture with the old wine with some other stuff out there. They've added more to it, made it more tasty, and then put it inside a new bottle. So what have they added there? They have actually recategorized the tumors into different slots. So the categorizations you had earlier, I will show you with the systems how they have changed. They have added, and thereby the ROMs have changed because the categories are different. Then they have also kind of linked the ancillary studies and the molecular to the system. So if you are addressing a particular entity, you will know what ancillary, what differentials, what molecular to do. And they have also described the techniques to be used at that particular site. So which technique, and they have evaluated those techniques in terms of sense spec, their applicability, and suppose that technique fails, what to do. So a lot of things have been addressed in these detailed cytopathology books, and finally they give you a management strategy as well. So that's what is different out there. These two books are currently available online. They are like published. These are the lung cytopathology and the pancreaticobiliary cytopathology. And because Deepali will be covering the lung, I eliminated the lung slides from my presentation, and I will show you some of the the pancreatic biliary cytology. So what are the advantages of the standard terminology? This is a regular advantage. We have been using this advantage earlier. It unifies the disease categories. It reduces inter-observer variability. It improves the inter-observer reproducibility. And it also aligns the patient management options and it improves patient care. So very generic things out there, but very applicable when you are using these systems. So what are these systems that we have been using so far? And it's not as if these systems did not have an advantage. They had a major advantage. And if you have to actually sum up, what did the Bethesda do for the thyroid? It actually improved the clinical confidence in the benign cytological diagnosis. And it reduced unnecessary surgery in almost 50% patients. Okay? So what did the Paris do? It focused the cytopathologists on what really matters, the high-grade urothelial cancers. And it reduced the meaningless atypical category. And similarly, the fluid cytology system, the international system for fluid cytology, it also linked each category and gave you a clear management as well as the use of ancillary techniques. So different systems used all this. What the WHO has done is put them all together in every system. So now just giving you an example of how the book looks like, your index page in the pancreatic biliary cytopathology. There's a foreword. Then there's an introduction to the WHO reporting system for the pancreatic biliary cytopathology. Then you have the cytopathology techniques, as I'm telling you, they will be detailed out there. So all the FNABs, the brush, everything is kind of listed. Even the rose is mentioned as to, when you should use it, how much it will improve if you are using rose, what will be the change out there. And then there's the diagnostic categories. Each of them is detailed. There are 10 chapters there. So every one of them, you have low risk, and you have the high risk, you have the suspicious, you have the malignant. So all these categories are kind of listed out there. And every one of these chapters will then describe in detail every individual one of them. So every one of these chapters will then have an introductory. So this is what it has, an introductory chapter, your techniques, sections on the rapid on-site evaluation, the best practice of the ancillary techniques, and then each of these chapters further has a introduction, definition, discussion, background, and a risk of malignancy, as well as management options that are present out there. And each of these chapters in turn will list to you the key diagnostic criteria. And what is also important is that you can link from your online book to the blue book. Okay? And then you can see the concomitant status of that tumor in the blue book when you are reporting. And especially if you are doing a histocytocorrelation, you have everything right there. And then also importantly, it gives you sample reports. So then it's going to kind of cause, like you have with the CAP protocols, these books can help in standardization across platforms on sample reports and how the cytopathology reports should be rendered. So this is what a standard report will look like. You have the demographic information of the patient. You have the type of specimen. For example, if this is lung, this is the type of specimen you will have to click from your hang down list. Then you have the clinical and imaging information. So also very importantly, as was also emphasized in the talk in the morning by Dr. Nishat, that the clinical correlation is really very important out there, and the radiology is very important. So now the report actually integrates it into your report. So you mention that part into your report as well. You do the category, whether this is a malignant or a suspicious or benign or whatever you're deciding. And then you give a diagnosis of a possible diagnosis in this case. And then you describe the ancillary techniques, if any, that you have used, and the molecular techniques, if you've used them. So this is what a standard cytopathology report will look like. Now, coming to the hepatobiliary system, let us start with a case. This is a 43-year-old male who was being followed up for a head and neck carcinoma. He was found to have a liver lesion on surveillance. The abdominal MRI showed a diffuse dilatation of the pancreatic duct up to 9 mm and side branches, and the liver lesion was consistent with a hemangioma. Okay, so multiple pathologies in this patient, that's the confusion. The EUS and the guided FNA was done, and the ultrasound identified a cyst which was connected with the main duct, and this cyst was multiseptated without a mass, and 0.5 ml of this fluid was aspirated from the cyst that was communicating with the duct. And this is like it is a very low cytology. You can appreciate there's a background of mucin, and then you can appreciate very like minimal cells out there, but these are clusters. So would you vote them as benign or malignant? So this is kind of a high new site ratio. You're finding some irregularity out there. There's some indenting of the nucleus also by the mucin that's present there. And you can appreciate here again that the new site ratio is definitely increased. So even though you have very few cells, you have a mucinous background, you can suggest that these are probably some high-grade cells. And here you can even appreciate a cell inside, a cell, an emperipolysis of the cell which has occurred inside this. So this is definitely going to a cell engulfment which is happening here. And so this can be diagnosed as an introductal papillary mucinous neoplasm with high-grade dysplasia. So that's a category which we will come to, just an introduction to the category. And the pancreatic biliary neoplasms in the cytology, the new system, have been categorized into low-grade and high-grade lesions. So if you actually look, and this was the dissection specimen of this patient, and you can appreciate that you can see IPMN that is present in this case. So if you look at the pancreaticobiliary system reporting, you have been following so far the Papanicolaou cytopathology reporting system for the pancreaticobiliary, and this system was given way back in 2014, and this system actually includes a non-diagnostic category, a negative category, an atypical, a neoplastic, and in the neoplastic it's benign and others. So if you were categorizing this case that I showed you by the Papanicolaou system, you will be putting it in the others out here. So how does the location of this case change when you are using the new system? The impact of this system was also amazing. Okay, so it's not as if the previous systems didn't do their jobs. They also did their jobs. And this improved the classification of the atypical and the suspicious malignancies better. There was a clear communication of the results here, and it also showed the ROM with the categories that were present there. And for those residents in the audience, if you are like questioning why high grade there and why low grade here, so this is how you will look at, when you will call it low grade, when you will call it high grade, when you're looking at the epithelial cells that are aspirated from the pancreaticobiliary system. So if these are gastric cells, the low-grade cells are actually, their nuclei are smaller than the gastric nuclei, okay? They are smaller, and when they become kind of more, what helps me is to some extent is there is more uniformity here, but if you kind of zoom in, you will find some irregularity of nuclei that will be present here. But overall, this kind of a plumping of the nuclei, the irregularity of the chromatin, and this kind of a high new site ratio is something that is very classical of high grade rather than low grade lesions. So this is your mucinous cells, how you will categorize them. And again, you can appreciate here, this is a duodenal enterocyte, and this is low grade, and this is high grade, okay? So the cell size is smaller than an enterocyte, there's an increased new site ratio, there's an abnormal chromatin pattern, and if there is background necrosis, you will push it into the high grade lesion. So this is how the digestive system tumors, the 5th edition in the blue book is. And if you see the categorization here, you will tell me that these lesions, these IPMNs, are actually in the benign epithelial tumors and the precursors, okay? But when you go in this blue book to where they have introduced the ICD coding, and in the ICD coding, you will realize that they have categorized these IPMNs further into low grade and high grade, and similarly, they have categorized the mucinous neoplasms into high grade and low grade, the mucinous cystic neoplasms. So there is an categorization, even though in the main classification, they are labeled as benign. Okay, so that means this categorization, which was reflected in the ICDO, is now reflected in the WHO classification. So this is the WHO reporting system for pancreatic biliary cytology, and you can appreciate that there is an inadequate category. And please note here that what this WHO has done is that it's put the non-neoplastic and the benign lesions together. That's one major difference. So for all the systems of classification, the benign and the non-neoplastic have been put together, probably because the focus is on cancer. Okay? And then you have, in the pancreatic biliary, you have an atypical. So the classic, would be inadequate, would be benign inflammatory together, would be the atypical, would be the suspicious and the malignant. These 5 categories are retained in the WHO all throughout. Now, depending upon which site it is, they have added something more. For example, in soft tissues, they've added those stump lesions, like the borderline lesions. Here, they have categorized these IPMNs or the mucinous neoplasms separately into low grade and high grade. Then you have suspicious, and the malignant has your other classically malignant categories like the ductal carcinomas, the acinar carcinoma, the NETs, and other lesions. So apologies for this, I will read it out to you. But this was like what the WHO is propagating. If you go through the book and you try to make a chart of it, what it is propagating is to correlate clinical radiology, cytology, and finally even biochemistry, molecular and ancillary together to come to a conclusion. So suppose you're looking at a pancreatic mass, you look at the age, gender, you look at the history of previous malignancy, you look at history of familial syndromes, etc. You look for serum tumor markers. Okay? Then you do a radiology, you categorize them whether you have a cystic lesion, a solid cystic lesion, or just a solid lesion. Now, if it is a cystic lesion, it is connected to the ductal system and the main pancreatic duct is dilated like we had in our case. This would be, and mucin is present, then you would kind of categorize, and cytomorphology is like kind of positive, you're getting cells, but it's mucinous, then if it is yes, then it's IPMN. If it is no, you can see it's not necessary you get mucin always in a mucinous neoplasm. So you then do a CEA and amylase, and if your CEA is coming positive, and especially if you're able to get the fluid and do your CEA and amylase in the fluid, then you can kind of go forth and then call it as a again an IPMN if these are positive, and if it's negative, it's a non-mucinous cyst. So similar kind of approach you would use in all directions. You have a solid cystic, you do a cytomorphology, you add ancillary techniques. It can be neoplastic, it can be non-neoplastic. And I cannot go into the details, it's a whole lot of books out there. But what I'm trying to point out is that there is an approach, you will have to integrate the approach, you will have to integrate the clinical, and then finally come to a report which is going to integrate everything. It's not just, a report of cytology. So that is what the WHO is advocating. It will also give you the indications for ancillary testing. So suppose you are thinking suspicious, it will tell you to do an ancillary testing. Suppose you are in doubt between whether this is a benign versus a malignant, it will advocate an ancillary testing. If you are thinking hemopoietic, it will advocate an ancillary testing. So similarly, the ancillary testings for specific samples are also enumerated, like for bile duct brushings, or etc. The biochemical analyses, for example, are built up into the pancreatic biliary system, where it is telling you to do a CEA, an amylase, and maybe some newer markers like VEGF, glucose, or MABDAS. And then, so these are the references basically for doing these markers out there. And then they've also given you a panel of molecular testing that will be required at that site. So life becomes easy. There's a standardized panel out there. As and when they upgrade it, you upgrade your panel, wherein you are going to do your molecular testing for these neoplasms. And then, of course, they've mentioned a ROM, or a risk of malignancy, for every one of those categories. And they have mentioned clearly the clinical management options when you are mentioning a particular. For example, if you are giving a PAN-N which is high, there is a 60 to 95% risk of malignancy, and what you are advising is, by giving this diagnosis, it is advised to the surgeon that a surgical resection in surgically fit patients or conservative management is an option that they have. So this is a communication which will have to be kind of at least this table will have to be clearly communicated to the clinicians who are referring the cases, that when I'm saying this is what I mean, right? So this kind of a communication, these systems are going to establish better. And I'm not getting into those details, but like this is the insufficient category, in which again at the end of the insufficient is going to advise you what you want to do. So it will advise you biochemical testing can be done. It can advise you that you can repeat your FNA and brushings. Similarly, for the benign and so forth, when you read the chapters individually, there will be a description of what the morphology is, there will be a differential diagnosis, there will be what to do subsequently, what is the ROM of this category, and what is the management of these lesions. And this I've already emphasized to you before, that the benign or the negative ones have included both the inflammatory as well as the benign lesions in this category too. And then the atypical, again, the ROM is fairly high. So it advises that either you do ancillary techniques, fish, etc., if you have adequate material, or you kind of go for a biopsy. Especially for pancreatic biliary samples, it is advised that if you're going all the way in and doing a cytology, it's a good idea to get a core biopsy as well for correlation. So that's with the grading. We've already talked about this. This is the size of and comparing with the enterocytes, and then you have the low grade and the high grade lesions there. And then these are the lesions which are coming into the pan low, and then so this is a category of lesions which are coming into pan high and suspicious and so forth. So these are the groups which you will get into, and just a small peep into the soft tissue tumor. Which is not yet published, but Ian Shibb from the Harvard Medical School, he had presented this there. I have permission from him to show you these slides here. So these are some of what the WHO classification of soft tissue tumors is going to look like for cytopathology. And this is what the book is going to look like. And they have again used a similar pattern. It's like going to be an introduction, the role of cytopathology, basically the techniques. And then the pattern in all the books is going to be similar. So it's going to be categorizing every one of those lesions separately, looking at the ROMs and so forth. The categories that are going to be there in the soft tissue are insufficient, benign, atypical. And as I told you, these 5 categories are common to all, and this 4th one, this is the soft tissue neoplasm of uncertain potential is what has been added to the soft tissue tumors. Every chapter has a definition, clinical features, histopathology, key diagnostic cytopathology features, discussion and differential diagnosis, ancillary testing and references. And for example, an extraskeletal myxoid chondrosarcoma, these would be the features that would be given in detail. You know what you're going to see there, so very nice cytological descriptions of every entity that will be given there. And then, this is how the lesions are listed in the soft tissue blue book. And the benign category again has the non-neoplastic and the benign lesions. In the non-neoplastic, you have the acute inflammation, granulomatous fat necrosis, amyloid tumors, ischemic fasciitis, IgG4 related disease. So then again, in each of them, they've described an approach as to how you can diagnose IgG4 in cytology and so forth. So what is the ratios you'll have to have for the IgG4 cells, like you have standard for histopathology. So those kind of details have been given there. And the benign lesions again are categorized into adipocytic, myxoid, spindle cell, chondro-osseous and epithelioid. As you can see, they've used basically the morphology of the cell to categorize the lesions which are under that, and each of them has an expanded list below. So it's, for example, the myxoid tumors which are benign can be either ganglion cysts or intramuscular myxomas, juxta-articular myxomas. The spindle cell lesions, of course, you have a whole list that are there for the benign ones. The chondro-osseous will have the myositis ossificans and chondroma. Of course, it's easier said than done when you actually have the slide. It's very hard to say whether you're looking at a benign or a malignant lesion. And then there will be ancillary techniques, there will be molecular techniques which can be applied to help you out. And then you have the epithelioid cell tumors. So this will be easier for residents to actually have, when we ask you which are the epithelioid sarcomas or which are the epithelioid benign tumors, you have the hang down list out there. You need to kind of go and make sure that you are, familiar with that list. And then you have the uncertain potential neoplasms. And this can be uncertain differentiation. I think the first category is what most of us are going to use more. The second category, if you are able to work up the case, you might be able to further categorize into which subtype that you are looking at out there. And then in the malignant neoplasms, again, these categories of adipocytic, myxoid, spindle cell, epithelioid, chondro-osseous, pleomorphic, round cell, and metastatic, right? Residents, this is what you learn up when you're looking at the sarcomas. And then you'll have a hang-down list under each one of those categories. And each hang-down list of the categories will be described in detail of their cytomorphology, and you can go ahead and even look at the ancillary techniques and the molecular that will be required in all these cases, okay? So those were the groups of this is the chondro-osseous lesions, and you can appreciate here that you're finding the neoplastic giant cells as well as the osteoblasts, etc. So you can think of an extraskeletal osteosarcoma there. And then you have the pleomorphic sarcomas and the subcategories down there. You can have the round cell lesions, and these are all the categories down there. And then they have they have shown samples of how the reports will look like. And the reports will again have the site, the adequacy, the interpretation, and the diagnosis out there. And then you can go forth and do some more ancillary techniques. For example, if this is a soft tissue neoplasm of uncertain potential, you are thinking it's a GIST, and if it's got a KIT positivity and a dog positivity, you can give a diagnosis of GIST, and you can of course do the other markers which are going to be negative. A retroperitoneal mass, FNAB, and you can see here again, very uniform looking cells, not looking very neoplastic, not too many mitosis out there. And again, another probably an uncertain potential neoplasm. There will of course be clinical correlations. You will look at the size of the mass, it's infiltrating, where exactly it is present, you know, a lot of other correlations that will be required. And if you note here, you've done a lot of markers, but all of them are negative, so you continue to call it as a monomorphic spindle cell neoplasm. And here, you're looking probably at a malignant lesion, and then you give inadequacy, and you're suggesting a myxofibrosarcoma, and you might want to go ahead and do your other ancillary studies in order to get to a final diagnosis. So this is another very aspirate here, and here what you're getting here is a focal INSM positivity. And this is a classical sort of a expression of INSM1 that you get in an extraskeletal myxoid chondrosarcoma. So if you get this kind of an INSM1 positivity, then you have to suspect that you're probably looking at an extraskeletal myxoid chondrosarcoma. So thank you very much. Tried to cover a lot in a short period, but the basic point was to try to introduce the WHO systems, and I think that's what we are in for in the future, and also to tell you that they are easily available.
Thank you very much, ma'am, for your presentation. Although this is a very complicated topic, and especially for postgraduates who are just finishing their career or just starting their this MD pathology courses, it is difficult, but once you started with this incorporation with IAC, IARC, and WHO, then you will definitely get it. Thank you very much, ma'am. Thank you very much.
And thank you very much, ma'am, for also finishing before time.
Thank you. Thanks. I know you have surgeries waiting, so I had to do that.
As a surgeon, I also got to know that in non-diagnostic category, the risk of malignancy is 25%. I was wondering, what should we do, like in salivary gland neoplasm, like in thyroid also. But you said we can right away, if the ROM is more than right away, then we can wait and watch, and we can go for surgery. Only one question, ma'am. Is there any chances of going for repeat cytopathology after 3 to 6 weeks? But thyroid describes, you know, Milan said, they say that you can always go for repeat cytopathology after 4 weeks and that.
Yeah, absolutely. I mean, it would be advised, and especially if you've had inadequate and your size of the lesion is small, you should go for a guided aspirate in that case to make sure that you're getting.
Should there be any time difference between the two? I mean, is there any sanctity of this? Is it important?
The reason for giving a gap probably is because there might be a hemorrhage in the lesion because of the previous FNA, especially if it has been very aggressive. But if that's not true, then you can go forth maybe earlier also.
Thank you, ma'am. Thank you very much. Thank you.
Any questions from audience? We can take a couple of questions.
Yeah, we still have 2.5 minutes.
Biliary system classification. Now, only one thing to add. Simple FNAC is not recommended for pancreaticobiliary lesions. And
yes,
endoscopic ultrasound guided FNAC is the only, in fact, it is the only modalities that have been suggested.
I totally agree with you. In fact, the technique description in the WHO classification, actually there's a hang down list and there are about 5 techniques that have been described. And one of them is EUS, and then you have the percutaneous guided aspirates as well. And then you have the CT guided aspirates, you have the core needle biopsy and the aspirates along with it. So there are multiple techniques that can be used in the hepatobiliary system. And I definitely agree with you that, just blind aspiration is not an option there. So in fact, that's what I was saying, that there is so much detail out there that, if you go to the bile duct brushings, for example, it will tell you exactly what the indication is. If you've got a lesion like that, then you'll actually go for a bile duct brushing only if you've got a particular kind of a tumor. And if you're suspecting this, so they've actually given very specific indications for the techniques as well. I thought that was interesting. And they've discussed in detail the inadequacy and the sense and spec of those techniques. So, you can actually kind of understand more as to when you're failing and how you can improve it. And if the technique has been inadequate, they also advise subsequently that what you have to do the second time. And a lot of those things they have advised that you should go in for a core needle biopsy along with the brushings or aspirates, whatever you are doing. They've also kind of detailed the kind of needles that are used out there, like you have the fork needle and the long one. So they have discussed the advantage or disadvantage of using the fork needle versus the single needle aspirate. So I think it's very interesting. If you read in detail, somebody who's very dedicated to cytopathology, I think it's really a must now to read those classifications.
It is easy to apply Papanicula Society's classification, but if you apply WHO system, you see it is very easy to say, but mucinous neoplasm, atypical mucinous neoplasm, and interductal mucinous neoplastic. So this category is almost impossible to diagnose fine needle aspiration cytology. So it's a large area of the classification system
is a gray zone.
It's not our domain.
It's a gray zone, I agree. And that's why they've talked about the integration. So probably then you're looking at, those areas where you have a tumor board and you have kind of everybody on board deciding as to what it is, and the cytopathologist goes with his own findings. And you kind of correlate and say that this is a well-demarcated cystic lesion, septate, communicating with the bile duct. So likely an IPMN, and then okay, fine, you've also got your cells and the mucin. So there you are. And then maybe you can go for a KRAS, a GNAS or something to prove the point that you are actually looking at a neoplastic cell.
One last question, ma'am. I just wanted to know that what is your experience at your place? How many patients of periambiliary cancer are able to make diagnosis pre-surgery?
Actually, we don't get too many of the guided aspirates from the pancreaticobiliary system, but we are doing more of histology. We get a lot of histology cases of the pancreaticobiliary system. So actually there's also, that's the debate, is whether you should go for the whole process or just do a biopsy. That's the point. But cytology will continue to do it. Thank you.
I think we are overshooting the time. Thank you, ma'am.
I now request our chairpersons to please felicitate ma'am. I request Professor Atul Gupta sir to please felicitate our chairpersons. Sir, please present a memento to Dr. Abhinav Arun Sonkar sir. Sir, please present a memento to Dr. Harish Chandra sir. Thank you.
Our next talk would be taken by Dr. Nalini Gupta ma'am, Professor at the Department of Pathology, Cytology and Gynecological Pathology, PGIMR, Chandigarh. Cytological analysis of serous effusion fluid is indeed a field of diagnostic pitfalls and potential misdiagnosis. And in today's talk, ma'am will lead us through the many facets of effusion cytology. So may I please request our chairpersons for this session, Professor MLB Bhatt sir and Professor Ram Naval Rao sir, to kindly join us on the dais. Dr. MLB Bhatt sir is the professor and head of Department of Radiotherapy, King George Medical University, and the former Vice Chancellor of King George Medical University, Lucknow. Sir has worked extensively in the field of lymphoma, urological cancer, gynecological cancer, along with epidemiology and preventive oncology. Dr. Ram Naval Rao sir is a professor at the Department of Pathology at SGPGIMS, Lucknow. Sir is the current secretary of Indian Academy of Cytologists, UP chapter. He has keen interest in the areas of cytopathology and liquid-based cytology. Sir has multiple publications and book chapters to his credits. May I now request our chairpersons to kindly introduce our next speaker to us.
Good afternoon to all of you. It's our distinct pleasure and honor on myself and my co-chairperson to invite Professor Nalini Gupta, who's going to talk about effusion cytology. We know that the cytology and particularly effusion cytology has taken a center stage in the diagnosis of not only many neoplastic disorders, but many benign conditions, degenerative conditions, traumatic conditions. And many of the cancers, we can really establish not only the histopathological nature of the disease, but also we can make the molecular aberrations associated with the disease and many more things currently with the help of cytology. And we are going to hear a lot about it from Dr. Nalini Gupta. You are invited, madam. Thank you very much.
Thank you, sir. Thanks to the organizers, especially Dr. Madhu, for inviting me here. And today I'll be talking on serous effusion cytopathology, reporting systems and liquid-based cytology. So to start with the topic, I'll say liquid-based cytology is just the reflection of conventional cytology. And in gynae pathology, in gynae cytology, we just do the liquid-based cytology, but in effusion cytology or in non-gynae, we retain one slide of conventional cytology as well. So it helps us to decide what is there in conventional cytology, where we do a lot of MGG stains, and liquid-based cytology actually concentrates the cells. So I'll be showing you examples. To start with, may I know how many PG students are there in the hall? Just raise your hands. Okay, so I know where to expect the answers. Okay. So in our scenario, at least in PGI, we stress that all effusion samples except CSF and synovial fluid should be collected in our anticoagulant. We do not accept fresh samples because many a times these samples are clotted and ultimately the malignant cells are present in the clot, and you actually are dealing with give a report which is false negative. So if you are getting fresh samples, these should be processed within 2 hours. But if there is delay expected, then they should be refrigerated. They can be refrigerated up to 48 hours. We use anticoagulant, which is ammonium oxalate, but there can be different anticoagulants used. And that's our sample acquisition form, which will have patient details, especially the date and time of the collection, because it matters after how much time you've received the sample after the collection. When we receive the sample in the lab, it looks like something like this. So the technician should actually write down the volume of the sample, what is the color, whether it is transudative, hemorrhagic, whether it is chylous looking whitish milky fluid, or is it chocolate brown, because it gives you an important information when you are interpreting the slides. And similarly, the consistency, whether it is honey-like, thick, gelatinous. If they think it is mucinous, they should mention that on the form. And conventional smears usually are prepared by centrifuging the sample, and that's the centrifuge, and we use the routine cytodiagnosis by one air-dried MGG stained slide, one alcohol-fixed PAP stained slide, and this is SurePath. We have SurePath system in our department, so we use SurePath slide. So we've actually done away with this PAP stained slide, and we just get 2 slides for effusion cytology. One is conventional MTG, and the other one would be Papniclaw stained SurePath liquid-based cytology. Rest of the sample is used to prepare cell blocks, and in effusions the cell blocks can be very, very cellular and can be very, very informative, because this is the era of ICC and ancillary techniques. If you're just doing cytopathology on just the cytomorphology, you will be dealing with a lot of gray zone areas. So actually cell block is used for ICC. So I'll show you the examples how this IHC actually helps us to define where the primary is, and we use MGG stained smears for DNA extraction, and most of the times mutation testing is done for lung cancer, but we'll show you the examples. So this is for PG students, how to deal with hemorrhagic samples. So before processing, you can use glacial acetic acid. This is the most commonly used technique, that you use 1 to 2% glacial acetic acid to lyse RBCs. We can make fishtail smears or buffy coat smears with thick and thin smears, so that you know the morphology as well as the concentration. And after the slide preparation also, you can deal with these hemorrhagic effusions by saline rehydration and saponin. If you ask me one advantage of liquid-based cytology, it would be concentrated sample. In a paucicellular sample where you have very few malignant cells in a conventional slide, liquid-based cytology shows a lot of cells, and that is one example. And second example would be that you are seeing a lot of lysis of RBC. So if this is hemorrhagic or paucicellular sample, liquid-based cytology works better than conventional cytology. And on liquid-based cytology slides, you can do all special stains, immunostains. So that is an extra advantage, that you can prepare a number of slides with liquid-based cytology. Cell block, we these days are using this sodium alginate method. We have experience with agar-based cell block method, and also the thrombin thromboplastin method. Why we have shifted to sodium alginate is because of the cost. It is quite cheap, and nowadays for all effusion samples, for FNA samples, we are making cell blocks day in, day night. I would say almost 50 cell blocks are prepared every day from all cytology samples in our department. This is just a table to show how to differentiate a transudate and exudate, and we've been reading this maybe from since MBBS times. There are some newer indicators of differentiating between transudate versus exudate. Again, it is the ratio of fluid to serum protein. If it is more than 0.5, it is more like exudative. LDH more than 0.6, and cholesterol also, and SAG. If it is SAG is less, it is more like exudate. As a cytopathologist, I'm more interested in reporting effusion cytology. And if we are talking of reporting, as Dr. Nusrat Hussain highlighted, there should be some essential components of the report. And in the report, at least in effusion cytology, we must mention the volume appearance, the specimen cellularity, whether it is low, moderate, or high. The description, we like to write the cells are round, nucleus is this and that, and followed by the background, whether it is clear, hemorrhagic, or proteinaceous. Your interpretation, ISC category, any IHC or ancillary technique done, and advice for the patient if like most of the lung effusion, like pleural effusions where we suspect lung cancer, our advice would be EGFR mutations and kindly pay for EGFR mutations, because we do not do it on the first thing, so patient has to pay. So that's the international system for reporting of effusion cytology. It starts with non-diagnostic, negative, atypia, suspicious, and malignancy. All these 5 categories are actually the standard of all cytology reports. And ROMs are given, and we can see that ROM for atypia is around 66%. So atypia means when you are thinking more towards malignancy and not reactive mesothelial cells. And on similar basis, we have Indian Academy Cytology guidelines. And if you see the categories in Indian Academies of Cytology, they are almost similar: unsatisfactory, benign, atypical cells, suspicious, and malignant. And again, the recommendations are there. If it is unsatisfactory, we need to repeat, and if it is benign, correlate clinically. And if it is malignant, we need to further find out where is the primary. And in our department, we did that study, and we kind of estimated the ROMs also for these 5 categories. So going to these 5 categories one by one, what is non-diagnostic in a fluid in maybe pleural effusion or ascites? If there is a lot of anticoagulant, many times on our form it's written anticoagulant, ammonium oxalate 9:1. So 9 should be fluid and 1 should be ammonium oxalate, but sometimes it's opposite, and you get a lot of anticoagulant crystals in the sample. Or if your sample is very paucicellular, you cannot see even the mesothelial cells, it can be non-diagnostic. Negative means just the reactive mesothelial cells, inflammation, or sometimes lymphocyte-rich effusions of tubercular effusions, or some specific infections like microfilaria, fungus, or tuberculosis or hydatid. Mesothelial cells, they say that they are like they are the cells which are like they can appear any they can have different appearances. So they can be discrete, clusters, knobby. They have this two-toned cytoplasm which actually helps, and this peripheral skirting because of long microvilli. So let's look at the pictures. So all these are mesothelial cells, and these pictures are from the famous book D. May. And you can see this peripheral skirting. This is because of long microvilli. These are cytoplasmic blebs of mesothelial cells. Sometimes you can see these vacuoles in mesothelial cells. So I also tried clicking photographs of different looks of mesothelial cells, and these are like there can be prominent nucleolus, there can be eccentrically placed nucleus, some peripheral skirting, a vacuole forming a signet ring cell, some microvilli which are seen on one pole of the mesothelial cell, cannibalism, windows, and again cell-in-cell formation. And this is again a medusa head-like mesothelial cell showing a flower pot-like appearance. So how to differentiate mesothelial cells and macrophages? Many times when you are reporting, your JR will ask, ma'am, is it a macrophage or a mesothelial cell? At times it becomes very difficult, but once you know it's a benign cell, you don't have to worry. The mesothelial cells will have windows, macrophages will not have windows, and macrophages typically show kidney bean shaped nucleus as compared to mesothelial cells which would have more eccentrically placed round nuclei. In addition to mesothelial cells, we can have histiocytes, lymphocytes, neutrophils, a lot of eosinophils or plasma cells, LE cells, liver cells if it is ascites, or some pigment like hemosiderin, melanin, or bile pigment, and Charcot-Leyden crystals, or sometimes Crushman spirals as well. So I'll show you some examples which are negative for malignancy. There is a lot of acute inflammation here, which is kind of necrotizing. If I see this kind of smear, I'll get an AFB done on this smear, because exudative effusion in tuberculosis can look like this, and any pyogenic effusion, bacterial peritonitis can look like this, or biliary peritonitis can look like this. Lymphocyte-rich effusion, this is a normal thing which we see maybe out of all smears reported in one day, you will see one or two these lymphocyte-rich effusions. The differential would be tuberculosis versus low-grade lymphoma, especially in a male or female who is older age, where you expect a small-sized lymphoma. The most common causes are tuberculosis, chronic effusions, viral infections, or lymphomas. And rheumatoid arthritis, we know you will not see any mesothelial cells. These effusion samples will have absence of mesothelial cells with these multinucleated histiocytes and elongated to oval macrophages with necrotic debris. So what are these? Anybody? There is something eosinophilic material engulfed by histiocytes, polymorphs. So I've marked these cells. What are these? Anybody? LE cells. So lupus effusions, you can have these LE cells which will have this homogeneous nucleus of degenerated material which is engulfed by leukocytes or macrophages. Eosinophilic rich effusion, we usually say that the criteria is more than 10% eosinophils in an effusion sample, and the most common cause of eosinophilic effusion is repeated tap or pneumothorax, but you can have other causes as well. So this was one example I wanted to share. This was a young female, and this was ascitic fluid, and all we could see was hemosiderin-laden macrophages. And this is MGD, this is Pearl stain, and this is liquid-based cytology. You can see these clusters of cells, and there are hemosiderin-laden macrophages. So what's your diagnosis? We are talking of something which is negative for malignancy. And she is young female with ascites, and there are just hemosiderin-laden macrophages. If you concentrate on these clusters, they have the top hat appearance, that there is center which is dense, surrounded by cells. So these are actually endometrial cells, and we suggested possibility of endometriosis here. And in the diaphragm, there were these small nodules present, and the biopsy was done from these nodules, and it was actually endometriosis. This is an example of eosinophil-rich effusion. These are microfilaria, and this is hydrated in an effusion sample. Atypical cells is a category where you have to actually repeat cytology, maybe correlate clinically. There are some atypical cells you don't know whether they are just reactive mesothelial cells or they are true malignant cells. So that's a category, I would say, where when you are doubtful, you are not sure whether it is malignant or benign, you will put it as atypical. But mind it, this category should not be more than 10% of all effusion samples reported. Suspicious would be when quantitatively or qualitatively there are cells which are falling short of frank malignancy. Again, it depends on your number of cells and the type of atypia you are seeing and the confidence and the experience. Many a times an experienced person will say it is category 5, but a newer, maybe a assistant professor will think of suspicious or something. So this actually is again a category where ancillary techniques, ICC is recommended to go for a proper diagnosis. When we have malignant cytology, the main thing is to decide whether it is carcinoma or non-carcinoma. In carcinoma, we know most common is adenocarcinoma. Once you know it is an adenocarcinoma, you need to find out the primary, whether it is lung, breast, ovary, or anything else. If it is non-carcinoma, we'll go to this area in a couple of slides. So these are the common malignancies, and we know that when it is a male patient with pleural effusion, you'll first think of lung followed by GIT, and in females it is breast, lung, and in ascites the first common malignancy you think of is ovary. And that's the table showing differences between mesothelial cells and malignant cells, and windows can be seen even in malignant cells. So it's not a perfect thing that if you have seen windows, they cannot. We've seen windows in a lot of lung cancers, and I'll show you the examples. So in IHC, we always prefer 2 epithelial markers and 2 mesothelial markers. Mesothelial markers, the best ones which are commonly used are calretinine, WT1 and D240. And sometimes CK720 can help in effusion samples. These are all, this is a table which shows that for lung you need to do TTF1, for ovary Paxate, for breast GATA3, and for colorectal it is CDX2 and SADB2. So these are the commonly used markers to know the site of primary. So this is a 67 male, and you can see the conventional smears and liquid-based cytology showing adenocarcinoma. We did CK7 was positive, TTF1 was positive. So it was an adenocarcinoma coming from lung, and you could do the Sanger sequencing to demonstrate EGFR mutations in this particular case. These days we are doing real-time PCR. So real-time PCR in an effusion sample showing these 2 EGFR mutations. So lung, at least in lung carcinomas, in effusion sample, the cells are so many in your cell block that you can do everything, including the NGS and real-time PCR for EGFR mutations, ALK, this is ALK, and that's ROS1 and PDL1. So everything for targeted therapy for lung cancer can be done on effusion samples, and we've seen that as compared to FNA also, sometimes the effusion samples are much more cellular, and we actually published our data in Diagnostic Cytopathology way back in 2017. This is another pleural fluid from a female, and the cell block is showing nice GATA3 positivity, ER and HER2 positivity. So this was a luminal type B type of breast carcinoma with effusion positive. And we can see this is a separate case, 56 female, and here we have this kind of vertebral bodies or cells in Indian file pattern, and this is a lobular carcinoma of breast. This is another patient. I've put in only the LVC slides, and maybe we have a higher par picture, and we can see these cells which are showing very high NC ratio, irregular nuclear membranes. They're not very clear signet ring cells, but this is the look signet ring cell carcinoma can have. Majority are dispersed population of cells, and this was a primary from stomach. This is another interesting case where we had this papilloid fragments in pleural fluid, and patient had PTC, papillary carcinoma thyroid, and this was actually metastasizing to pleural effusion. This was a small cell carcinoma. So in addition to these MGG slides, we can see these vertebral columns or Indian file-like pattern, lot of cannibalism and cells which are small in size, and they have high NC ratio. So these are all pictures in LBC, and you can see this kind of small cells forming molding. So nuclear molding is very, very evident, and once you've seen this, you just need to do one synaptophysin and give a diagnosis of small cell carcinoma. I think if you see this, you can report it off as small cell carcinoma metastatic if the patient is a smoker and an older age patient clinically fitting with small cell carcinoma. This was another case where actually P63 was positive. So this was a squamous cell carcinoma lung with lung primary. But if you are just doing P40, P40 or P63, it doesn't tell you it is lung. It is the clinical information which will tell you that there is a primary in the lung. You can just call it squamous cell carcinoma metastatic in pleural effusion. So in ascites also, I think the morphology is almost similar, but there are some differences. So let's see what are the differences. This is 56 female ascites, and there are these clusters which are more papilloid, and they're better seen on LBC, and see the concentration. These are the same power slides, like I've clicked them both in 20x, and you can see both are showing papillary excrescences, but here you have more papillary formations. In addition, if you are able to demonstrate some bodies, you can actually report it as serous carcinoma. directly. What we do in all our ascitic fluids which are positive and with ovarian primary, suspected ovarian primary, we do 4 markers, Paxate, WT1, P53 and P16, and patient will be reported as, the sample will be reported as metastatic carcinoma serous, high grade, and patient will go for neoadjuvant chemotherapy before the surgery. This is just an example where ascites was NMCS, that is no malignant cells in conventional smear, but on liquid-based cytology you could see some cells, and we've seen in our audit that there are 10 to 15% cases which are actually picked up on LBC better because of cellular concentration. Sometimes ascites is full of cells, but it's a borderline tumor. We know these excrescences are on the surface of the ovary, and that can lead to a lot of shedding of cells. And here, instead of calling it metastatic adenocarcinoma, it's better to report it as of positive for neoplasm, because this is not malignant, this is SBT. When it comes to mucinous tumors, or especially pseudomyxoma peritoni, the WHO says the acceptable terminology is mucinous carcinoma grade 1, grade 2 and grade 3. So the terminology where we used to use DPAM, disseminated peritoneal adenomycinosis, is now reported as mucinous carcinoma peritoni grade 1, and mucinous carcinomas which we used to call just peritoneal mucinous carcinomas, you need to divide them into grade 2 and 3. When you have a lot of signet ring cells and sheets of tumor cells, you will call it grade 3. If you have some mucin and some cells which are malignant looking, you will call it grade 2. If you have just mucin, hypocellular just mucinous deposits, you will call it as grade 1. So this would go as grade 1. This is grade 1, acellular mucin only, and this is like some cells are there, so it will be grade 1. Grade 1. This was a audit where we did effusion cytology of metastatic carcinosarcomas. Dr. Day is the corresponding author in this particular paper, and we've shown that majority of these effusion samples will show epithelial cells being shed in the effusion cytology, and you will not see too many cells representing the sarcomatous component. In ascites, this is another case where it is 14-year female, and in addition to these mesothelial cells, the lymphocytes, you have these cells which have large nucleus, NC ratio is high, and they have vacuolated cytoplasm. So this was a case of dysgerminoma, and again we have shown these germ cell tumors in effusion cytology. This was an example of immature teratoma, a yolk sac tumor with a lot of cytoplasmic vacuolation, and follow-up histopathology, and this is dysgerminoma in effusion sample, especially the ascitic fluid. So all these type of tumors can be seen in ascites. This was another case of teratoma where squamous cell carcinoma was arising in teratoma, and you could see squamous cells in effusion cytology. This was ascites with signet ring cell carcinoma coming from rectum, and this was ascites with urothelial carcinoma. So a lot of these cases are actually diagnosed with when you do audit, and I would say if you want to learn cytology, keep doing audits, because you actually know where you have gone wrong in your reporting. So for hematolymphoid malignancies, for the want of time, I will not spend too much of time, but this would be like a scenario, old age person with effusion cytology, lymphocyte rich effusion, and you have these cells which are monomorphic, and they have this soccer ball like nuclear chromatin. So you can see this nuclear chromatin, which is like there are some condensed nuclear chromatin granules. Flow cytometry actually helps in deciding whether it is neoplastic or monoclonal. Here you can see lambda restrictions, cells are CD45 positive, and they are showing IgD positivity, and they're negative for CD10 and FMC7. So this was a case of CLL infiltration. Patient had CLL, and similarly on the blood there was flow cytometry done. This is another pleural fluid Of mantle cell lymphoma, the cells are larger here. They are intermediate in size, small to intermediate in size, and they have this kind of irregular indented, clefted nuclei, angulated cells. So on morphology also sometimes it helps you decide. These are IHCs done on effusion cytology, the cell blocks. This is positive for cyclin D1, SOX10, SOX11, and on flow cytometry they are positive for CD5 and they show kappa restriction. Mantle cell lymphoma, if you can demonstrate, FISH can be done on the MGG stained slides. So we destain MGG stained slides and do FISH cytology. This is an example of Burkitt's lymphoma, and we know Burkitt lymphoma, you need to demonstrate c-MYC and Ki67 would be very high. This is DLBCL, and again in DLBCL, FISH will just tell you this is mature B-cell lymphoma, which is positive for CD19, 20, and it is negative for CD10, and it is positive for negative for 5 and 7 also, but kappa is restricted. So it is a mature B-cell lymphoma. Make a cell block and do CD20. CD10, cyclin D1 and BCL6 are negative, but MUM1 is positive. So if MUM1 is positive, it is non-GCB type, that is non-germinal center type of lymphoma. This is a rare example of Hodgkin's lymphoma. Patient was a known case of Hodgkin lymphoma, and in addition to a lot of eosinophils, polymorphs, we could see these atypical cells. And this is another example where we could see these atypical cells, RS-like cell, which are binucleated, and you could demonstrate again CD15 and 20 on cell block. This is another case of Hodgkin's only. Similarly, multiple myeloma, you can do flow cytometry or ICC to demonstrate. Most of these cases are not diagnosed primarily on fluid because they are known cases, but sometimes the request comes that you need to confirm multiple myeloma or lymphomas even on effusion samples. And in hematolymphoid malignancies, I would say flow cytometry actually helps. So this was another multiple myeloma. This was a publication long back in 2007. Sir, I'll take another 5 minutes. Another 5 minutes I'll take. So Ewing's sarcoma, neuroblastoma, Wilms, these are also cases sometimes seen on effusion cytology. I'm left with mesothelioma, and for JAs I would say suspect mesothelioma only if there is a clinical suspicion, one. Second, if it is pleural fluid with whatever band-like pleural thickening, and you are seeing lots and lots of mesothelial cells which are large and present in large clusters or aggregates. So most of the times mesothelial cells have knobby borders as compared to adenocarcinomas, which will have ball-like clusters. So they will have single population, there's no alien population, and they have these morules or dispersed population of cells with range of nuclear atypia. And this was a case of mesothelioma where calretinine was positive, CK was positive, and EMA and vimentin are positive, and we can see WT1 is also positive. So this was a study where they have shown that in mesotheliomas, the most common morphology which is helpful is berry-like clusters with uniform cell population and cell-in-cell engulfment, that is cannibalism. These are the features which help you decide this is mesothelioma, but at times it can be difficult. Again, I'm showing the same table. If you are differentiating between mesothelial cells and adenocarcinomas, take two markers of epithelial and two markers of mesothelial origin. MOC31 actually works very well, and we use BEREP4 also. Sometimes reactive mesothelial cells and mesothelioma is also difficult, but reactive mesothelial cells are desmin positive and mesothelioma would be desmin negative. If you have markers like BAP1 and MTAP, they will show loss in mesothelioma. So these are two good markers which show loss in mesothelioma, and they help you decide that this is mesothelioma. So for mesothelioma versus reactive mesothelial proliferation, remember desmin, EMA, MTAB and BAP1. And
Dr.
again,
Gupta, please wind up in 2
yes,
minutes,
sir.
please.
Sir, I'm doing that.
Thank you.
Thank you. So on FISH, again, it is the same FISH which is used for Eurovision, and we demonstrate centromeric probes for chromosomes 3, 7, 17, and probe labeled as 9p21. And on electron microscopy, you will see these long microvilli in mesothelioma. So to wind up, I'll say the proper collection is important. If you have used good anticoagulant, transportation is good, cytopreparation is good, you will have less number of false negative cases. LBC offers advantage in non-gynae samples, especially effusion samples. Cellular concentration happens in LBC, so that is one important thing. And special stains and immunocytochemistry can be done on LBC. But if you are planning to do immunochemistry, make a cell block. And cell block must be prepared in all suspected cases of malignancy in effusion samples. And molecular studies including EGFR mutations, NGS can be done on effusion samples. So with that, thank you very much. And sorry for taking an extra 5 minutes. Actually, I was told I am getting 1 hour. That is why the slides were like too many. And I had to rush through my slides.
You covered the content of 1 hour in half.
Thank you.
Thank you, Professor Dr. Nalini Gupta, for excellent presentation. You have covered all the things about the serous fluid cytology. You have covered how to process the serous fluid cytology samples, and you described how to difference between the mesothelial from the mesothelioma cells and adenocarcinoma cell. I have also described the different category for the reporting of the international system for serous fluid cytology. Yes. And you have also described the molecular technique on the LVC sample and also the cell block. Thank you, Dr. Nalini Gupta.
Okay. Thanks.
Any question from audience?
Yes, ma'am. So most of the times when we have lymphocyte-rich effusion, many times we do not report it as no malignant cells. We just call it lymphocyte-rich effusion. If the patient is young, they're most likely other causes rather than lymphoma. But if the patient is slightly older, more than 50, then we try to do flow in almost all cases, because it will help you decide whether it is just the reactive lymphocyte-rich effusion or malignant effusion. Many times we don't get that clinical information because you are basically reporting so many hundreds of cases that it's difficult to know which case is tuberculosis or which case is lymphoma. But if they suspect lymphoma, we do flow cytometry. Yeah.
Well, just suppose like if ADA more than 50 or 90 recognized more
then it goes in favor of tuberculosis. Yes.
In what percentage your experience?
That's what I'm saying, that many times we don't get the information that this patient had ADA levels high or low. But if you have lymphocyte-rich effusion and your differential is between a low-grade lymphoma, what we do is flow cytometry.
Thank you.
Professor P.K. Agarwal, ma'am. Front row.
I wanted to ask one basic question.
Yes,
in the preparation of fluid, in hemorrhagic fluid. In 1973, I worked in your Chandigarh laboratory. I learned one technique, and that was a capillary centrifugation technique.
Yes.
Are you not doing now?
No, ma'am, we are not doing it now.
But the technique was very
Yes.
good, very successful. And after coming back to Lucknow, I tried in my lab, and I published a paper on hemorrhagic fluid by capillary technique. The paper is published in Acta Cytologica 2009, and it was appreciated. So I think that is a good technique because it is simple. You centrifuge, then put some capillary,
and make
lock the
fishtail.
capillary, then again make the smear. So it was a good technique.
Actually, ma'am, with the advent of liquid-based cytology, you don't have to do anything. Any hemorrhagic sample, you can process it with the liquid-based cytology and you get good cells. All RBCs are usually lysed, so you don't have that problem of hemorrhagic effusions now. So now we are not making those thick, thin smears or fishtail smears. We don't do that.
Question for
not like a question. I mean, such an informative, we have heard such a good account. Just my personal experience, I just wanted to share. It may be helpful, it may not be, but I have seen it help me. Like when we do the cytology and we suspect lymphomas, like may it be a cervical lymph node, may it be an effusion. So I always, especially a child or even an old person, I always advise a GBP because that helps. Many times I catch because once in my lifetime I missed, and that made me learn a lesson. So I always make a GBP for a slide just to see whether the lymphoma cells are there or not, it's like leukemia or not accompanying.
Yes.
So that is my experience. It may help. That's what I said. Thank you so much.
Well taken. Fine, I think if there are no more questions, thanks.
Hello. Thank you. Thank you, ma'am.
Okay. Yeah, hi.
You covered the... Hello. I just want to know for LBC, whether which LBC, I mean, where thin prep or sure path, which we will prefer for this?
We have sure path, so we use sure path. And as such, people don't say that prefer this over that. Even for cervical cytology, people have seen that people who were trained with thin prep, they preferred thin prep, and people who were trained with sure path, they preferred sure path. But over the time, people have seen that at least for gynae, sure path works better. But for non-gynae, there is no preference for that matter.
Thank you.
Yeah. Yes.
1998, and sure path, lot of sure path in PGI. If you ask me this question, I will give you the answer non-commercially. Thin prep is much better because the solution they use it, number one. Number two, if you do thin prep, you will get monolayer slides. And monolayer slides always will give you the better vision than sure path. Sure path, this just dissociated the cell by mechanical process. And if you see that there is double-decker bus like 2 layers, and you will never get the excellent picture like thin prep. But thin prep is much more costly than sure path.
So again, I would say he has been trained first of all in thin prep, so he'll always prefer. That's the thing. Like I have worked in England, there used to be screeners who were trained on thin prep. They used to prefer thin prep. There were screeners who were trained on sure path. They used to prefer sure path.
Thank you, ma'am.
Okay.
It was really very informative and useful talk on effusion cytology. And thanks to the audience and organizers for giving us the opportunity to be here. Thanks to one and all. And probably inaugural session is going to start immediately after this session. So we move on to the next preparation of this podium and stage. Thank you very much.
Thank you so much, ma'am, for such an informative session on how to swim through all the different types of effusion. May I now request our respected chairpersons to please present a memento to Dr. Nalini Gupta, ma'am. May I now invite on stage Professor Madhumati Goyal, ma'am, to please present a memento to our respected chairpersons. May I now request ma'am to please present a memento to Professor Ram Naval Rao, sir. We are now beginning with the inauguration ceremony. We feel honored to be joined by our Honorable Vice Chancellor, Professor Sonia Nityanand ma'am today. On behalf of the entire Department of Pathology, I would like to thank ma'am for taking out her precious time to be a part of this conference. Ma'am is a fountainhead of illuminating ideas, an idol of knowledge and experience, and an inspiration to us all. Thank you, ma'am, for your gracious presence today. We are also delighted to be joined by our esteemed Pro Vice Chancellor, Professor Vineet Sharma sir, and Dean Academics, Professor Amita Jain ma'am, among us today, who have been a source of constant support and encouragement to us. Their presence has undoubtedly added immense value and prestige to this occasion. We shall now proceed with the inauguration ceremony. May I request our Honorable Vice Chancellor, Professor Sonia Nityanand ma'am, Pro Vice Chancellor, Professor Vineet Sharma sir, Dean Academics, Professor Amita Jain ma'am, Organizing Chairperson and respected Head, Professor U.S. Singh sir, the President of Indian Academy of Cytologists, Professor Anurag Gupta sir, Secretary of Indian Academy of Cytologists UP Chapter, Professor Ram Naval Rao sir, the co-organizing chairperson, Professor Suresh Babu sir, and the organizing secretary, Professor Madhu ma'am, to please join us in dais for the same.
There's a small change in the program since ma'am also has to leave a little early. So we are doing the inauguration just now, and the sessions will continue after the inauguration.
May I please request Professor P.K. Agarwal ma'am to please join us on dais for the inauguration ceremony. As a token of heartfelt appreciation, we would like to give a floral welcome to all our dignitaries. The Honorable Vice Chancellor, Professor Sonia Nityanand Ma'am, Professor P.K. Agarwal Ma'am, Organizing Chairperson and the respected Head of Department of Pathology, King George Medical University, Professor U.S. Singh, Sir. President of Indian Academy of Cytologists, UP Chapter, Professor Anurag Gupta, Sir. Secretary of the Indian Academy of Cytologists, UP Chapter, Professor Ram Naval Rao, Sir. Co-organizing Chairperson, Professor Suresh Babu, Sir. Organizing Secretary of UPCYTOCON 2023, Dr. Madhu Kumar, Ma'am. No auspicious event can be started without the remembrance of God, and on this occasion, we seek the blessings of Ma Saraswati, who is the goddess of knowledge and an embodiment of wisdom and learning. I request our respected dignitaries to officially inaugurate the ceremony with a traditional lamp lighting ceremony. May I now request the organizing chairperson and our respected head, Professor U.S. Singh, Sir, to please welcome all our dignitaries and delegates.
On behalf of Department of Pathology, we welcome Honorable Vice Chancellor, Professor Sonia Nityanand Ma'am, Pro Vice Chancellor, Professor Vineet Sharma Sir, who somehow could not manage to come, Dean Academics, Professor Amita Jain Ma'am, who is also busy with some schedule, President ISC UP, Professor Anurag Gupta, Secretary ISC UP, Professor Ram Naval, Professor Pranod De, Professor M.D. Bhatt Sir, Professor P.K. Agarwal Ma'am, Professor Sneh Lata Tiwarsan Ma'am, Professor M. Goel Ma'am, Professor Nuzhat Hussain, Professor Arvind Rajvanshi, Professor Vatsala Misra, Professor Vinita Agarwal, Professor Harish Chandra, Dr. Sudhir Srivastava, Dr. Vandana Mehrotra, Dr. P.K. Gupta, and Brigadier Nikhilesh Kumar. All distinguished faculty, head of the departments, dear residents, students, staff, employees, and media persons. We are thankful to Honorable Vice Chancellor Ma'am to grace this occasion and bless us all. We are profoundly thankful for her vision, advices, guidelines, encouragement, and unconditional support in all our endeavors. We are thankful to executive body of the UPCYTOCON 2023 to give us an opportunity to hold this conference in our prestigious Department of Pathology, KGMU. I congratulate and thank Professor Madhu Kumar, Organizing Secretary, and her team for successfully organizing UPCYTOCON 2023. We are thankful to all delegates for coming from faraway places and participating in this conference and making it successful. We are proud of great heritage and legacy of prestigious upgraded Department of Pathology as Center of Excellence, founded and brought about by our revered honorable teachers. We pay our sincere gratitude, great respect, and feel highly indebted to them all. Welcome, sir, Professor Vinesh Sharma, sir, Pro Vice Chancellor, KGMU. Thank you, sir. We pay our sincere gratitude, great respect, and feel highly indebted to them all. I feel fortunate and am proud of all the faculty of our department for their geniusness, exemplary services, professional talent and skill, hard work, and immense contributions in teaching, training, hospital laboratory services, patients' pathology diagnostic services, and research of international standards. We are proud of all junior and senior residents for their innate natural geniusness, respectfulness, discipline, hard work, punctuality, integrity, obedience, and professional contributions in teaching, training, hospital, laboratory services, patients' pathology diagnostic services, and research. All junior and senior residents are faculty's right hand and are backbone of our department and are all the vibrant and energetic youth icon and workforce to run Department of Pathology Services 24/7 throughout the year. Please, ma'am, come upstairs. We are proud of all staff and employees of our department for their immense contribution in the smooth running of the department. The challenges of the healthcare are in the domain of the disease prevention, eradication, low-cost affordable diagnosis and treatment, availability of low-cost affordable healthcare at central and remote geographical locations of the country, low-cost, easily understood and practiced diagnostic and treatment facilities to one and all its citizens, especially addressing the healthcare needs of children, elderly, physically challenged, pregnant females, and follow-up disease patients and disease-prone citizens with comprehensive health, education, and awareness prevention, early diagnosis and treatment and eradication. I am grateful and obliged to whole Department of Orthopedics. I am grateful, which is beyond words to be expressed, and pay my utmost respect, homage to my life savior and mentor, teacher of teachers, Honorable Padam Shri Professor M.K. Goel, sir, ex-head Department of Orthopedics, KGMC, who not only saved my life but blessed and inspired me with his charismatic divine aura and fatherly love, affection, care, and unconditional support throughout my career. Myself and my entire family feel immensely indebted to him. We wish that the Lucknow weather remains pleasant and all delegates' Lucknow stay remains comfortable and joyous, and academic presentations, discussions, and conversations among us all participants make this conference achieve great success and a memorable experience. Thank you one and all for your participation. Thank you very much.
Thank you so much, sir. We are privileged to be joined by our respected Pro Vice Chancellor, Professor Vineet Sharma Sir, on the dais, and also by Dean Academics, Professor Amita Jain Ma'am. We would like to welcome them with an Ekal Pushp. I now request the President of Indian Academy of Cytologists, UP Chapter, Professor Anurag Gupta Sir, to please address the audience.
Good morning, everyone. Respected Professor Sonia Nityanand, VC KGMU, respected Professor Vineet Sharma, Pro VC KGMU, Dean Academics, Professor Amita Jain, our organizing team, Professor U.S. Singh, Dr. Madhu, Professor P.K. Agarwal, our patron of the society. So I am delighted and honored to be here before you as a president of the society. I am really grateful to all of you, especially our speakers who have come all the way from different parts of the country and the state. I am thankful to Dr. Pranav De, who gave his consent to deliver the talk, the oration of the society, and various other prestigious speakers, Professor Nalini Gupta, Professor Atul Gupta, Professor Nujhat Hussain, and many more people who are associated with cytology, field of cytology in one way or other. Professor Rajvanshi, thank you. I just want to highlight few issues of cytology. So it's a bit neglected branch nowadays in pathology. We all have different streams of pathology in the department. Somehow, due to unavailability of adequate infrastructure or the stuff, the part of training is lacking in many institutes or many medical colleges. The cases are polarized in some of the bigger institutes or the institutes with more clinical material or more clinicians, manpower, infrastructure. So the basic aim and the responsibility of the society is to provide equal opportunity to everyone. And that can be done by conducting various activities. Annual conference is one thing. Ideally, we should conduct more and more conferences, more teaching activity in the form of workshops, and due to availability of online platforms, computational pathology, digital pathology, now this is the high time to think about sharing the stuff and the material to the youngsters, the budding pathologists, amongst all the members of the states. And we should focus on these activities with more frequently in per calendar year. So I will not take much time. I will thank to everyone, and I will congratulate to the team, organizing team, who took all the pain to organize this conference and made this beautiful program by inviting the speaker of national and international repute. I thank you all once again. Jai Hind. Thank you.
Thank you so much, sir. May I now request the Secretary of Indian Academy of Cytologists, UP Chapter, to please, Professor Ram Naval Rao, sir, to please say a few words.
Good afternoon, everyone. I respect to all the dignitaries present on the dais. On behalf of IAC Secretary, I would like to thank the respected Honorable Vice Chancellor, Professor Dr. Sonia Nityanand ma'am, and our Secretary, Organizing Secretary Dr. Madhu Kumar, President our Anurag Gupta, and our Pro VC Vineet Sharma sir, our Organizing Chairperson Professor Ivar Singh, and Co-Organizing Chairperson Professor Suresh Babu sir. I also would like to thank to all the faculty speakers who have taken part in this UPCYTOCON 2023. Cytopathology as a discipline is constantly evolving with the use of ancillary technique, thus enhancing the diagnostic ability of the cytopathologist for the developing the early definitive treatment, management, and the better prognosis. So I would like to thank to all the dignitary from the distinguished faculty, chairperson, expert came from the National Premier Institute, who spare the time, energy, knowledge, and the wisdom to make this event fulfill this goal. I again would like to extend my special thanks and gratitude to the organizing secretary, Professor Dr. Madhu Kumar and her teams, who contribution make this event a grand success. Last but not least, the strength of any conference lies in the number of the peoples. It has benefited. I am sure all the participants, delegates, and residents will again much knowledge, and thank to everyone their participation in the UPCYTOCON 2023 at KGMU. Thank you.
Thank you so much, sir. I now request our respected Dean Academics, Professor Amita Jain ma'am, to please share her valuable thoughts.
Honorable Vice Chancellor Professor Sonia Nityanand, our Pro Vice Chancellor Professor Vineet Sharma, the executive members of the Indian Association of Cytologists UP chapter, Professor U.S. Singh, Dr. Mala Kumar, the whole organizing team, and some of my teachers and my friends in the audience and on the dais, Professor Madhu, Dr. Bandana, Dr. Nuzhat, and it seems I know almost everyone here. Pathology is my parent department. It's like homecoming to me. So I always emotionally feel attached to it. I look forward to any meeting which is happening. And so I want to join. Sometimes I can, sometimes I cannot. I'm sure that this conference is going to be a big success. I can see the effort which has been put up by the organizing team. And actually I've been hearing about it for last 2-3 months, that what is going on. So my best wishes to organizing team, and I'm sure the delegates here will have a nice academic feast. Thank you very much for squeezing me on the dais too. Thank you so much.
Thank you so much, ma'am, for your motivational words. May I now request our respected Pro Vice Chancellor, Professor Vineet Sharma sir, to please enlighten us with his thoughts.
Thank you. Respected Honorable Vice Chancellor, Professor Sonia Nityanand, my teacher, Professor P.K. Agarwal, and of course, Professor Madhumati, Professor Amita Jain, Dr. Anurag, Dr. Ram, Professor U.S. Singh, Dr. Madhu, dear faculty members, a lot of friends are sitting in the audience, ladies and gentlemen. The importance of cytology I can vouch for and understand since I have been involved in the diagnosis of certain problems. Basically, this branch leads to a lot of diagnostic problems which can be treated early in life. I congratulate the Department of Pathology, Professor U.S. Singh and Dr. Madhu and the whole organizing team for Professor Suresh for organizing this conference. I am sure the young budding cytologists will take the advantage of experience for our senior cytologists and go further in life. My best wishes to all of you.
Thank you so much, sir, for your encouraging words. We are extremely proud to present to you the souvenir of UPCYTOCON 2023 and the liquid-based cytology manual, workshop manual, that would be conducted tomorrow. And I request all our respected dignitaries on the dais to please unveil the manual and the souvenir before us. Thank you so much, respected dignitaries. May I now request our Honorable Vice Chancellor, Professor Sonia Nityanand Ma'am, to please share her words of wisdom.
Thank you. Thank you. So, I think it's afternoon. Okay. A very good afternoon to our Pro Vice Chancellor, Dr. Vineet Sharma, the Dean Academics, Dr. Amita Jain, my most respected teacher, Professor P.K. Agarwal, and all the other dignitaries on the dais, which is Professor U.S. Singh, the organizing chairperson, and Dr. Madhu Kumar, who's the organizing secretary, the president of the IAC UP chapter, Dr. Anurag Gupta, and the secretary of IAC UP, Dr. Ram Naval Rao. A lot of teachers who are sitting in the audience, Dr. Madhumati Goyal, and Dr. Vandana, Dr. Nuzhat Hussain, from RML IMS, the head of the Department of Pathology, all the participants in this conference, all the faculty members of the Department of Pathology, and all the participants, the staff here. And I also would like to extend a very warm welcome from the King George's Medical University to all of you who have come to attend the UPCYTOCON 2023. As someone already said, that cytopathology somehow is a non-glamorous area of pathology, but because of the recent developments, I think it is gaining more and more glamour. And most important, it is a modality of rapid reporting. You know, you get a very rapid report by cytopathology. And I would like to congratulate Dr. U.S. Singh and his entire team, Professor Madhu Kumar, for hosting this amalgamated program on cervical cancer screening, squash cytology, revised cytopathological classifications, and highlighting the latest systemic cytology reporting protocols. So it just shows how this field of pathology has gone forward by leaps and bounds, and there are so many new developments in this area which has warranted a conference like this to update through the eminent speakers about all the recent advances in this field. I would also like to congratulate the release of this concise workshop manual on liquid-based cytology interpretation for cervical cytology. I think I was trying to look at it. It's a very useful manual. So congratulations to all the people who've contributed towards this manual. As a clinical hematologist, it's an area which has really, cytopathology is an area which has really helped us in diagnosis in various ways. You know, a lot of fungal infections from lesions have been very rapidly diagnosed because of cytopathology. And as I highlighted, that I don't know if it's really a part of cytopathology, but moving on from moving on from blood flow cytometry to a liquid sample obtained through cytology for flow cytometry has also been a very great advancement for us, that you don't have to wait for the lymph node biopsy reports to come, which takes a little time, and you can get a very rapid report through the cytology specimen and which has been subjected to flow cytometry. So my two take-home messages for this audience would be, especially for the young people who are attending, is that apart from updating yourself on the recent advances through this conference, think of more innovations which could be introduced in this area of pathology. I think there would be even more and more innovations which can be introduced. And there is a very good orator. I understand that Dr. Day is probably a dawn in this area with more than 500 publications and with, you know, making advancements in computational cytology. So there is an excellent oration by him, and he'll serve as an example of introducing how innovations can be introduced into this field and then taken forward for the rapid diagnosis. So I wish you all a very good luck. Enjoy this workshop, gain a lot from it, and good luck. Thank you.
Thank you so much, ma'am, for your inspirational insights. May I now request our respected head, Professor U.S. Singh, sir, to please present a memento to Honorable Vice Chancellor, ma'am. Thank you, ma'am. May I now request Professor U.S. Singh, sir, to please present a memento to our respected Pro Vice Chancellor, Professor Vineet Sharma, sir. Thank you, sir. May I please request, sir, to please present a memento to respected Dean Academics, Professor Amita Jain, ma'am. Thank you, ma'am. I also request, sir, to please present a memento to Professor P.K. Agarwal, ma'am. Thank you, ma'am. I again request, sir, to please present a memento to President of Indian Academy of Cytologists, UP Chapter, Professor Anurag Gupta, sir. I request, sir, to please present a memento to the Secretary of Indian Academy of Cytologists, UP Chapter, Professor Ram Naval Rao, sir. Thank you, sir. May I now request our President of Indian Academy of Cytologists, UP Chapter, Professor Anurag Gupta, sir, to please present a memento to our respected head and organizing chairperson, Professor U.S. Singh, sir. Thank you, sir. Sir, I again request you to please present a memento to our co-organizing chairperson, Professor Suresh Babu, sir. Sir, I request you again to please present a memento to our organizing secretary, Dr. Madhu Kumar ma'am. Thank you, sir. Thank you, ma'am. May I now call upon the podium Dr. Madhu Kumar ma'am, the organizing secretary of UPCYTOCON 2023, to please give away a vote of thanks.
Honorable Vice Chancellor Professor Sonia Nityanand Madam, respected Pro Vice Chancellor Professor Vineet Sharma Sir, respected Dean Academics Professor Amita Jain Madam, Head of Department Pathology Professor U.S. Singh Sir, Professor Pranav Dey Sir, and all esteemed speakers, our most valued invited guests, delegates, my teachers, past and present Secretary of Indian Academy of Cytologists, Professor Madhumati Goyal Ma'am, Professor Nuzhat Hussain Ma'am, Dr. Atul Gupta Sir, Dr. Vinita Agarwal Ma'am, and present and past Secretary, Dr. Anurag Gupta and Dr. Ram Naval Rao, and their students. I, Dr. Madhu Kumar, Organizing Secretary of UPCYTOCON 2023, on the behalf of the organizing team of Pathology Department of KGMU, I extend a very warm welcome to all guests for gracing this program. We are deeply gratified and thankful to our Honorable Vice Chancellor Madam, Professor Nityanand Ma'am, for accepting our invitation and gracing the occasion as a chief guest. Madam, your continuous motivation and guidance help us to give our best. I also express our sincere thanks to Pro Vice Chancellor Professor Vineet Sharma Sir for his gracious presence. I would like to thank Dean Academics Professor Amita Jain Madam. I extend my heartfelt thanks to all head of department of faculty member of various department of King George's Medical University, other medical colleges of Uttar Pradesh. I would like to thanks to all retired faculty member of Pathology Department who have accepted my invitation and have made effort to attend this conference. I express my sincere thanks to Professor Suresh Babu Sir for his insightful guidance throughout the preparations. I would like to thank to all esteemed faculty, colleagues of our department for their boundless support. Each member responded my numerous calls, messages, and lovingly shared the responsibility I instructed them with. All senior and postgraduate residents deserve our sincere thanks, in particular for their timeless and continuous support for organizing the event. I must mention my deep sensation of appreciation, Professor Pranav Dey Sir, who readily accepted our invitation from his busy schedule for Professor Padam Kumari Agarwal oration. Today, we have the opportunity to hear you, sir. I am sure that our delegate and student would get a good insight from your talk. Words will fall short to offer sincere thanks to our head of department, Professor U.S. Singh Sir, for giving opportunity for organizing the UPCYTOCON 2023. Thank you, sir, for showing your confidence in me for organizing this event. Your forward vision has always brought a fruitful result in our department. Such academic event cannot happen overnight. The wheel started moving months ago, and it required positive thinking, proper planning, activity to culminate into the proper feast. Professor U.S. Singh Sir is a man who had been the driving force behind this event. His positive criticism, suggestion had always been a motivational factor for us. Thank you, sir, for promoting and encouraging me throughout the preparations. At the last, I want to express my gratitude to my family, my husband, Dr. Brijesh Kumar, for his indirect, unwavering support and encourage throughout the preparations. The staff of our department, Convention Center staff, deserve our sincere thanks for their support. My special thanks to our sponsors, media person, who have contributed immensely in the success of conference. All participants from various medical colleges, university, Institute of Uttar Pradesh have made this conference more graceful and glorified. This conference could not be possible without your kind
presence and enthusiastic participation in the conference. We have more than 300 participant or registrations, more than 70 paper and poster abstract, 90 workshop participant in both LBC and square cytology, and more than 50 faculty from Uttar Pradesh joining us for this 2 days conference. Once again, I thanks to all for your cordial cooperation. Thank you.
Thank you, ma'am. We have an announcement by the President of Indian Academy of Cytologists and Secretary of Indian Academy of Cytologists UP chapter. Sir, may I please invite you?
Thank you. Now the times of announcement. I request to our Vice Chancellor ma'am kindly inaugurate our website of the Indian Academy of Cytology, UP chapter ma'am.
I would like to emphasize that Dr. Ram Naval, since he has taken over as secretary, it has made lots of efforts to revive our association, because during COVID period our registration got expired, and then we had some problem with our PAN card, and later on there was no website, so we could not add more members. But somehow he took all the pains and he got all the things in line in very short period of time. I congratulate to him, and I'm really, there should be a big applause for him to do this wonderful job.
Thank you so much, ma'am. May I now request all the dignitaries and the delegates to please stand up for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
I thank all the dignitaries on the dais for joining us. We shall now have the oration lecture, and for the same, I request Professor P.K. Agarwal ma'am to please stay back on the stage, while I request rest of the dignitaries to please proceed. Thank you. Somebody has misplaced her room key from Silvet Hotel, so I request them to please collect it from a photographer. Thank you.
Now coming to the much awaited segment of today, the Professor P.K. Agarwal oration, which will be delivered by Dr. Pranab De. For this, I would like to invite on stage Professor Madhumati Goyal ma'am and Professor Arvind Rajvanshi sir to please chair the session. Professor Madhumati Goyal ma'am is a director, Department of Pathology and Lab Medicine, Medanta, Lucknow. Ma'am is the former head of the Department of Pathology, Dean College and Pro VC at KGMU. During her tenure, ma'am has strengthened the diagnostic services of histopathology, cytopathology, and molecular pathology. Professor Arvind Rajvanshi sir is a professor at the Department of Pathology, AIIMS, Raebareli. Sir has a research interest area of FNAC and gynecological pathology. Sir has been bestowed with numerous awards, including the Ernest Fernandez Award and Padam Kumari Agarwal Oration Award. I request Professor Madhumati Goyal ma'am to please share a few words about Professor P.K. Agarwal ma'am. We request everyone to please settle down as we'll be starting with the oration soon. I request Dr. Arvind Rajvanshi sir to introduce Dr. Pranab De sir.
I have been given a very pleasant duty to introduce Professor Pranab De, who has been the orator for today, Dr. Padam Agarwal oration. He will be talking about computational cytopathology, the new path ahead. I have known Dr. Pranab De for 40 years. I can introduce him without reading this paper, but it's customary to read out of this paper. Dr. Pranab De completed his MD in pathology from Postgraduate Institute of Medical Education and Research, Chandigarh, India, in the year 1988. He was awarded a fellowship of Royal College of Pathologists in the year 2006. He has been working as a consultant in cytology and gynec pathology in the same institute for the last 30 years. He was considered as the top 2% scientist in the world in his recently published article in PLOS Biology. Dr. Day is the author of a number of books in the field of cytology and histopathology, as is considered as a leading author in pathology books by International Review Committee. He is a prolific writer. He has vast experience in research and teaching in cytology and gynecologic pathology. He has more than 400 research publications in various international journals, and out of which more than 150 were original research papers. He has numerous reviewed articles in various cytology journals and many significant research publications on artificial neural network, advanced morphometry, and flow cytometry. His prime interest is on the artificial intelligence in the field of cytology. Dr. Day has been a prolific researcher, and that is the reason all residents in Department of Cytology used to be behind him. They were more interested with following him up so that they will get one or the other publication. And he has done good service to them by making them publish some article or the other. And he has been talking about artificial intelligence since many of us would have not heard about artificial intelligence and the use of computer in cytopathology. So today he will be delivering P.K. Agarwal oration, Computational Cytopathology, the New Path Ahead. And probably we all will be interested in listening to it. I would like to inform you all, the Government of India is proposing a artificial intelligence in pathology program all over the country. So we all have to listen to it carefully and plan our research on artificial intelligence. Thank you very much.
We are sorry to reverse the order. Now, since the oration is in the name of Dr. Padam Kumari Agarwal, my teacher too, so I'll first introduce her. She needs no introduction to this audience. Again, this is a formality. So at the outset, I would like to convey my heartfelt thanks to HOD Pathology, Dr. U.S. Singh, and his entire organizing team for giving me this opportunity to say a few words for an accomplished teacher, researcher, and diagnostician par excellence, Madam Padam Kumari Agarwal, popularly known as PK Madam in the pathology groups. Am I right, Madam? Okay. So she has been my teacher, mentor, and guide too. An MBBS graduate from Agra Medical College, and MD Path and Back from KGMC in late 60s, Madam had a long, illustrious journey of more than 40 years at KGMC till her superannuation as Professor of Pathology in 1997. She has been the first one to establish the full-fledged discipline of cytopathology at KGMC and the first one in the state of Uttar Pradesh. Her journey of cytology began in 1973 when she was asked to develop cytology by Professor Armil Mehrotra and had the opportunity to get an ICMR fellowship at PGI Chandigarh under late Professor Subhash Kumari Gupta. The two great stalwarts, you can call one the initiator and the other promoter, as in our language. So ever since then, her journey continued from Commonwealth Fellowship at UK under Doctors Gordon Kenty, Marigold Curling, and A.I. Sprague, a well-known author of Effusion Cytology book, where she received advanced training in cytology, especially neurocytology, FNAC, and fluid cytology. Thereafter, she dedicated herself wholeheartedly to develop the specialty of cytology at KGMC and disseminated the knowledge to other state medical colleges also through CMEs, workshops, seminars, guest lectures in cytology at the state and national level. She also organized 15th Annual Conference of Cytology in 1985 at KGMC, and like any other young faculty, I was sitting there at the registration counter. So with her untiring efforts, the cytology laboratory at KGMC, Lucknow, was accredited at the national level for training, conducting examinations, and also for diagnostic services in 1989. And it continues re-accredited till date, the legacy carried forward by her disciples. Her published work in journals has been quoted in recent books on cytology. Her technician-friendly technique for processing the hemorrhagic fluids, as she already told, was published in ACTA, and it was adjudged as one of the best 10 publications that time in the year 2010. Besides being a member of IAPM and so many associations, she is also an emeritus member of International Academy of Cytology, past president of Indian Academy of Cytology. She has received countless awards, as to name a few: academic oration, Ernest Fernandez slide seminar, Dr. Subhash Kumari Gupta memorial orations, and a number of lifetime achievement awards. And she has also been honored as pioneer cytopathologist of the state of Uttar Pradesh. Even at this age, Madam PK is actively contributing and serving to cytology passionately. Currently, she is senior consultant and DNB coordinator in pathology at Vivekananda Institute of Medical Sciences, Lucknow. There also, she has developed the specialty of cytology. Under her able guidance, the pathology laboratory at Vivekananda has now been upgraded to a full-fledged postgraduate department to train DNB postgraduate students. I, having been her student, can go on and on. I need to stop here. Madam, aapko shat naman. What an honor to all of us and a moment of pride to have a living legend here with us for whom we are conducting this oration. So a big round of applause. So many of our students are already there in the audience, so it is a moment of pride for us. I request Master Ceremony Dr. Isha Makkad to play a very small video of her journey of cytology of more than 40 years, which will be displayed only in 3 minutes. We need your attention. तो आप ऐसे समझ सकते हैं, मैडम की कहानी, मैडम की जुबानी. The video madam had shared at Golden Jubilee celebrations of ISC held at Delhi 2 years back. Dr. Isha, please.
Friends, I would like to narrate my journey as cytopathologist. After completing my MD pathology, I joined pathology department of King George Medical College, Lucknow as a faculty in 1970. In 1973, my mentor, Professor Amir Malhotra, wished to enhance the cytopathology diagnostic services in the department. For that, I had a chance to visit cytopathology department of PGI Chandigarh to update my knowledge in the cytopathology diagnosis under the able guidance of Professor Miraikal. Besides exposure to cytology, fortunately, I had a chance to learn fine detailed patient cytology from Dr. Subhash Gupta on my return to Lucknow. I was quite excited to establish a new branch of diagnosing palpable masses prior to biopsy. Initially, I faced some resistance by the senior surgeon. I didn't give up and tried to convince my counterparts in the surgery department with the full support of my husband, who was faculty in the plastic surgery department. I became life member of this great Indian Academy of Cytology and participated in the annual conferences very regularly. With the inspiration of blessing of my teachers, Professor P.N.Y. and Madam Professor Usha K. Luthra, I was motivated to work hard in this field. Fortunately, I was offered Commonwealth Medical Fellowship in 1977-78 to work in the cytology Laboratory of St. Bartholomew Hospital, London, UK, under the guidance of Dr. Gordon Kempty and Marigold Curley. Since I was quite regular in attending annual conferences of IAC, senior members gave me chance to chair the sessions and moderate the seminars. I was member of Executive Council and editorial board of Indian Journal of Cytology for quite long time. I am grateful to the dear members of the Academy to give me opportunity to organize 15th annual conference of IAC in 1985 in KGMU College, Lucknow. I was given the opportunity to deliver academic oration and present Ernest Fernandez Diagnostic Fly Seminar. I published several papers in Acta Cytologica, the main being a new technique developed to process hemorrhagic fluids in 2009. This was just one of the best techniques in 2010. In 2012, I was invited to deliver prestigious lecture instituted in the name memory of Dr. Subhash Kumari Gupta in the GBM of the conference. My request to start UP chapter of cytology was granted, which we are holding quite regularly each year. Jai Hind, Dhanyavad. Long live Indian Academy of Cytology.
Even if we go indefinitely, it would be difficult to summarize all the accomplishments of ma'am to the field of pathology. So without any further delay, I may request Dr. Pranab Desar to please join on the stage for the oration.
Good afternoon. Thank you, chairpersons, Dr. Rajbogshi and Dr. Madhumati Goyal, and my regards to the teacher of the teacher, Dr. P.K. Agarwal, which I have seen for many, many decades with my Guruji, Guruma, Dr. Subhash Gupta. And it's my pleasure to deliver oration in front of her. I wish her blessing. Today, I will introduce you with a unborn baby. Yes, it is the unborn baby that is computational cytopathology. Let's see what immense potential of this computational cytopathology. And I will discuss these topics in this following heading. We all know about the light microscope. More than 400 years, we are habituated of the light microscope. And it is very easy to use, widely available. Every day, all of us, we use whether cytopathologist or histopathologist, we have to take the help of light microscope. And it's very cheap. In every laboratory, we have this light microscope. Then why should we talk about this so-called computational cytopathology? Why? Because light microscope has its own limitation. The diagnosis is expert oriented. there is lot of subjective variation. At times, it is very difficult to correlate. If you get the images in the light microscope, along with your immunocytochemistry, fluorescent in situ hybridization data, and NGS data, means next generation sequencing data, and it is very difficult to give these diagnoses, predictions, and so on. But what is computational cytopathology? Actually, it is the digital image data of the patient are combined with the patient metadata and to extract and analyze the features by using artificial neural network. So basically, computational cytopathology, we can say that it is the amalgamation of WSI data, that means whole slide imaging data, clinical data of the patient, various biomarkers of the patient, ICC or immunocytochemistry, and then genomic data. And then you apply artificial neural network on this whole amalgamation of data. But why? To correlate the image data to the patient's outcome, assisting diagnosis, and identifying various novel features. And so, you can say that digital image data by WSI, whole slide imaging, and metadata of the patient, plus artificial neural network is equal to computational cytopathology. What are the components of computational cytopathology? There are mainly two components. One is that clinical information, digital image data, overall laboratory data, and molecular data. That means data, information. And another is that application of artificial neural network on this data. So basically, I will discuss, or I will give you the overview of these two things first. And the most important is the data generation. Data may be in your laboratory internal database, and data may be external database. What are the internal database? Internal database means administration. It comes from the patient's billing, hospital stay, outdoor service, then clinical information, various clinical information which you have in your hand. Then laboratory data, that means different biomarkers data, serum markers, etc., digital image data, and molecular data. And external database, we all have the external database. It is in the internet system. What are the experiences of other people? That also you can use here. Now, about the digital image data, I'll give you a brief glimpse of digital image data, WSI or whole slide imaging. Just you do scanning of a paper, important documents. Similarly, you can scan of your slide, where the whole slide will come in your system. That means the slide, glass slide will be converted into a digital slides. And each of the image, we all know that these are made up of pixels. And each pixel of red, green, and blue, these basic three primary colors. So it gives value of that, each of the primary color, it records that. And if you apply that primary colors in your computer system, you develop that images. That is the very basic things. And these are the components of WSI. We know that it has a hardware, it has a software. Hardware means microscope, lens, focusing system of the microscope, robotics to use that to load the slide, and etc. And the software where we get the images in different formatting image viewing, image analyzing. And this is the overall pictures of the hardware. Robotics, it helps to introduce these slides into the system. And we know that cytopathology have the cluster of cells, so we have to go the scanning of Z scan, means X and Y axis, and Z axis means depth, and the depth of the slides, and you take the picture, various digital images of different depths, and the moment you do that things, your image size will be very, very much. Each of the slide equal to one movie, full movie, about 2 to 3 maybe gigabyte. And then after image capturing, you can see the images, it will come your system, and you can analyze the image. Now, these other components you all know. So, then artificial neural network. I'll be very brief, just give a glimpse of artificial neural network. Actually, artificial neural network almost equal to artificial intelligence. Here, the simulation of the human mind in the computer system is done, and the computer is programmed in such a way that it will behave like humans. Behave like humans means it will learn. There will be no specific algorithm, but it will learn from the environment. Each of the times it will learn, and it will apply its learning to take decision. So, as that biological neurons, we have the nodes in the artificial neural network. We know there are layers of artificial neural network. First layer is the input nodes, which you are giving the information. Second layer, the black box or hidden layer. Hidden layer is the must. Here, the input nodes is connected, and then it goes to the output nodes. And this is the mathematical formulation. I will not go in details. But this traditional artificial neural network has several problems. It takes long time to extract the morphometric data. And data acquisition needs expert. And data selection also may be biased. When we first started artificial neural network about 23 years before, 2001, that time we used that the simple capturing the images and data extraction from the images. And capturing the images of different parts may be biased by you. So it comes that deep learning system or machine learning. Nowadays, we are using convolutional neural network. Actually, it is an algorithmic model of the deep learning network that helps itself. The system does the feature extraction and final interpretation from the image. So if you give the image, automatically it does the feature extraction. There is no need of technical knowledge, which we have done the work on effusion fluid. You give the images, and it takes the significant data extraction, which of the cells it feels that important. It takes the images, and just like a magician's, it makes a big image into smaller and smaller and smaller image, which all the features intact. That seems unbelievable, but it is true. And these are the steps of convolutional neural network. First, we use a filter. We put the filter on that, and with the help of the filter, we make the images smaller image. This is just mathematical formulation. The filter has certain pixels, and this pixels number and images pixel number is multiplied. Then addition of that total pixel value comes in a another pixel. That means 9 pixels will have a single one value. And this is a mathematical formulation known as convolution, then activation by ReLU system, then pooling of the layer, and fully convoluted neural network is applied. By that, you can utilize your whole histopathology digital slides or cytopathology slides, and you can extract the data. Next is implementation. I will be very brief because time is showing only 2 minutes. I think 15 minutes is not enough justice for the talk. I may take 4 or 5 minutes more. Okay. So I have permitted to another 10 minutes, so I'll be slow. Now, the implementation, here it is very important. First, you have to think in any of the laboratory pathologists that what is your problem? You have to understand the problem. Problem may be many things. Suppose a lung pathologist want to know the classification of the image, means what type of tumor that may be, what may be the prognosis, second, whether that particular mutation is present in that or not, and what type of drugs or what type of mutation, further mutation can occur. That may be your problem. So accordingly, you extract your data and generate your data set. So your internal data set will be that. External database you can take what other people have done, what other people have found. Next is that you have to take the help of the computer software engineer, but you have to know that you have to make the input notes. Input notes means different features, clinical features, age, suppose sex, diameter of the tumor, etc. All clinical details. Laboratory features, that different notes. Then you have to incorporate your digital images. That is very difficult. Whole images will come. Then your fish or other data will come. So that will make your input notes. Then there will be hidden notes and output notes. So again, I have explained that things. So these are the input data. Then your hidden layer and your output layer. Next thing is your model training. So here you have to determine that how many iterations you have to do, what will be your training set, what will be your validation set, and you have to judge that how your system works. It usually is judged by receiver operating curve or confusion matrix. What we do both. And this is the overview. Data set preparation, model generation, model deployment. Then you, after the adequate training, when you see that model is working fine, you use the patient data and see what is the outcome. If your outcome is not satisfying, change the model again. So this is the overall data set preparation, model generation, and model deployment. This is the overall implementation of the computational cytopathology. What may be the applications? That is the most important thing, is applications. First is that it will give you precise diagnosis over the manual study, number one. Number two, various antigen, various scoring you can do by this model. You want to do the PDL1 score, you can use it. You want to have others mitotic scoring, you can use it for this. And subtyping of the tumor, I am not discussing in details because people have done various subtyping of various organs their malignancies and subtyping is possible when they are using neural network and other data. Then identifying the unrecognized morphological features. It has been seen that we do not know many of the subvisual information. Suppose it has been shown that the stromal changes in the breast carcinoma, and certain stromal changes is related with the prognosis of the patient, that we do not know. So various papers have come, and not only breast carcinoma, in other areas also, many subvisual images you can detect, and you can utilize in future, and many novel imaging features which we do not know. The machine can detect and can say this type of ductal proliferation indicating malignancy. That you can do. We have used many years back the endometrial cytology, what agas, which one will go malignancy, which will be benign, you can predict. Recently we have seen the area of AUS thyroid. It is very difficult when we say flush or follicular lesion of undetermined significance, so that benign or malignant. But using the artificial neural network, you can precisely say these subvisual features are responsible for the tumor. Then important is the FISH data. Next generation sequencing data. We have huge amount of data in our hand. Now it is the time to use a computational cytopathology to integrate this data, and this will help you not only in the diagnosis, it will help you in the prognostic assessment of the patient, even therapeutic assessment. But there are various problems of implementation. I will be brief in that. Data source, infrastructure, speed of the computer, security, and medical ethics. Data source. If you see that, we have molecular data in our hand. Molecular data, there are huge amount of molecular data in our hand, and it is unexplored area. Second thing is that image, WSI or whole slide imaging gives you immense information, because unbiasedly computer will extract the various features from the digital images. Clinical information you have to add, and you need cloud storage from multiple sources, and then immunocytochemistry and other data. So you see that enormous amount of the data in your hand, which is very difficult to handle. We have the very good computer, but still, if you do yourself in your computer will be blocked immediately. It will be hanged. So that is one problem of handling of the huge data. Second thing is the infrastructure. You need to have a whole slide scanner, expert in bioinformatics, who will convert your data in the reasonable way so that computer can read. You need computer software engineer. You need data entry operator. And then you need collaboration, because it needs huge amount of data from the different hospitals. So, and the most important, you need that whether you should use it or not. If you decide that you will not use it, you will use it only light microscope, fine, then you will not progress, and there will be no computational cytopathology. Then speed of the computer also very important, and security, that is very important, because your data is available by other computer, other people, and you do not know the medical company can use your data or not. Who will give the security? Then medical ethics. If something is wrong, who will be the responsible persons? That law is not still decided. So in conclusion, I can say that what I have talked in this afternoon, there is no existence of such discipline in reality. But very soon we will encounter of such discipline. And for that we need proper vision, good funding, human resources, collaboration, and your will. Because we are the persons, and we have to know what will be our role in this modern world. And I am very definite that computational cytopathology will bring significant change in your or in our laboratory system very soon. And a journey of 1,000 miles begins with a single step. We have to put our first step for computational cytopathology. And we means all of our young generation who has that vision, who has the hope, they and they only can implement this newer technology along with artificial intelligence. As Dr. Rajbangshi first beginning, he said, government of India is going to sanction on artificial intelligence. And we have to integrate this in your system, in our system. Thank you very much.
So, very well said, Dr. Pranav. And in fact, you are right. We will be thrown out of the stream if you don't go beyond that. So, you have started, you have initiated. I think younger generation will be motivated, and they need to be trained, in fact. So, we require a lot of human resource. Most important is the training part. And we have to be motivated, and we have to be
right.
So it was very good, and traditionally we don't ask any questions in orations. So if you have any questions, you can discuss those questions. So that is what I'm saying. That so you can discuss any questions if you have over the lunch with Dr. Pranav. So thank you so much, Dr. Pranav.
Thank you very much.
It was excellent.
Thank you.
You want to say?
Thank you, sir, for such an enthralling oration. Now I request Professor P.K. Agarwal, ma'am, to present sir with an oration award. I now request our chairpersons to please felicitate Professor P.K. Agarwal, ma'am. I now request Professor Vatsala Vishra, ma'am, to felicitate our chairpersons. Ma'am, please felicitate Professor Madhumati Goyal, ma'am. Ma'am, please felicitate Professor Arvind Rajvanshi, sir. Thank you.
Thank you very much. I'm overwhelmed to see today's program, and Dr. Madhu Kumar, I'm very much grateful. Dr. USC and the whole team of faculty of KG Medical College. Now, this function or this status of cytology in this state is not single person's job. It is a teamwork. With my postgraduate, the number one, my teacher, mentor, Professor Amil Mehrotra, he initiated the work, but I obeyed his orders, whatever he said. Then support of my husband to carry out, to go outside, leaving family for 1 month, then for 1 year to UK, courage go tours. Then to carry on this job, credit goes to my postgraduates, my colleagues who work with me, and I'm very much proud of everyone, and I wish you good luck to everyone. Thank you.
Thank you so much, ma'am. A very good afternoon to all of you. Since we are running out of time and a little late in the sessions, may I request the judges of the poster presentations to please, start with the poster judgment right now, and the poster presenters to please stand beside their posters, so that we can save a little time and the judges can have their lunch at time. Also the delegates. Thank you so much.
So now for the next session, we have a series of slide presentation that will be led by Dr. Deepa Rani ma'am, professor at SNMC Agra, and Dr. Amrita Ghoshkar ma'am, professor at BHU Varanasi. And to chair this session, may I invite Professor Vinita Agrawal ma'am and Dr. Bandana Mehrotra ma'am to please join us on the dais. Dr. Vinita Agrawal ma'am is a professor, Department of Pathology at SGPGIMS. Ma'am is an alumni of Department of Pathology, KGMU, and was awarded Dr. Joy Gopal Mukherjee Gold Medal Award for MD Pathology at KGMU. She has been bestowed with Mission Shakti Award by Honorable Governor of UP 2021. Ma'am has deep interest in the field of renal pathology, cytopathology, and electron microscopy. Dr. Bandana Mehrotra ma'am is currently the CEO Director and Consultant Pathologist at RML Pathology Lab and RML Research Foundation. Her areas of interest include surgical pathology, gynae pathology, and cytology. Ma'am is a visiting fellow at Department Pathology, Civic Hospital, Ottawa, Canada, and Department Pathology, Allegheny University Hospital, Pittsburgh, USA. Now I request our chairperson to please introduce the speakers.
First of all, I'd like to thank the Department of Pathology, KGMC, for inviting me. As has been said, I am an alumni of this college. I did my MBBS and MD both from this college. This is my alma mater, and it is like coming home. I will now start the session with the first presenter is Dr. Amrita Ghoshkar. She has been a resident at SGPGI. She is affiliated to the Pathology Department of Pathology, BHU IMS. She is as a professor, and has authored and co-authored multiple peer-reviewed scientific papers and presented works at many national and international conferences. She has contributions and recognition for the subject and is actively associated with different societies and academics. She has been decorated with several reputed awards and fundings projects, and she has research interest in histopathology, cytopathology, and neuropathology. Recently, she also did a course in medical genetics at our institute. I invite Dr. Amrita to present the case.
A very good afternoon to all of the delegates and chairpersons. First of all, I thank the chairperson for giving me this opportunity to present a few cases. So the first case, these are basically the cases in which the cytopathology is important. So the first case is a 8-year-old female. She presented to our OPD with a swelling in the right lower lateral aspect of the back, just above the iliac crest for about 1 month. This swelling was soft to firm swelling. It did not had any bony attachment. It measured about 3 into 2 centimeter. Radiology was not available, and the patient was subjected for FNAC, which revealed a extremely cellular smear, and this these were composed of predominantly dispersed population. These cells were in the single form, and also noted some loose clusters here and there. On this is an H&E preparation in which we can see that most of the cells are mononuclear. They have, but few of them displayed binucleation and multinucleation. So this is an MGG stain preparation which showed most of the cells were dispersed population. They were having, this is also showing a binucleation. These cells were having a round nucleus and abundant amount of cytoplasm. These were some clusters which were present here and there, and at places these clusters were concentrated around some vessels, whereas the other areas they were showing some sheet-like patterns, and in the lower part we can see that there is some kind of clustering or a vague, we can say, alveolar arrangement was there. So the individual cells were of about medium size, or we can say large size, and they show a relatively mild anisonucleosis. Most of the nucleus were round. They were centrally located. However, at places they were a little bit eccentrically located nucleus. These cells had got abundant amount of cytoplasm, and these at places we can see that the cytoplasmic borders are fragile, and they are indistinct. They are not very clear or well demarcated, and some of the in some of the cells there is also showing some vacuolations. Apart from that, we could find binucleation. At places some vague acinar arrangement was also seen. The nucleus were showing prominent nucleuses at places. However, it was not a very uniform feature. In this area, the nucleus is showing prominent nucleolus, whereas in the other area, the nucleus was showing some kind of wrinkling or irregularity, or some irregularities were there. Also noted few atypical mitosis. So another feature which was found was this kind of material was there, in which we can see it's a very cellular area, and there is a kind of matrix which is present within the cells, and this matrix is like a metachromatic staining, which is like a ropey or a thread-like pattern which is present between the cells as well as crossing across the cells. This feature was present here and there, And it was not very well-defined feature, but a kind of matrix was noted in between the cells. This is again a feature which was again a cluster which is showing a kind of matrix. Apart from this, so this is a metachromatically staining basalt-like material which was identified predominantly in the Giemsa stain smears, and it was present between the cells within the tumor fragments, and it was like either a ropey or a thick thread-like, ropey-like character, or in the form of thin threads. Then we could identify in some of the cells some kind of intracellular cytoplasmic, some granules were there, which was appreciated in the Giemsa stain. We can also identify in 1 or 2 smears intracytoplasmic, some material was present which was like a needle shaped, or we can say that it was a kind of crystal, but it was not very crisp, but there were few cells which were displaying this kind of crystals. Here is another cell which is showing intracellular crystal. So based on this finding, so to sum up, the smears were extremely cellular, predominantly scattered population, medium to large size atypical cells having round nucleus with occasional prominent nucleolus, with focal nuclear irregularities and abundant amount of pale cytoplasm, and also atypical mitosis noted. So based on these findings, the features suggested of a poorly differentiated malignancy. We could not categorize the histogenesis, but we broadly thought of the differentials like it could be a soft tissue sarcoma having a epithelioid morphology, which included epithelioid sarcoma, clear cell sarcoma, or granular cell tumor, or alveolar soft part sarcoma. Since it was a child, so we also considered the possibility of germ cell tumor or histiocytosis, or extremely rare but melanoma. So an excision biopsy and histopathology was advised, and we received an unoriented firm tissue piece of about 6 × 5 × 4 centimeter, and which revealed a tumor of about 4 × 3.5 × 2.5 centimeter. On histopathology, we find a well circumscribed a tumor which was disposed in some nodules, and it showed the classic nested arrangement of the tumor cells surrounded by thin fibrous septa. So we can see that this is a nested pattern of the cells having a abundant amount of cytoplasm, and the nucleus is showing a small nucleolus in most of the areas. However, at many places the nucleus is also not shown. And on pass after diastase stain, we could find some crystals present in these cells. And on IHC, we could find that TFE3 stain was positive in nucleus, and it was tumor cells were negative for PAN-CK, HMB45, S100, Desmin, and MyoD1. So this case was diagnosed as alveolar soft part sarcoma, which is a rare soft tissue tumor of uncertain histogenesis, which have a distinctive histomorphological appearance of variably discohesive epithelioid cells arranged in nests, and recently they have been found to have an unbalanced translocation between X and 17, resulting into a fusion protein of ASPS CR1 and TFE3. And immune detection of the C-terminus of the TFE3 protein is considered to be a diagnostic hallmark, but TFE3 can also be present in several other tumors. It can be identified in subset of PCOMAs and MIT translocation associated renal cell carcinomas. So I presented this case to highlight that it's a very rare tumor, and the cytological diagnosis of alveolar soft part sarcoma is difficult because one, it is a very rare tumor, and secondly, the cytological features are not very well defined. And however, the cytological reports in the literature have revealed certain features, which includes that predominantly these tumors, they show a dispersed cell population, and they are singly lying, and sometimes they can form some cohesive clusters, and also they contain some bare nuclei or strip nuclei. However, the tigroid background is not seen. The cytoplasm is abundant and it shows fragility, which sometimes result in a flocculent and a finely granular background. Also, sometimes we can find pseudoalveolar or acinar type of arrangement, and sometimes even alveolar pattern can also be shown by some of the authors. But very important feature which we identified a predominantly a singly scattered pattern, and these cells are of course of epithelioid type of cells. But the most important and a very interesting feature that was observed was the fibrillary metachromatic staining basement membrane-like material, which was present between the cells, and it was in the form of like a fine thread-like or a thick ropey-like substance which is seen attached with the cells. This might be the basement membrane-like material because the tumor is very extremely vascular and they contain several thin-walled blood vessels. Most of the authors have reported the nucleus to be round, and they lacking any irregularities, and they contain usually one macronuclei. Sometimes some intranuclear inclusions has also been observed. Another nuclear feature that some authors have identified is the nuclei exhibiting a concave irregularities, which has been recognized as a apple bite morphology, which is seen in histopathology as well as in HNE or wet preparations. The cells are having finely vacuolated to granular cytoplasm, and some authors have sometimes they have done the pass and after diastase stain, which is positive but not that frequently. Another important feature is the presence of magenta colored or pink coarse intracytoplasmic granules instead of the slender rod-like crystalline structures. So these were some features that has been described in the literature. So to conclude, we can say that these cells, which are a very large epithelioid having morphology, has the differential diagnosis of soft tissue sarcomas containing this type of morphology can be seen in epithelioid sarcoma, clear cell sarcoma, granular cell tumor, picomas, rhabdomyomas, and some non-mesenchymal tumors like germ cell tumor, metastatic melanoma, metastatic RCC, or even histiocytosis can show this type of abundant cytoplasm, and sometimes paraganglioma can also show this type of morphology. So, all these tumors, the sarcomas, which are most of them are of uncertain histogenesis or rare tumors, they are usually moderately cellular, and most of them they show single scattered pattern, and sometimes their clusters may be present. Bare nuclei is a feature that has been reported by many authors in alveolar soft part sarcoma, and presence of a macronuclei is also has been found to be a feature of alveolar soft part sarcoma. However, it is also seen in metastatic renal cell carcinoma and metastatic hepatocellular carcinoma, metastatic melanoma, etc. And the cytoplasm is abundant and finely granular, but there is some differences. Like in granular cell tumor, the cytoplasm will be finely granular or finely vacuolated. In the epithelioid cytoplasm, the epithelioid sarcoma, the cytoplasm will not be that granular, and the cells will be some spindling. They will show some kind of spindling. Then malignant melanoma, obviously they will show abundant basophilic cytoplasm, and the presence of pigments will clinch the diagnosis. Very rarely, normally paraganglioma will have a very small nucleus, but at times it can show nuclear atypia. And mastocytoma can show some bright eosinophilic granular cytoplasm. Rhabdomyoma, the eosinophilic or fine granular cytoplasm. But the most importantly, the intracytoplasmic granules and intracytoplasmic crystals, if they are present in about 10 to 20 to 30% of cases, and so if they are observed, they are very helpful for the diagnosis. Sometimes some authors have also reported the intranuclear inclusions. Another important feature is the basement membrane-like material which is present in between the cells. So, shall I present with the case 2?
I think we can then go to the second speaker.
It's a very...
you can, if you can complete it in 2 minutes, just rapidly.
It's a very small case. The second case is a 26-year male presented with a right testicular swelling measuring 6 into 5 centimeter for about 1 year. USG, it was a heterogeneous echo texture with foci of calcification, which suggested a feature of germ cell tumor. On cytology, this was the morphology. It was a very cellular looking morphology, but the cells were very evenly showing a very regular kind of round nucleus and abundant amount of cytoplasm, and in some area which showed very beautiful crystals of Reinke. So based on this, we gave that, and this is the PAP preparation, which showed a small nucleus and abundant amount of granular cytoplasm. On again, Reinke's crystal. This is very well discerned in the MGG stain. So the cytological findings were moderately cellular smear composed of sheets of polygonal cells with round nucleus, with small prominent nucleolus and an abundant amount of pale cytoplasm, and some of the cells shows presence of Reinke's crystals, which were pathognomonic of Leydig cells. So we offered a diagnosis of Leydig cell tumor. Subsequently, this patient underwent orchidectomy, which revealed a tumor, and on microscopic examination, it showed arranged in sheets, nodules, and trabeculae. These were spindle-shaped cells, and this was the morphology of these cells. So there were no other cells present in this tumor. So also identified some areas of necrosis, calcification, but crystalloid of Reinke's were not identified on H&E stain. So this case I presented to highlight that if identified, the Reinke's crystals are pathognomonic of Leydig cell tumor, and their visualization is important for the diagnosis of Leydig cell tumor. Preoperatively identified on fine, this is very well discerned in the fine needle aspiration cytology, especially in the air-dried smears. In smears, the crystals were numerous, and cytological examination appears to be a very effective way to reveal the Reinke's crystal. Thank you.
Thank you, Dr. Amrita. For the two cases, the first case brought out the fact that we as cytopathologists face problems in soft tissue sarcoma, making a diagnosis of soft tissue sarcomas. And the second case, of course, for the postgraduates for the Reinke crystals, they are very characteristic. Just a small question, did you do a PAS and a PS after diastase stain on the cytological smears in the first case?
No, we could not, at that time we could not do because we kept it a broad category, and we didn't aspirate it once more.
No, on the same smears that you had already prepared, the cytology smears, you could have done a PS and a PS after diastase.
We haven't done
because
it.
You saw some granular.
Yeah, we saw some granular. Actually, this literature also explains that the past and past diastase stains on cytology are not that good. Okay, thank you.
And in both the cases, you highlighted the presence of crystals,
Yeah.
which we have to look for.
Yeah, so I just based my presentation on morphology only.
Thank you. Thanks a lot. It was
Any questions?
Any questions from the audience?
Okay. Now we have the next speaker, Dr. Deepa Rani. She is a professor of pathology, SN Medical College, Agra, and she has a number of publications and presentations in her name. She graduated from Medical College, Meerut, and post-graduated from SN Medical College, Agra. She joined the medical college as lecturer in 2008, has guided 10 MD theses and co-guided many theses. She has presented a case of at UPCYTOCON and cytopathology several times. She has conducted workshops on soft tissue of head and neck region in UPCYTOCON 2022. She has been invited as chairpersons in several conferences, was the second runner-up of EPCON 2018 online quiz. She is a member of medical education at SN Medical College, Agra, currently joined the treasurers as IAC UP chapter. Her special area of interest is soft tissue lesion with emphasis on their cytology. Now, I would like Dr. Deepa to
Thank you so much, ma'am. Good afternoon, everyone. First of all, I would like to thank organizing team of UPCYTOCON 2023 who has given me the opportunity to present here. Now, I am starting with the case. 25-year-old male presented with a small nodular swelling on ventral aspect of left upper part of forearm. Swelling was 1 into 1 centimeter from last 1 year. It was non-tender, firm, and attached to the overlying skin. This is the clinical pic of the patient. A small nodular swelling presented on ventral aspect of left upper part of forearm. Fine needle aspiration cytology was advised. On fine needle aspiration cytology, the smears were hypocellular, comprising mostly of blood along with the small cellular aggregates and these singly dispersed cells. On hyper view, we can see the oval to spindle-shaped cells appear to be originating from a single point. This is another hyper view. We can see beautiful fibroblast, histiocytic giant cell. In another view, we found this histiocytic giant cell, histiocyte, and another this fibroblastic cluster, and these are the histiocytes. In this another hyper view, we can see that these fibroblasts, histiocytes, and macrophages are admixed with these inflammatory cells, lymphocytes. So, with the clinical picture in mind, that a small nodular swelling of 1 year duration, and on cytology, we found fibroblast, histiocytes, macrophages, histiocytic giant cells, and lymphocytes. So, what the diagnosis we should think of? We have given the cytodiagnosis of dermatofibroma. Histopathology was advised. On histology, a small nodular swelling, skin-covered piece of tissue was received. Cut surface is grayish-white, and it is a well-demarcated lesion. Microscopically, it was we found the hyperplastic stratified squamous epithelium. Subepithelial tissue shows fibroblastic cells arranged in a vague story-form pattern. This is the fibroblastic histiocytic cells admixed with Toutoun-type giant cells and few scattered lymphocytes. So, histodiagnosis was confirmed as dermatofibroma. On immunohistochemistry, the tumor cells were CD10 positive. CD34 was negative. It was done to rule out DFSP, which is CD34 is positive in DFSP, and CD34 is seen in blood vessels. S100 was negative. So the differential diagnosis includes a variety of spindle cell lesion. First of all, dermatofibrosarcoma protuberans, cutaneous leiomyoma, neurofibroma, schwannoma, nodular fasciitis, and some adnexal tumor. Dermatofibroma should be distinguished from DFSP. Dermatofibroma is usually less than 1 centimeter, while DFSP is more than 1 centimeter. In dermatofibroma, we found oval to spindle-shaped cells with mild pleomorphism admixed with few lymphocytes, histiocytes, and histiocytic giant cells, while in DFSP, oval to spindle-shaped cells which are monomorphic or mildly pleomorphic. Dermatofibroma is a symmetrical lesion, while DFSP is a asymmetrical lesion. Symmetrical lesion means if we draw an imaginary line from the tumor in the tumor margin, they are mirror image of each other. This is because as dermatofibroma grows, it pushes the adnexal structures towards the periphery, while when DFSP grows, it entraps the adnexal structures. Epidermis is hyperplastic in dermatofibroma, while in, it is atrophic or there is no change in case of DFSP. In dermatofibroma, mitotic figures are uncommon, while mitotic figures are seen in DFSP. CD34 is negative in dermatofibroma, while it is positive in DFSP. CD10 is positive in dermatofibroma, while it is negative in DFSP. This is the cytological images of DFSP. We found cellular aggregates as well as dispersed cells. And cells are monomorphic to mildly pleomorphic. They have finely granular chromatin and indistinct cytoplasm. This is the classical storiform pattern seen in case of DFSP. This is a gross picture of DFSP, and in DFSP, epidermis is usually atrophic or normal, while in dermatofibroma it is hyperplastic, and a beautiful storiform pattern is seen in case of DFSP. In this image, we can see that DFSP appears to be infiltrating into the underlying adipose tissue. CD34 is positive in DFSP. Now, another differential diagnosis is cutaneous leiomyoma. Dermatofibroma is skin colored to brown, smooth plaque, nodule or polyp, while cutaneous leiomyoma, it arises from erector pili muscle as a small pink papule. Cutaneous leiomyoma is painful, while dermatofibroma is painless. In dermatofibroma, we find admixture of oval to spindle-shaped fibroblast with lymphocytes, histiocytes and osteocytic giant cell, while in cutaneous leiomyoma, blunt-ended, elongated or truncated nuclei are seen. This is the clinical image of cutaneous leiomyoma, small nodular swelling. On a fine needle aspiration cytology, smears were very hypocellular. This is the only cluster which we found in slide, and the cells are oval to spindle shaped, having blunt-ended oval nuclei. Histopathology reveals these longitudinal sections as well as transverse cut, and it is Desmin positive. Another differential diagnosis is neurofibroma. In neurofibroma, myxoid background is usually present, while in dermatofibroma, it is absent. In neurofibroma, dispersed cells are more common than tissue fragments, while in dermatofibroma, cells are dispersed as well as small cellular clusters are seen. Elongated nuclei with pointed ends and few fibroblasts in fragmented fibrillary matrix are seen in case of neurofibroma, while in dermatofibroma, fibroblasts are admixed with lymphocytes and histiocytes. This is the cytological image of neurofibroma. We found these elongated spindle cell nuclei in a neurofibrillary background. Now, another differential diagnosis is schwannoma. Dermatofibroma is usually painless, while in schwannoma, sometimes radiating pain on needling is seen. Schwannoma में numerous tissue fragments, rarely single cells are seen, while in dermatofibroma, dispersed cells as well as cellular aggregates are seen. Admixed population of fibrohistiocytic cells, while in schwannoma, elongated wavy nuclei with pointed ends. And nuclear palisading is present in schwannoma, while in dermatofibroma, no such nuclear palisading is present. This is the cytological image of schwannoma. In schwannoma, we found these tissue fragments. And the oval to spindle-shaped elongated nuclei, this is the neurofibrillary background, and this is the nuclear palisading seen in case of schwannoma. Now, another differential diagnosis is nodular fasciitis. Nodular fasciitis, it is a rapidly growing lesion and there is short history. While in dermatofibroma, it is a slow growing lesion and there is history of long duration. It is dermal in location, it is subcutaneously located. It is a fibrohistiocytic tumor, while nodular fasciitis is a fibroblastic, myofibroblastic tumor. Dermatofibroma has generally low cellularity, while nodular fasciitis has high cellularity. There is abundant myxoid matrix and there is no myxoid background in dermatofibroma. This is the cytological feature of nodular fasciitis. See, highly cellular smear comprising of fibroblastic, myofibroblastic cells embedded in a myxoid background matrix, showing moderate anisopoikilocytosis. Binucleate cells and trinucleate cells are frequently seen in case of nodular fasciitis. Another differential diagnosis, which is are adnexal tumors. This is a small nodular swelling present on the neck. On fine needle aspiration cytology, we found these epithelial cell clusters. So it was reported as adnexal tumor, benign adnexal tumor. On histopathology, it came out to be benign nodular hidradenoma in which cytokeratin was positive. So the take-home message is dermatofibroma is a benign, well-demarcated tumor, occur typically in adults. It is painless and found most often on limbs and trunk and measures between 0.5 and 2 centimeter in diameter. They are skin colored to brown to purple, smooth plaques, nodules or polyps surfaced by skin. Some lesions have central dell. Aspirate contains low cellularity, oval to spindle-shaped fibroblast in dispersed or small cellular aggregates, inflammatory cells, lymphocytes and histiocytes, giant cells of Tootone type and sidrophages. These are the references. Thank you so much for your patience hearing.
Thank you, Dr. Deepa. The case was very interesting.
Thank you.
And I think everybody enjoyed the cases. Any questions? And it was well finished in time, so we have time for questions also. Yes, yes, sure, sir. We would be happy to. And maybe you can throw some light on the cases. Thank you.
Thank you, Dr. Deepa. That was really nice. I think it is very important for these benign lesions to be picked up, and they are so common. Thank you so much for the case.
Thank you,
Any
ma'am.
questions? Do we have any comments? Okay, thank you.
Thank you, ma'am.
Thank you so much, ma'am. Now I request our chairpersons to please give memento to our speakers. Dr. Deepa Rani, ma'am. Now I request our chairpersons to please give memento to Dr. Amrita Ghoshkar, ma'am. Now I request Dr. Seema Sharma, ma'am, to please give memento to our chairpersons. Now I request everyone to please proceed for lunch at Banquet Hall ground floor, and we will resume with our next session at 3 p.m. And I request everyone to please be back on time, and as we are already lagging. Thank you.
Now that everyone is recharged after a sumptuous meal, we shall proceed with our next set of session. For that, I would like to invite Professor Seema Sharma ma'am and Professor Rajiv Garg sir to please join us on the stage and chair the session. Dr. Seema Sharma ma'am is the Professor and Head Department of Pathology, SGPGIMS. Ma'am is particularly interested in lab hematology and hematopathology. Ma'am has been a member of various national and international society reviewer of various national and international journals. Dr. Rajiv Garg sir is a Professor, Department of Respiratory Medicine, KGMU, Lucknow. His research interest included diffuse parenchymal lung diseases, lung cancers, and tuberculosis. He has been awarded Fellowship of National College of Chest Physicians, Indian Chest Society, Indian Association of Bronchology, and has been associated with many ICMR-funded research products on tuberculosis and lung cancer. First we have a talk by Dr. Dipali Jain ma'am, who will brief us about the WHO 2020 classification of lung cytology reporting system. I request our chairperson to please introduce ma'am to us.
Good afternoon, everyone. We are going to start the session on WHO 2022 classification of lung cytology reporting system. First, I would like to thank the organizing persons, especially Dr. Madhu, for inviting me here. Dr. Dipali, I invite you to the dais. Dr. Dipali Jain is professor in Department of Pathology, AIIMS, New Delhi, and she has numerous publications, more than 350, and so many presentations, and she has received very numerous national and international awards, including editorial board member WHO classification of thoracic tumors and lung cytopathology. And she has also received Talented Young Pathologist Award, IAPM Delhi chapter, and Young Researcher Award, Tata Memorial Trust. And also she has received many national and international travel grants and fellowships. And her main area of interest is cytopathology, thoracic pathology, and sinonasal cancer. So, Dr. Dipali, we would like to hear you.
Thank you, ma'am.
Without any delay.
Thank you, ma'am, for kind introduction. And I would like to first thank organizing team for kind invitation. And with that, I will start with WHO reporting system for lung cytopathology. So in these 25-30 minutes, I'm going to talk about this newly introduced WHO IAC reporting system for lung cytopathology, and then I'll be showing you some rare cases, which is excluding non-small cell and small cell lung cancer, which we see day in, day out. So I have excluded those and taken some rare cases in routine practice we encounter, and what is their categorization according to WHO and IAC classification. So it's not that we did not have any reporting system for respiratory cytopathology. We did have in the form of Papa-Nicolau Society of Cytopathology and Japanese Lung Cancer Society, etc. But they were actually confined to their places of origin. So we didn't have so far any international or global reporting system which everyone can implement in their labs or practices. So for that, WHO, which we know IARC, that is International Agency for Research on Cancer, they shook hands with the International Association of Cytopathology, IAC, and then they collaborated, and then they made these systems, out of which 4 are already published, either hard copies or in beta version, and they are other ones are in preparation. So we'll get them soon. So in this talk, we'll be focusing on lung cytopathology. Inclusive to WHO reporting system, if we compare other reporting systems like Papa Society and Japanese respiratory cytopathology, exclusive to WHO, is that in these books they have emphasized the importance of cell preparation techniques, how you sample, how you receive the samples, how you should proceed with preparation, what preparations, and important and unique feature of WHO classification system is that they have taken everyone into consideration, including low and middle income countries where lab resources and infrastructure is not so well established, so they have not set recommendations only for resourceful countries. So they are kind of flexible in their recommendations that anybody or everybody can use it as per their lab resources and infrastructure. So it suits everyone, though it should suits everyone. So, and then second thing is that the key diagnostic cytopathologic features of each lesion found in each category, that is also given in these books and classification. And they have provided best practice recommendations for use of immunocytochemistry on cell block as well as on non-cell block cytology preparations, in situ hybridization and molecular techniques in respiratory cytopathology. So these are few things which are just unique to WHO reporting system. They have talked about every specimen preparation which we have in respiratory cytopathology, ranges from exfoliative to abrasive to FNACs, excluding thoracentesis or effusion specimens, because we already have international system for serous fluids reporting system. So that is why effusions you won't find here, but other preparations and specimens are taken into consideration. And then, as I said, that they have, given recommendations as per your lab, setup. And when the sample is acquired, you can process it in many ways depending on whatever infrastructure you have. And out of all the preparations, cell block is always being emphasized upon. So in cytology, what all preparations at the end we are going to have is these many. We can have cytospins, we can have direct smears, cell blocks, and LBC preparations. And ROSE is always a preferred modality. If you can do it, it's always preferable, so that you can ascertain adequacy and accuracy of the specimen at the point of care. So these are the categories as we have already been seen in different classification systems across all body sites. They are nothing different, so it starts from insufficient and then going to malignant. Here in this particular classification, they have said that you use descriptive terminology rather than a number. As we have seen in Bethesda and urine and other classification systems, there is a category 1, 2, 3, 4, 5 and so on. But in lung cytopathology, they emphasize that rather than a number, because it may switch, from one to another number. So rather than going by number, you just give a descriptive category. And these are estimated range of malignancies across all the benign. So benign in respiratory cytopathology is rare if you compare with malignant lesions. So in our country, it is still, we have a lot of tuberculosis, so granulomatous lesions and infections. But otherwise, if you see neoplastic lesions, they are very, very rare and uncommon if you compare with the malignant lesions. So these are all benign tumors they have classified and categorized in this classification. ATPI and suspicious for malignancy, we know for years together now, ATPI is when you are not sure whether it is benign or malignant. Suspicious for malignancy when it is either quantitatively or qualitatively insufficient to say this is malignant or not. So those are same things. And then there is a whole list of malignant tumors which they have described. So anything which is not able to answer a lesion in question under imaging, so that is insufficient or inadequate or non-diagnostic. So the recommendation is that you can choose either of the terminology out of these, but be sure that your clinician should be familiar enough with those terminologies. So stick to one category, one terminology, either you say insufficient or inadequate or non-diagnostic. For example, this is an EBUS FNA from lymph node, so you would expect some lymphoid tissue, but if it is not, then you can say this is category insufficient. So any low cellularity specimen, poorly prepared, poorly fixed, poorly stained, they all come into this category. And when we have diagnosis and it is not neoplastic, then you can say this is benign category, for example, well-formed epithelioid cell granulomas, and you can even give a diagnosis of tuberculosis if you see a lot of acid-fast bacilli. So this is category benign. atypia, if you have without any clinical or imaging, findings, if you find this single cluster of these monolayered cells, then you can say this is atypia, because it can be well differentiated adenocarcinoma, lipidic predominant adenocarcinoma, or it may be something else. So you have to talk to your clinician, see what is the radiology, and then only you can decide on, diagnosis or category. So this particular case is category atypia on cytology, and when it was resected, it was on radiology as well as on gross. This was a well-defined tumor nodule, and this was around 3+ centimeter. And this is the morphology. Anyone can offer any diagnosis. So this tumor has a lot of hemorrhagic areas, fibrotic, stroma, and then these papillary nubbins. So this has two types of cells, surface cells, deeper cells. So imagine, if these cells come into cytology, they would exactly look like, single monolayered cells, those small cuboidal cells. And cytologically, they look alike, like lipidic predominant adenocarcinoma, but this is nothing but, anybody? So this is TTF positive, both type of cells, surface cells and deeper cells. So this is sclerosing pneumocytoma. I have not written here, I think I missed it. So this was a case of sclerosing pneumocytoma. So it's a very rare benign tumor. If you get in cytology, talk to your clinician. If they are also sure this is a benign tumor, then it is fine. You can go from atypia to benign. But if it is not, then you have to go for atypical category. So atypia categorization also holds true for reactive changes, infections. If you get COVID specimens in cytology, you will be, they look fairly alarming. So in those cases, you can say this is atypia. This is pleural effusion cell block. You are sure that these are malignant cells, but quantitatively they are less. If you have to see, tumor fraction, it's less than 5%. So you would go for suspicious for malignancy, because they are qualitatively malignant, but quantitatively they are less. So this is suspicious for malignancy, whereas this is a bona fide case of adenocarcinoma, which is also positive for EGFR mutation, and they are, quantitatively as well as qualitatively, they are, the malignant clusters. So this is fine. This is category malignant. And now then in this particular classification, they have emphasized on incorporation of ancillary studies and reporting systems. So by doing that, you may change the category. For example, this particular case where we have said this is suspicious for malignancy because of less number of tumor fraction, but if you stain it for ALK IHC and suppose those few tumor cells, show up or blow up on the immunohistochemistry, then you are sure that this is ALK rearranged lung adenocarcinoma. So you may change your category from suspicious for malignancy to frankly malignant, and in a proper clinical and radiological setting. So this is a list, how WHO wants you to report, starting from the demographic information of the patient, from type of specimen to clinical imaging information. So as much as information you can give in that report, including ancillary studies and which block or which preparation you are using for that ancillary study, and so on. This is a picture of editorial board of thoracic pathology, which was, this was only meeting which happened physically in 2019, and after that everything, shut off because of COVID, and everything was on Zoom. So this was the only meeting which happened physically. So with that background, I show you some rare cases in which how we categorize if you have to categorize them according to WHO IAC categories. And remember to note that categories may change. If you on just morphology you may think some other category, and if you see radiology, if you talk to a clinician, the category may change. So that is what is very important, to have clin rad and microbiology correlation. So in these cases, I'm going to show you some spectrum of benign to malignant spindle cell tumors, some new entities, and rare encounters. So as I said, I'm now going to show you non-small cell and small cell lung cancer. So this was a 54-year-old man who has a pleural nodule. Can you make out on X-ray? This is a very faint shadow which is present in this picture. So since this was superficial, big enough, they poked the needle and they did USG guided FNA. On cytology, we did not have material to do to make cell block and perform ancillary study, and this was a pleural-based nodule, and this is a cluster which was embedded in magenta-colored stromal matrix, and these are spindle cells. So if you don't have radiology, you see this type of cluster that is also in very rare location like pleura, you would say that this is atypical. I'm not sure whether this is benign or malignant, but if you see the radiology, it was a well circumscribed, and clinically and radiologically they were thinking this is not a cancer thing, it's looking like benign. Then you may choose to go for benign. Okay, so that is what has been done on this case. We talked to the clinician and they said that this is this looks benign on radiology. In report we said radiological correlation is advised, and we did not perform any ancillary studies. So if we talk about spindle cell tumors, even in WHO as well as at other places, we have heard earlier presenters also, the differential diagnosis ranges from benign to malignant. So it's not very, it's not very hard and fast in cytology that you cannot make a differential diagnosis of malignant in benign case and vice versa. So cytology has its own limitations. So that is what has been given in WHO also. Spindle cell tumors comes in benign, comes in malignant, and then you have to sort it out. So this was a guided biopsy of this case, USG guided core needle biopsy. It was very cellular, juicy, and it has cellular and hypocellular areas, and this is diagnostic. Anybody can propose? Yeah. So I want residents to just wake up, and interact. Okay, so this is Verroque body. We know hyalinized blood vessels in the background. So this is schwannoma, but at a rare location of pleura, you would not think of schwannoma on cytology, right? So even if you go atypical, that's perfectly fine. So this was schwannoma, S100 positive. You can see diffusely positive. SOX10 was positive. So this was schwannoma and benign diagnosis. Okay. So this is spindle cell neoplasm on cytology and schwannoma on histology. This was case 2, who is 50-year-old man. EBUS aspirate was done from left lower lung mass, and pap stain smears and cell block was there. This was fairly cellular smear. You can see juicy fragments, cohesive as well as discohesive, and these are the cells which are very plump. They are ovalish to spindlish and discohesively present, very cellular, some epithelioid appearing cells. So since this was predominantly spindle, it is again spindle cell neoplasm. And categories we have to decide. So again, I'm showing same slides. You can go benign or malignant, but this was radiologically, it's a very big lesion, unlike the previous one. It was 9+ centimeter mass, which was pleural based and PET avid, and they were sure this is cancer. So in those cases, and on cytology, it was pretty cellular. So you can, go for suspicious for malignancy. So that is what has been done on this case. Suspicious for malignancy in ISC was advised. So on smears, we did not do anything, but this is a juicy cell block of this, which was taken out from the needle of EBUS TBNA, and this is again showing very cellular tumor, and on higher magnification you can see pinpoint nucleoli, and they are there is an isonucleosis. They are kind of anaplastic cells. We could spot some mitotic figures as well. So now the thing is that spindle cell lesions or tumors in lung mediastinum, they again ranges from benign to malignant, lot of tumors. But which tumor is this? So since it was pleural based and they were thinking this is mesothelioma, CK and EMA were negative. So virtually rules out thymoma and carcinoid because they are the top differentials in spindle cell neoplasm. Calretinine and D240 were positive. So the consideration was that is it sarcomatoid meso? Ki67 was high, so it was malignant on morphology as well as on this thing. So BCL2 and TLE3 were positive. So anything? Synovial sarcoma, right? So this was synovial sarcoma, again a rare diagnosis. It was confirmed on SSET in translocation. Okay, and this is a resected specimen because it was a well confined, so they resected it out. There was no history of any prior primary, and you can see this is well circumscribed. This is lung parenchyma, and the same areas which you saw on radiology, they were there on the resected specimen, epithelioid to spindle and so on. So this was monophasic synovial sarcoma. They have given the cytopathologic features, etc. But the key thing is that you have to take everything into consideration before putting these categories on these tumors. So this was malignant spindle cell tumor. Other tumors can be type A thymoma, is also very organoid, can be very spindly, and then you can have a diagnostic dilemma on cytology. Spindle type A thymomas, where you don't see any lymphocyte or thymocytes, but they are CK positive, they are P63 and PAX8 positive. So this is another case of type A thymoma. So I still have 2 minutes. Okay. So this is case 3, which is 75-year-old woman, smoker, and then there is a left lower lobe lung mass, which is query carcinoma lung. So if you don't, if you delete radiology from clinical requisition forms, more than half of the, clinical requisition forms have differential diagnosis of CA lung and tuberculosis. That's all. If you don't talk to them, you will be always, seeing these requests that this is CA lung or this is tuberculosis. Okay. So this was the imaging where you can see this is a well-defined mass which is present in the left lower lobe of the lung. You can see this asterisk here, and this is the mass, and this is the cytology. So this was bronchoscopic brush. We did not have, again, any material to perform any ancillary study, but you can see these cells, they are wandering here and there. Some of them are plump, some of them are oval, round, and this and that, and this is impossible to make a definite diagnosis without doing any ancillary study. So it's fine, it's perfectly fine. You can go category A atypia, when they are suspecting carcinoma lung, okay, and if you go into detail of radiology, they would say this is a well circumscribed, and there is no speculations, there is no necrosis, this, that, and they are thinking of benign. You can say this is benign, but on morphology they look quite plump, so you can go from benign to atypia. Okay, so radiological correlation again was advised in this, and they have a lot of cytoplasm, right, and they have some clearing of the cytoplasm as well, and since this was bronchoscopic brush, some threading, some smearing artifact was there. So this was the morphology, which I don't think I could make on just cytology smears. So this was a CT-guided biopsy, because we said this is inconclusive, we cannot offer a definite diagnosis. So CT-guided biopsy was done from that particular mass, and you can see this is a richly vascularized tumor, and then these are the tumor cells which we saw on bronchoscopic brush. They are large cells, they have a lot of cytoplasm, somewhere they have clearing in the cytoplasm that you can see in histology as well. Okay, and these are epithelioid cells, clear granular cytoplasm, pan-CK, TTF1, napsin A, PAX8 were negative. Any diagnosis? This has a tumor which is well circumscribed, okay, clinically, radiologically benign. You have this morphology with clearing of the cytoplasm. All these stains are negative. So I would do HMB45 in Milan A, and they were strongly and diffusely positive with expression of myeloid and melanocytic markers. So melanocytic markers are these, and myeloid markers were also positive. So what is the diagnosis here? So this is PCOMA. PCOMas on imaging, they are solid, solitary peripheral lung nodules. They were earlier known as sugar cell tumors or clear cell tumors, and virtually all primary PCOMas of lung are benign and cured by excision. Okay, so this was benign and quite challenging on cytology. Okay. This is case 4, which is, there is a right paratracheal mass and EBUS was performed. This is coming out from the neck, and then going into the paratracheal region from where the EBUS FNA was done. So we did not have any information when we got the cytology EBUS FNA slides. Okay, so this was coming, this came when we had a dialogue with pulmonologist and found out, okay, this is that easy for them, and we were struggling on slides. Okay, so this is the cytology where you can see this is, organoid tumor, which is very juicy, trees and trunks and branches and so on. You can see everything on these smears, right? And if you zoom in further, you can see some monolayered sheet and these fragments, right? And here, as if they are, any diagnosis? You have seen radiology. We have not, at that time, we had not seen radiology. So they were looking like macro follicles, as if they are monolayered sheets of follicles, right? And some thin material, some thin fluid-like material in the background. So, so this was category benign to atypia, depending on when you had a dialogue with your clinician or not. So if I show you the next slide, you will say, Eureka, this is so easy. This is so easy, okay? So on cytology, you may struggle because this may be neuroendocrine tumor, this may be parathyroid neoplasm, this may be just simple thyroid follicle. So without having any history about this, and when we discussed with the pulmonologist, he said, yeah, I know this is retrosternal goiter because the thyroid was coming down to the mediastinum and we poked that mass. So without that, it is very difficult. We were struggling whether it is neuroendocrine tumor or what is going on, it is carcinoid or what. So that is what I'm saying. I mean, you can go from benign to atypia depending on what is your triple test telling. Okay, so just 2 more slides. New entities I'm not going to cover because of the time restrictions. Nut carcinoma is one of them, where you can see combination of squamous cells and primitive appearing basaloid cells, and this is called as abrupt keratinization. When you have this kind of tumor in a non-smoker patient and in a young patient, okay, and this is quite PET avid, it's blowing like a Christmas tree, okay, and when this is sampled and you have this combination, don't make squamous cell carcinoma in a young and non-smoker patient, okay. Think about nut carcinoma, and this particular case was positive for nut IHC, so this is a new entity. I mean, not new entity, it was earlier known as nut midline, but now it is realized that this is not a midline restricted tumor, it can occur in any body site. So nut carcinoma of thorax and nut carcinoma in both Blue Book and Purple Book, it has been featured. And second rare or new entity is thoracic SMARCA4 deficient undifferentiated tumor, which is very, very poorly differentiated. Until unless you have a high index of suspicion or you know about this particular entity, you will not be able to make this diagnosis because they are negative for everything except for BRG1, which is lost in these tumors. So these tumors are also featured in both WHO 2021 and WHO 2022 Blue and Purple books. So summary, this is new thing, okay, WHO reporting system for all the reporting, all the body sites is a system for categorizing cases to provide uniform information to clinicians at a global level, and it assists them in making correct management decisions, and it will evolve because we don't know what is the range of malignancy because they are already, previous publications, so it is a process, continuous process, and we will get to know more about, when we apply or when we implement this WHO classification system in our practice. So with that, I thank you for your attention, and this is my recently published book, so I just have a privilege to advertise this for residents. That is all. Thank you.
Thank you,
I'm
Deepali.
sorry for exceeding time.
No, it's always a pleasure, Deepali, to listen to you in the conferences when we meet, and it's a pulmonologist conference. I know the whole objective of this classification is to have, say, common communication and standardized communication, and for the improvement of the cytopathological standards and the better communication between a clinician and a pathologist. Sure. Yes, we do come across the surprises, and the time has gone where only the morphological diagnosis was the things. And believe me, it's very gratifying when you give, now it's a time of the precision medicine. When we do is, we don't say stop only just getting a report of, say, adenocarcinoma. We still want what it is.
Right.
So that, and when you see the patients, the survival has improved a lot in the lung cancer patients. So if after this, I think the residents must take this opportunity to interact with the wonderful speakers who have come all the way from different parts of the country. Any questions from the audience?
Any questions from residents? Want to clear any doubts?
They understood so well.
After a lunch, a sumptuous lunch, it's hard to make them awake.
Everyone is sleepy or want to ask any questions?
No, they are not sleeping.
Okay, thank you.
Thank you, ma'am. Thank you, sir.
Okay. The second speaker is Dr. Atul Gupta.
Thank you so much, ma'am, for such a crisp overview of lung cytology. Now I request our chairpersons to please introduce our second speaker, Dr. Atul Gupta, sir.
I invite Dr. Atul Gupta, who was professor and head department of SN Medical College, Agra. He is a histopathology consultant at a private center currently. He has more than 50 publications to his credit and has several presentations at different podium. And he is to his credit, he entered in, say, SN Medical College, Agra in 71 as an MBBS student and passed MD Pathology in December 79 from the same institution, and subsequently was a tutor in pathology department at AIIMS New Delhi, was a pool officer there at SN Medical College, Agra, joined as a teaching faculty in SN Medical College, Agra, and started FNAC service in the Department of Pathology in SN Medical College,
Agra. He was observer in pathology department and Tata Memorial Hospital. He also worked at Tata Memorial Hospital, Mumbai in 1990, 1992 and 1997. He has, to his credit, Best Paper Presentation Award in UP chapter of IAPM in Aligarh, awarded Best Teacher in SN Medical College, Agra in 2017 and 2016, and served as an Executive Council member of Indian Academy of Cytologists. Sir, podium is all yours.
और मुझे पॉइंटर ये है, ये बता. Thank you, doctor. Just a moment, please, while I familiarize myself with this. ये किस तरह से? ये है next है ना? इससे है और ये है पॉइंटर. Okay. Okay, so good afternoon, everybody. And we just had a great presentation, and now my turn. And it's at the grassroots level, number one. So it is at the very base. There will be mostly morphology and very little of the molecular stuff, etc. Well, the talk, thyroid FNA, is like a vast expanse, and this is Loch Ness, which is a lake but is longer than the British Channel, English Channel, 25 kilometers approximately, and I am supposed to navigate through this in the next, well, 30 minutes. I was initially told 45 minutes, but no problem. I just want to ask permission for one thing. Can I mix it with Hindi? Everyone is familiar with Hindi, अपनी भाषा मातृभाषा, ठीक है, चलिए, थोड़ी रफ्तार बढ़ जाती है and comprehensibility भी enhance हो जाती है. So, okay, and I am the monster out here, Nessie, the Loch Ness monster. Since I rarely complete my presentations, so I do the last things first, which is the acknowledgement part. And right at the outset, I would say that I am very grateful to be invited here and to be given a chance to stand before all of you. I must thank my patients who have enabled me to reach where I am. And additionally, for preparing this presentation, Dr. Deepa deserves a big hand. And if any error is there, it is on her part. And I stand absolutely cleared of that. And Dr. Anupam Varshni has helped. He is not here. Okay. And since the thyroidectomy is likely to be incomplete, I have given my mail address. So if you are interested, we can do a completion thyroidectomy later on. I begin here. I didn't want to show this, but this is 221B Baker Street. 221B Baker Street is famous because Sherlock Holmes used to live here, at least in the books we have read from Sir Arthur Conan Doyle. And remember, the role of a pathologist is quite similar to that of a detective. Sherlock Holmes represented a detective, the epitome of excellence. And what he did was he solved the mystery and then passed it on to the administration for sentencing or whatever. And this is what we also do. We solve the mystery and pass it on to the clinician to do whatever, sentencing or otherwise. So, okay, and my talks are always directed towards the junior faculty and the residents. I hope I have at least 20 or 30 of them at the back. हाथ खड़े करेंगे कृपया? अच्छा हैं, गुड. तो आप पीछे क्यों बैठे हैं? आप मेरी आवाज़ टेस्ट कर रहे हैं क्या? आई विल डेवलप अ लेरेंजियल नोड्यूल. आगे आ जाइए, ठीक है? रिक्वेस्ट, नॉट अ कमांड. ओके, so he represents the epitome of excellence, and I do hope that you all should fall into the habit of practicing excellence. Excellence, remember, and this is not what I am saying it now, but it was said by someone else. Excellence then is not an act, but a habit. So you have to fall into that habit, and without realizing, you will pursue that. So for utility of thyroid FNAC, what we are doing, we should understand. Somehow I get the impression, I am sure you also get the same impression, that this is geared towards a tumor, detecting a tumor in the thyroid. The Bethesda 6 categories, the first 2 are not devoted to tumors, the other 4 are devoted to tumors. Well, this is not exactly correct as far as the thyroid goes. Yes, we are obsessed with tumors, but in diffuse goiters also, non-tumorous entities, it proves diagnostic. Hashimoto thyroiditis, yes. Subacute thyroiditis, yes. Primary hyperplasia is a big no-no, though we tend to fall into the trap of making a diagnosis there. I just want to talk a little bit about Bethesda. Now, Bethesda is what? It has 6 categories, etc., etc. But people have this mistaken notion that it is a way of learning cytology. No, it's a way of expressing your knowledge and diagnosis in cytology. So that's important. Just as you can look at surgical pathology, you report and you can adopt a synoptic format. So similarly here, you have to know your cytology very, very well, and then when you write the report, you can categorize it into one of these 6 categories. Oh my God. Already. And another advantage of using, at the end you should use the Bethesda. Why? See, this is the risk of, so sorry. And how do I go back? I don't know. Well, anyway, none of the categories has a 100% risk of malignancy. So when you write it is papillary carcinoma, fine. But the moment you add a category to it, category 6 for example, still you have a chance of making an error 3% or 4%, largely due to NIFT-P. So it's a good excuse for a pathologist to have. The first part, and see, mostly I'll just roll through the technical part, but it is very, very important. If you have a stillborn slide, lame duck slide, you won't be able to do anything with it. So 9/10 of making a correct cytologic diagnosis depends on the information. The buzzword, the keyword is information. Information gained from history, information from physical examination, and the second thing is the quality of the specimen submitted. Rollins 1991. Here now to the information we can add now imaging characteristics, diffuse, solitary nodule, dominant nodule, calcification, cystic cum solid, thyroid function tests, subacute thyroiditis, primary hyperplasia, both of them are easily, at least have characteristic findings in thyroid functions. And then you can add the serology for antithyroid autoantibodies for autoimmune disease. The quality of the specimen is most important in the thyroid. The procedure is a bit different. I'll just summarize it by saying it's a hit and run procedure. Within 5 seconds you hit and get out and draw the smears. Smears should be thin. And if they are thick and they are air dried smears, the detail will be lost. Use a hairdryer to dry it. And then run away and get good fixation. Good fixation means it should be the Ganga Jal type of methanol. The methanol should be changed very frequently, and I reserve my best methanols for lymph node aspirates and for thyroids. Results, it's good, that's what I can say. Some areas where you can get trapped. One, if there is a lot of necrosis in a tumor, then it invites a neutrophilic response, and you can be misled into calling it an inflammatory lesion. Anaplastic carcinomas have this tendency to undergo necrosis and lead to neutrophils, and so be careful about them. Imaging guidance can help you in selecting a viable area. And the other thing is, of course, cytology is bugbear in thyroid, cystic lesions. Because a cyst can conceal a small solid nodule, and if you go blind, you have an overwhelming chance of missing it. Even if you do a guided FNA, you may still miss it. So, and all of our categories, the category 3 is largely because of this. Category 2 has category 1 has 2 parts, one of which is devoted entirely to this cyst fluid only. And I had quite a few cases which I have subtracted because of the lack of time, where one aspirate showed something else, cyst fluid, and the other aspirate gave a different picture. So I think I must speed up. Dr. Deepali went helter-skelter. Yes, okay. Ancillary technique stuff. Now, ancillary techniques are required mainly for category 3 lesions, where the pathologist has said no to the clinician. He doesn't know what to do, and so what does the clinician bank on? He banks upon the imaging findings, he banks upon the clinical to make a decision. And the pathologist can provide him with something else, one of 4 things, and that is the genetic testing. Exorbitantly priced, so you have to watch out for that. I think all of us know that RET PTC is associated with papillary carcinoma. So if you can do that on the fluid or aspirate, fine, but it has a very low sensitivity. And hence, there was a battery of molecular tests which were consolidated into the Afirma GEC, gene expression conditioner test, in which they added the other ones also. But the result was that sensitivity was quite high, but specificity fell down. And so they use it, and in cases which are difficult, the first thing you do in a category 3 FNA is that you repeat the test after a few weeks or months. And only 10 to 30% of cases of category 3 remain category 3 after repeated FNA. And then to further add to that, we have the Afirma GEC, and it helps because if you have about half of all cases of category 3 have a positive gene Afirma, half are approximately negative. And if you have a negative gene Afirma, then it tells you that about only 5% risk of this being malignant. If the gene Afirma is positive, there is a 25% of risk of malignancy. So you can go ahead with surgery if the clinician feels so. With a negative test, it's unlikely to be malignant. And now I'll go at the cases. Case 1 was a 23G196. This is a 26-year-old female, right thyroid swelling, 2 years, solid cystic, 4.8 into 3.2 centimeters. And that's the swelling which one can see on the right side. Next. What is this, postgraduates? This is obviously some fluid, looks like serum. But watch out, you have these lines. And within these lines, there are very light staining areas. These are lacunae, and they tell you that this is thin colloid, not serum. So we have got colloid. And next, we have thick colloid here. Next, we have got cells. And what do these cells show? Very uniform cells, uniform nuclei, round nuclear membrane, no nucleoli, no grooving, no inclusions, syncytium-like appearance, at least in the lower ones, and frayed cytoplasm, the edges. So this is characteristic benign cytology. And another area from the same case, and what does it show? Apart from the colloid, there is some pink stroma in which numerous follicles are suspended. And these are intermediate sized follicles. Another area to show you fire flares. Remember that fire flares do not signal primary hyperplasia. They can be found in neoplasms, in Hashimoto thyroiditis, and as we are just seeing, in also nodular colloid goiters. And this is another area to show you, apart from the colloid, a fairly cellular area. And if you see this in isolation, then we can call it a neoplastic affair. Additionally, signs of degeneration, cyst macrophages, easy to pick up. And yes, rectangular crystal with a missing edge. That's a cholesterol crystal in a background of this. Now remember that cyst macrophages, cholesterol crystals, they can be found in any goiter which has cystic change. And remember that cystic change is not confined to cystic nodular goiters. Any large tumor especially can show you cystic change. So it's useful but not conclusive. And then another sign of degeneration, you have the cells at the top, and these show bare nuclei. Now, Bare nuclei can be confused with lymphocytes. I've seen cases being misdiagnosed as autoimmune thyroiditis on this base. Let's have a look at the lymphocytes. Now, lymphocytes do not stain as darkly, number one. They don't stain very uniformly, and a cytoplasmic rim can be made out in at least some of the lymphoid cells. So this is something which one has to be careful about. And so I think diagnosis is obvious. And the benign BFN, benign follicular nodular goiter, or thyroid follicular nodular disease in the current parlance, Bethesda category 2. And this is another case, nodular colloid goiter, shows you what? Sorry. Okay, shows you a really large nucleus. So don't take cognizance of them if they are isolated. And yes, additionally, you can get what? Spindle cells. And because there is degeneration, there is regeneration, and they can be quite abundant. And at one occasion, at least, I have suspected a squamous carcinoma because the fiber type of cells. Do remember that spindle cells, if they are abundant, they can lead you to diagnosing a medullary carcinoma of spindle cell type and a plastic carcinoma also. And do remember, the postgraduates also, that there is a papillary carcinoma which can have spindle cells also. Okay, so features of BFN, the important features are just two: low cellularity, and to check whether the cellularity is genuinely low or whether this is due to indifferent technique, you have a predominance of colloid. Because if quite often I have seen dilute aspirates of tumor, and instead of being reported category 4, they are reported as category 2. Why? Because the cellularity was low. And the primary criterion for diagnosing a tumor is tumor cellularity. So just to keep a check on that, colloid should be abundant. And important DD considerations are, well, if there are cellular areas abound to the detriment of colloid, then you can have a hyperplastic nodule, easily confused with a follicular neoplasm. And then because of the fluid, remember, papillary carcinoma is the snake in the grass as far as thyroid FNAC is concerned. Because you may not have any very little cellularity, and the atypia can be modest. So this is what has to be taken care of. And this is another lady, 40-year-old female, had a previous history of FNA, cyst fluid only. I have deleted the images, etc., because of time consideration. Then this was, I made two passes. First pass shows cyst fluid only, obviously. Second pass showed two clusters of cells in the entire slide. One of them which looks like a papillary aggregate, suspicious at the very least. And this was the second cluster. And this second cluster shows features very characteristic of papillary carcinoma, including an intranuclear inclusion here. There is a suggestion of another one, nuclear membrane irregularity. Chromatin is grainy chromatin. So I felt confident that we are dealing with a cystic papillary carcinoma, but because of the paucity of cells, the tumor cellularity wasn't there. So hence, I downgraded it a bit, called it category 5 instead of category 6. And we follow up the patients, though some of them are quite reluctant. And this patient got operated somewhere else later. And he said he didn't have the report. He said, Doctor ne kaha koi cancer वगैरह नहीं है, whatever that means. I'm still trying to get hold of the report first hand. This is a feature of papillary carcinoma which many of us are not aware of. You can see this spiral appearance of this whole thing, or a concentrically laminate structure. And we'll go under higher power, and it shows you what? That the orientation of the nuclei. Have a look at that. The peripheral nuclei run parallel to the circumference of the circle, and these are referred to as cellular swirls and are a characteristic feature of papillary carcinoma. Yes, some relief Those of you who are about to undergo an arranged marriage, this is for you. And those of you who are in an arranged marriage and are very happy, reason to party. 67-year-old female, right lobe only, euthyroid, anti-TPO, deadly high. And yes, this is a cellular aspirate, it appears. And on the right, we can see a microfollicular aggregate, and the left is another aggregate, which is partly, I would say, a monolayer sheet and partly microfollicular with some crowding. And so the diagnosis would be what? I have crossed half an hour. 15 minutes. I was supposed to get half an hour. It was half an hour. Achha, I don't know what they loaded. 30 minutes plus 5, I got a loan from someone who finished 5 minutes earlier. So that is the, where is, okay, thank you. Okay, so this was a cellular aspirate. It is at least suspicious, not less than category 3, may go ahead. But see, now this is the full picture. Abhi picture baki hai. Lower part shows a lot of colloid, and hence you know now this was a hyperplastic nodule. Remember also that when we say follicular neoplasm, it is not only the cellularity, it should be microfollicular, and there should be some cellular crowding. And the follicles have to be small, which means that they shouldn't exceed 15 cells in size. Okay, and the other area from the same case, and this is an out and out nodular colloid goiter. Apart from chunks of colloid, have a look at the cells, withered cytoplasm, nothing wrong with the nuclei. So I think I better speed up the act. Okay, so hyperplastic nodular goiter, it becomes category 2 as opposed to at least category 3 or 4, which it could have been. And yes, this is a clear-cut case of primary hyperplasia, 10 years treatment, and despite the neomercazole, she is still thyrotoxic. Ultrasound shows a diffuse goiter with some no nodularity. That's important. Homogeneous ecotexture. But look what is the cyto. This is the lady, and look what is the cyto shows. Can anyone call this a primary hyperplasia by any stretch of imagination? This looks so much colloid in the background when it should have blood. So I have learnt a lot, and these are the cells. The cells are quite uniform. They look like monolayer sheets with sparse cytoplasm, uniform nuclei, no fire flares. So the lesson I have learnt is that primary hyperplasia is not to be diagnosed cytologically, and sometimes we miss this point. It is there in the books. The cytological findings are thus just to ensure that if accidentally, inadvertently a primary hyperplasia has been aspirated, the pathologist becomes aware and suggests that possibility to the clinician. Also remember that Hashimoto and primary hyperplasia are basically two poles of the same thing, and this was, and it is remarkable in fact that it was reported as early as 1957 by Ackerman himself along with Sput in a paper, that there is a lot of overlap between these conditions. Remember that Hashimoto described it in 1912 and there was a lot of silence. 1957, this was the thing. So lymphocytes दोनों में होते हैं, Hurthal cells भी दोनों में हो सकते हैं. Of course, lymphoid cells we see few in the aspirate in primary hyperplasia, but the histology textbooks will say that the basic thing is that there are lymphoid follicles, but probably they are not as abundant. Right thyroid swelling in a 55-year-old female, TRADS 4. You have the swelling here, right? So it is suspected to be malignant on imaging. And what do we get? I think it's quite easy. Lots of lymphoid cells. And in addition, you have these cells which look like Hurdle cells. So the diagnosis is autoimmune thyroiditis, and you can confirm by TPO. The more Hurdle cells to boot. nice Hurtle cells, and do see that some of them have oval nuclei like papillary carcinoma. Also they have nuclear membrane irregularity, and the chromatin is granular like a papillary carcinoma. The lymphoid cells in this field, see, they form a tangle of nuclei. Sometimes the only evidence of lymphoid cells can be these lymphoid tangles, and they are to be equated with lymphoid cells. And these are the Hurtle cells, characteristic Hurtle cells, clearly benign. What do we see? Central nucleus, abundant cytoplasm, light basophilic. One can also make out the granularity in the cytoplasm. And postgraduates, loud. Why do we have this morphology? What is common to the Hurtle cells in various conditions? It's the mitochondria, the massively increased mitochondria. And why are the mitochondria increased? Because remember that DNA is nuclear, DNA is mitochondrial also. And in the mitochondrial DNA also codes for structural subunits of the OXPHOS system, oxidative phosphorylation system, जो mitochondria की inner membrane पे होता है. Multimeric subunits होते हैं 5. एक भी अगर खराब हो जाए उसका जीन तो पूरा यूनिट असेंबल नहीं होगा, एंड ऑक्सीडेटिव फॉस्फोरिलेशन सफर्स. एंड इफ इट सफर्स देन व्हाट डज द बॉडी डू? क्वांटिटी इंक्रीज कर दीजिए अगर क्वालिटी खराब है. सो यू हैव न्यूमरस माइटोकॉन्ड्रिया एंड द पोलैरिटी ऑफ द सेल इज लॉस्ट. न्यूक्लियस एक पोल पे नहीं रहता है. Point to remember is that since the oxidative phosphorylation is precarious, they are very prone to succumb to hypoxic stimuli. And this is another field showing Hurtle cells. And what does one see? I wanted to show you oval, elongated nucleus, suggestion of a nuclear groove is there, and some variation in the size of the nucleus. The one here is at least twice the size of its other companions. And this is known as large cell dysplasia, variation in the size of the nucleus, twice, at least twice, twofold, large cell dysplasia. It is of no consequence. If there is no dysplasia, it is benign. If there is large cell dysplasia, it's more likely benign than malignant. Doesn't mean much. It is like I always say, low grade pin. जैसे लो ग्रेड पिन की कोई अहमियत नहीं होती है. आगे चलते हैं. सो दिस वाज अ हाशिमोटो थायराइडाइटिस केस, एंड द डिफरेंशियल डायग्नोसिस, प्राइमरी हाइपरप्लेजिया बिकॉज ऑफ ऑटोइम्यूनिटी, abundance of Hurtle cells to the exclusion of lymphoid cells, Hurtle cell neoplasm, lymphoma if there is the dominance of lymphoid cells to the exclusion of the epithelial elements. Left thyroid in a 75-year-old male. Right. क्या देखते हैं हम इसमें? Hurtle cells की बरसात है. Lots of Hurtle cells. But do they appear different? They are poorly cohesive. Number one. Number two, you have large cell dysplasia at the center. I think you can see this easily. Also note that these Hurtle cells appear to have less cytoplasm than the companions which you saw in Hashimoto thyroiditis. So these are small Hurtle cells, referred to as small cell dysplasia. And remember, small cell dysplasia points towards a Hurtle cell neoplasm rather than a reactive proliferation. And the other thing is that if you look at the surgical pathology text, they will tell you that the size of oncocytic carcinomas, the cell size is much smaller than oncocytic adenomas. So maybe there is a clue that this is likely to be malignant. Have a look at this. Again, the same case, and it shows you what? At least 2 mitosis. So this Hurtle cell neoplasm you have got to be careful about. Some funny aggregates, basophilic aggregates, इन्हें कोशिश करते हैं देखने की और. Yes, now what is this? Postgraduates. Concentrically laminate structure located in the follicle, and this is inspissated colloid which has calcified at the center, looks like a samoma body, right? And remember, Hurtle cell neoplasm have a tendency for this to occur, and also they appear to have a tendency to go to lymph nodes, unlike other follicular derived carcinomas. Papillary lymph node में जाता था, Hurtle नहीं जाता था lymph node में. but Hurtle goes in the lymph nodes. But now they say that this is not lymph node metastasis. This is just loco-regional dissemination via the vascular channels. And the repercussions are that now you don't need to do a lymph node dissection. You can get away with just removal of that thing. Samoma bodies to compare. I think it's getting stuck. And yes, another feature, vessels. Can we get the vessels? Traversing vessels, useful for neoplastic versus non-neoplastic Hurtle cells. So oncocytic neoplasm. I said they are prone to hypoxic damage. And look at these cells. It appears something has gone wrong. They are bonsai versions of the Hurtle cells, and the staining is quite bad. Really, it isn't bad, because in the same case, you had these cells staining well and these cells staining badly. So these are degenerate cells. Probably it is undergoing infarction. And FNA-induced infarction is very common in Hurtle cell neoplasms. And now what I do is, shall I finish?
Yeah.
Yeah, okay, okay. Thank you so much.
5 minutes, that time, the 5 minutes included is
वो भी हो गया. अच्छा, ठीक है. So, yes. हाँ जी, हाँ. ठीक है, thank you so much. And with that I proceed, and I leave you where I said at the outset कि टाइम की तो हमेशा दिक्कत रहती है, बट चलिए मैं आपको एंड में जी लास्ट स्लाइड में दिखा दूं बस. डॉक्टर सुरेश हैं क्या? नहीं है तो अच्छा है. जस्ट अ मोमेंट. अच्छा, सुरेश साहब हैं. अच्छा, तो आपके लिए. अरे आइए, तो आपसे कल बात हुई थी ना कुछ, तो उसके लाइफ इज टू लॉन्ग शॉर्ट फॉर द इंडल्जेंस ऑफ एनिमोसिटी. ये हमारी और डॉक्टर सुरेश की कुछ प्राइवेट बात है. एंड विद दिस आई से थैंक यू टू ऑल ऑफ यू, एंड दीज आर द 3 sister mountains from Scotland, with love. Thank you.
Thank you so much, sir, for
Thank you.
really showing the thyroid efficacy at grassroots level. Sir, I think there must be some questions from the audience. So, any questions from the audience? Yeah, there is one. Somewhere.
Yeah.
We are not able to hear you. Please come forward. Sir, you please come to the dais.
And amplify the question. The question is, how much importance should be given to fire flares, especially in the context of calling it primary hyperplasia? Well, first, I would like to say that primary hyperplasia doesn't need FNA for diagnosis, nor should it be diagnosed through FNA. The cytology appearance is mentioned only to ensure that if inadvertently it has been diagnosed, you may suggest that possibility, and then the clinician proceeds further. He takes a clue from this and proceeds further. So it is not a cytologic diagnosis. Part 2, I've just showed you a case wherein it was a clear-cut primary hyperplasia, and yet the cytology was not like that. There are cases where it appears like a follicular neoplasm. Only if you are not aware of this, that it is a diffuse goiter, then you might call it a neoplasm. तो इसलिए उसकी importance really है नहीं. Additionally, you get it in Hashimoto's thyroiditis, which is a first cousin of primary hyperplasia. You get it in nodular colloid goiter and in neoplasms. In fact, sometimes there is a neoplasm at a metastatic site, and we don't know what is the primary site. And it is merely by the recognition of the fire flare that you can tell them that this is originating from the thyroid. In fact, some time back, it was held at SGPGI, UPCYTOCON. And there someone from the department presented a case in which there was a lymph node from the inguinal region. That was my case, which had been presented. And that was the first clue that this is a metastasis from a thyroid carcinoma.
Thank you so much, sir, for enlightening us. I hope sir has been awarded a Best Teacher Award. And in the interest of time, I would not allow any more question. You can very well interact with the sir during the dinner as well as tomorrow's session. And before ending the session, I would like to thank the organizer for giving us the opportunity to chair this very important session. Thank you so much.
Thank you so much. Thank you.
Thank you.
I now request our chairpersons to please felicitate Dr. Atul Gupta, sir. I now request our chairpersons to please felicitate Dr. Dipali Jain, ma'am. Now I request Professor Nuzhat Hussain ma'am to please give memento to our chairpersons. Now for our last segment, we'll be having a potpourri of unusual and interesting cases. To chair this session, I would like to invite on stage Dr. Vatsala Mishra ma'am and Dr. P.K. Gupta sir. Dr. Vatsala Mishra ma'am is a former head of the Department of Pathology, Motilal Nehru Medical College. Ma'am has been the president of the Indian Association of Pathologists and Microbiologists. Dr. P.K. Gupta sir is the focused city-based clinical pathologist, director of PK Pathology Labs, and ex-president of IMA Lucknow. Now I call upon the first speaker, Dr. Nidhi Verma.
The first presenter in this session is Dr. Nidhi Verma from
Department of Pathology, MMC. She has 38 publications in international and national competitive journals and 1 book to upgrade it. Intramural projects she has done and completed 1, and others are ongoing projects. She has supervised 4 postgraduate theses and 2 are ongoing. Her area of interest is cytopathology, LPC, both gynec and non-gynec, molecular pathology, immunopathology, histopathology, and postgraduate quiz conduction, etc. So I welcome Dr. Nidhi Baba for presentation.
Thank you so much, ma'am, for this brief and crisp introduction. And I would like to thank the organizing secretary, Dr. Madhu Kumar, and the head of the department, Professor U. Singh sir, for inviting me here. And I have worked in KGMC for 3 to 4 years, and so coming to KGMU is just like coming home. So we'll start with the first case. Here we can see that a 50 years old female patient presented to us with complaints of, it's not working actually. Here we can see that a 50 years old female patient presented to us with complaints of swelling in the breast for past 3 to 4 weeks. Here we can notice that the swelling was involving the upper outer and the upper inner quadrant. It was 5 by 3 by 2 centimeter in size, and the outer surface was showing ulceration, and there was history of discharge from this swelling. However, there was no history of discharge from the nipple. There was no history of any other lump in the body, and bilateral axilla were free, and there was no family history of breast carcinoma. And this is the mammographic findings. Here we can see that the similar lump, which is subcutaneous in location, it was not present in the deep mammary tissue, and the Byrides grading 2/3 was done, and it was done outside. And we performed FNEC. We did 2 aspirates. In first aspirate, the smears were cystic. So here we can see that hardly any cellularity. There's just 1 cluster of cells lying in this abundant pinkish background. And this is the high power view of these cells. Here we can see that, here we can see the cells, they are polygonal to round in shape, and they have central to eccentrically placed nucleus and very abundant clear kind of cytoplasm. And these are the smears from the second aspirate. Here we can see the cells, they are quite cellular, and the tumor cells, they are present in papyroid fragments, small clusters, and some of the tumor cells are lying singly. And here again, even at 20x, we can notice that they are clearly 2 cell population. One is the cells with the abundant granular cytoplasm, and second cell population, which is showing the clear cytoplasm. And again, this is the high power view, similar epithelial cells with round oval nucleus, bland looking nucleus, and chromatin pattern eosinophilic cytoplasm. And this is the second cell population, which was also present in the first smear. The cells are polygonal in shape, and they have round oval nucleus and abundant clear cytoplasm. Again, similar cells, eosinophilic with eosinophilic cytoplasm. Here again, we can notice some of the cells, they have very clear cytoplasm. So in this case, we have a tumor which is subcutaneous in location and presence of epithelial cells in a subcutaneous tumor. The cells were present in papilla, clusters, and clearly 2 cell pattern was present. The cells were polygonal in shape with eosinophilic cytoplasm, and the second population was of clear cells. There was total lack of cytological atypia, and unlike DCIS, there was no proliferation of monotonous type of cells, no atypia, and isonucleosis, no mitosis was present. So in a subcutaneous tumor, whenever you are looking at a epithelial cell, always think of an adenoaxial tumor. So we gave a diagnosis of benign skin adenoaxial tumor and possibly nodular adenoma. And therefore, the lumpectomy was advised, and we received a well-encapsulated globular tumor, which was 4.8 by 3 by 2 centimeter in size. It was firm to hard. Cut surface was showing solid gray-white areas and also the cystic areas. In FNEC, we also received 3 ml of cystic fluid. In microscopy, we saw a tumor which was present purely in the dermis. It was a well-circumscribed tumor, and it was lobulated in appearance. And here we can see the tumor lobules, which are separated by this fibrovascular kind of septa. And this is the high power view. Here again, you can notice the similar cells, 2 cell population. This is the first cell population which are large to polygonal in shape, eosinophilic cytoplasm, round to oval bland looking nucleus, and this is the second cell population, which is clear cells showing eccentric to centrally placed nucleus, and apart from this, there were some cystic spaces which were lined by cuboidal cells and filled with these secretions. And again, this is the other view showing mainly the clear cells. Again, here we can see the cells, they are predominantly clear cells without any significant atypia or anisonucleosis. These clear cells were showing glycogen positivity and which was PAS positive and diestrase resistant. Here again, we can notice the tumor is well circumscribed and it is lobulated in appearance. And these tumor cells, they were positive for EMA and CK and they were negative for ER and PR. So a diagnosis of clear cell nodular heteroderma of breast was given, and we rule out the differential diagnosis because of the location. The first differential diagnosis can be DCIS or the ductal carcinoma of breast, but in DCIS we have a proliferation of monotonous type of cells which was not present in our case. We have two cell population which was very clear, and there was no significant atypia, mitosis, necrosis, and ER/PR are usually positive, but it can be negative in DCIS, but in our case it was ER/PR was negative. Second differential can be adenomyoepitheliomas, but they are deeper in location, but our case was very subcutaneous in location. Two cell pattern can be present in adenomyoepitheliomas, but they show positivity for epithelial markers like SMA and S100, while nodular heterodermas, they are negative for SMA. The third differential can be myoepitheliomas, but mainly they show one cell population, that is plasmacytoid cells or the spindle cells, which are myoepithelial cells. In our case, we have two cell populations, so it was ruled out. Again, myoepitheliomas, they are deeper in location. Another interesting differential diagnosis was metastatic RCC. Why metastatic RCC? Because we have a clear cell population. But unlike metastatic RCC, we did not have any atypia, mitosis, or necrosis, and it is positive for CD10 and Vimentin, while our case was negative for CD10, so a diagnosis of nodular heteroderma was given. And now coming to the second case, a 45-year-old male patient presented to us with multiple swellings involving different parts of face. There was swelling in the bilateral preauricular region, also in the forehead, over the eyebrows, around the bilateral ala of nose, and there was one big swelling on the scalp. So there were multiple swellings all over the face, and they have a tendency of grouping of lesions. And we perform FNAC only from the larger swellings, that is from the bilateral preauricular area and also from the scalp swelling. All the smears show similar features, and here we can see that the smears are quite cellular, and one type of cell population is present, which is the basaloid kind of cell population. And these cells have round to oval nucleus, hyperchromatic nucleus, inconspicuous nucleolus, and hardly any cytoplasm. There was no significant nuclear molding, anisonucleosis, mitosis, or atypia. And apart from these basaloid cells, we also have this basement membrane kind of material. And the tumor cells, they were clinging around this basement membrane kind of material. This is the high power view of the same basaloid cells without any significant anisonucleosis or atypia. And again, in the high power view, we can also notice this thick basement membrane kind of material, and the tumor cells, they are clinging around this basement membrane kind of material. And so, again, a subcutaneous tumor with basaloid cells and without any significant atypia and the basement membrane material, we thought of an adnexal tumor. So first differential was kept as cylindroma, second was pyrinoma. Because of the basement membrane material, we also kept a differential diagnosis of adenoid cystic carcinoma of skin, which is not very common, and the last differential was basal cell carcinoma because of the presence of basaloid cells. So why we kept cylindroma as first differential? Because the cell pattern is basaloid, which was present in our case, like the nuclei, they are round to oval, uniform, chromatin, inconspicuous nucleus, which was present in our case. And plus, they have a very thick basement membrane kind of material. And the tumor cells, they attach to this basement membrane kind of material. But in spiroadenoma, usually, apart from the epithelial cells, which are basaloid, there can be myoepithelial cells, which were not present in our case, plus the lymphocytes. Lymphocytes are present in spiroademas, which were not present in our case. And basement membrane material can be present in spiroademas, but it was not present in our case. So we kept the diagnosis of cylindroma, and spiroadenoma was ruled out. The third differential was adenoid cystic carcinoma, but in adenoid cystic carcinoma, the tumor cells, they are present in 3D clusters. And the tumor cell globules, and these tumor cells are uniform, hyperchromatic, and the tumor cells are all over these basement membrane kind of material. But it was not present like that. In our case, it was just fragments of the basement membrane material. It was not cup-shaped, it was not 3D clusters. Plus, since adenoid cystic carcinoma is a malignant tumor, the nuclei are hyperchromatic, irregular nuclear membrane, sometimes mitotic activity can be present, but it was not present in our case. So it was ruled out. Another very important thing is that in adenoid cystic carcinomas, usually the basement membrane material is very thin, but in our case, it was very thick kind of basement membrane material. So ACC was ruled out. The last differential was basal cell carcinomas. Again, there are basaloid cells in basal cell carcinoma, just like our case, but again, it's a malignant condition, so there can be dark hyperchromatic nuclei with brisk mitotic activity, and very importantly, this basement membrane kind of material is absent in BCC, so it was also ruled out. And we gave the diagnosis of a benign skin adenoaxial tumor, possibly cylindroma. And the surgeons performed biopsy only from excision only from the larger lesions to improve the facial appearance of the patient, because there were multiple lesions. And in gross, we received multiple swellings ranging in size from 1.2 to 2.5 centimeter in maximum dimension. These were encapsulated swellings and solid uniform cut surface gray white, no necrosis, mitosis, or no cystic changes. And in microscopy, the tumor was well circumscribed, and the tumor cells were like the group of the basaloid cells. The tumor cells were present in basaloid clusters, and it was a well encapsulated tumor and purely dermal in nature. And here we can see the tumor cells, islands of tumor cells, they are tightly packed together, just like the jigsaw puzzle appearance or the mosaic appearance. Again, these tumor cells, tumor islands, they are separated by this thick basement membrane kind of material. And if we focus on individual island, we can see two types of cells present in these islands. Outer cells are showing somewhat palisading, and the inner cells, they are slightly larger in size, and they are more differentiated. They have round to benign nuclei and the abundant vesicular nuclei, and the cytoplasm is abundant eosinophilic. While the outer cells, they have darker nuclei and scant cytoplasm. Here, this is the high power view. Again, two cell population, outer cells, tumor, these are the tumor lobules. The outer cells, they are hyperchromatic, basaloid kind of cells, and the inner cells, they are showing the slightly vesicular nucleus and granular cytoplasm. Again, here we can see that the tumor nodules, they are separated by thin fibrovascular septa, and it was showing positivity for PAS. So a final diagnosis of multiple cylindromatosis was given. As we all know that cylindromas are benign adenoaxial tumors, and they can be solitary or multiple. And when the cylindromas are multiple, they are associated with certain syndromes. Like we have three syndromes which are associated with multiple syndromas. First is the Brooks-Spiegler syndrome, second is the familial cylindromatosis, and third is the multiple familial trichoepitheliomas. All these syndromes, they are closely related entities, and in some patient, some lesion can show cylindroma-like features, while the other lesions can show spideroma-like features. So there's a lot of overlap between the lesions, and all these syndromes, they are associated with the mutation in the CYLD1 gene, which is basically a tumor suppressor gene, and mutation, this gene is located in chromosome 16q, and mutation in this gene leads to activation of the nuclear factor kappa B, and thereby causing the tumorigenesis. In our case, we could not demonstrate the mutation of CYLD gene because it was not available with us, so we gave a diagnosis of multiple cylindromatosis, possibly familial in origin. Yes, ma'am? Yes, ma'am. Ma'am, there were multiple swellings in the preauricular area. Ma'am, there were multiple swelling in the both pre and post-auricular region.
I think let her complete, then in
this can be
question
left
answer session we can take the discussion.
Yes,
yeah, she can just complete it.
And now coming to case 3, 50 years old, because I'm running short of time, we'll just try to rapidly finish this case. 50 years old female patient presented to us with complaints of swelling in the left leg, which was 2 by 3 centimeter in size, and outer skin was stretched out over the swelling. It was subcutaneous in location, and it was not adhered to the underlying structure. There was no significant medical or treatment history of the patient. And when we performed FNSC, and it was a very cellular aspirate, and the tumor cells, they were present papyroid fragments and clusters, and these tumor cells were blending in this abundant chondromyxoid stroma. Very easy diagnosis. If it is present pleomorphic salivary gland, we give the diagnosis of pleomorphic adenoma. So this is the high epithelial cell population, and these are the myoepithelial cells, which are plasmacytoid in appearance, and they are lying in this abundant chondromyxoid stroma. So a diagnosis of chondroid syringoma was given. Differentials can be myoepitheliomas, but they don't show 2-cell population. They have only 1-cell population, which is plasmacytoid to spindle cells, and plus the background is usually not there. Because of this background, the diagnosis can be neuruloma or neurofibroma, but the nuclei were not matching with neurofibroma. One differential can be intramuscular myxomas, but they show scant cellularity. Our case was very cellular, plus their cells have long cytoplasmic processes, and occasionally giant cells can be present in myxomas, which were not present in our case. Another differential can be nodular fasciitis, but it can show anisonucleosis, anisocytosis, binucleation can be present, which was absent in our case, so it was also ruled out. And because of this background, a differential can be fibromyxoid sarcoma, but again, they have low cellularity. Our case was quite cellular, and plus there was no atypia. So it was also ruled out. Histopathology confirmed our case. Here we can see the 2-cell population, the cells in cords at places forming the acini and the ducts, and they're melting in this chondromyxoid background. Again, the high power were the same. And these tumor cells, plasmacytoids or the myoepithelial cells, were showing positivity for S100. So just very few words about how to approach to a case of skin adenoaxial tumors. Just as a cytological point of view, how do we classify adenoaxial tumors? They can be classified into 3 types. First of all, the tumors that arise from the sweat gland. Second can be the tumors that arise from sebaceous gland. And fourth one, the tumors that arise from the follicular areas. Sweat gland tumors can be the tumors that show acrine differentiation, the tumors that show apocrine differentiation, and the tumors that show both apocrine and acrine differentiation. In the ectodermal tumor, we have poromas, hydradenomas, cylindromas, etc. And in the apocrine tumors, we have SCAP or the syringosis adenopapilliferum, hydradenoma, apocrine adenoma, etc. Then chondroid syringoma, which can show both acrine and apocrine differentiation. Sebaceous tumors are not very common. Whenever they are present, they are usually associated with certain syndromes like Mortuary syndrome, and they are like sebaceous epitheliomas, sebaceomas, sebaceous carcinomas, and the tumors of follicular origin. This is a very heterogeneous variety, but it is very common type of adenoaxial tumor. These include the pilomatricomas, the trichoepitheliomas, trichoblastomas, pilar tumors, etc. So from as a cytopathologist, first we need to understand that whenever you are seeing any tumor which is subcutaneous in location, plus you are seeing epithelial cells, and the tumor has a monomorphic kind of appearance, always think of you should keep 2 differential in mind. First is the benign adenoaxial tumor, and second is the metastatic kind of tumor. So, and then you have to rule out whether it is benign adenoaxial tumor, or the malignant kind of adenoaxial tumor. So after categorizing these 2 things, you should try to subcategorize the tumor, which origin is there, whether it is follicular origin, whether it is sweat gland origin, or apocrine or sebaceous origin. And again, the aspirate is also very important. If it is cystic aspirate plus 2-cell population, always think of an nodular hydradenoma. Similarly, if the aspirate is thick, mucoid, and gelatinous, and you have 2-cell population plus the chondromyxoid background, think of chondroid syringoma. Plus, if you have an aspirate that is granular and flaky, and apart from besides instead of basement membrane kind of material, you are seeing the keratinous kind of background, always think of the tumor that is of follicular origin. In follicular tumors, usually you can see the squamoid cells, which can be nucleated or anucleated squams, plus the basaloid cells, sometimes inflammatory cells, and the foreign body kind of giant cells can also be present in pilomatricomas. While in cylindromas, basically we have basaloid kind of cells, and basement membrane kind of material is present in both. In spironoma, we have myoepithelial cells plus the lymphocytes. And now coming to the take-home message, the strength, we should remember that the strength of FNAC lies in number one, first of all, identifying or establishing the adnexal origin of lesion. Precise subclassification can be challenging because sometimes some of the lesions can mimic 2 or more type of lesions like cylindromas and spironoma. Multiple features can overlap, so subtyping can be difficult. But FNAC is pretty good in differentiating between benign and malignant lesions. Therefore, it is very helpful in diagnosing, giving the first line of diagnosis to the clinician. And in the end, I would say that as a cytopathologist, we are not provided with the luxury of architecture. But yes, we have our own stars. If we first star is the clinical signs and symptoms, because we are doing FNA ourselves. So we can examine the patient, look whether the swelling is subcutaneous in location, it is not adhered to underlying structures. And the second star is the type of cell population. Which type of cell population is there? 1 cell type, 2 cell type, myoepithelial cells are present. And the third star is the background, whether it is chondromyxoid kind of background or it is base membrane-like material. And if we try to correlate these stars and try to draw some beautiful constellation out of it, then I think we can reach to a diagnosis. Thank you so much.
Thank you, Dr. Nidhi, for very nicely illustrated the 3 skin adnexal tumors. Now, we can just take 1 or 2 questions. Anybody? Now, madam, you were saying something.
Ma'am, that's what we have given the diagnosis. We could not establish the mutation in C-viable lesion because it was not available with us, but we have given the diagnosis of multiple cylindromatosis, possibly familial in origin. Yes, ma'am, we have given the diagnosis.
Okay, if there are no more questions, thank you, Dr. Nidhi.
Thank you, ma'am.
And I'll ask Dr. Gupta to introduce the next.
Thank you.
Our next speaker is Dr. Kashnar Verma. I think she is coming. Please welcome. She is MD from MGIMS, Sevagram. She did SRship from MAMS, New Delhi. She was an oncopathology trainee at TMH, Mumbai. At present, she is a professor in Department of Pathology, Eminent Medical College, Prayagraj. And she had 51 publications and more than 20 presentations. And she was a gold medalist. And she has the best oral paper presentation at APCON 2021 and best paper presentation CYTOCON 2010 and membership IAPM, IAC, UP, IAPM. She was a principal investigator in 4 projects including ICMR, MRU guided MD. She is awarded for COVID warrior and she is an exemplary teacher award also. She has a fellowship in neuropathology, molecular pathology. She is the organizing secretary of UPCYTOCON 2018. She was scientific secretary, CYTOCON and INT-CME. She was a reviewer of IJPM as a diagnostic cytopathology, Journal of Cytology and Activity and Early Detection of Cancer. Her area of interest is oncopathology, breast and GI pathology. Welcome, Dr. Kashnar Verma.
Thank you, chairpersons, for the introduction. And first of all, I congratulate the organizers for this academic feast and also thank the organizer for giving me this opportunity to be here with you. Since it's the fag end of the session, I think I'll hurry up with my presentation. And the good news is I have just one interesting case, so I think that's a big relief. So I'll be presenting unusual fluid cytology, and my corollary here is it is for your eyes only because it's a very rare case, and I request the postgraduates to definitely think of this diagnosis only after inclusion of the other entities. So the case, a 60-year-old man presented with abdominal distension and discomfort and dyspnea. Examination showed clinical signs of ascites, and the routine blood counts, urea, electrolyte concentrations, and the liver function tests were normal, within normal limits. The radiological findings: abdominal ultrasound scan confirmed the presence of abundant ascites as well as a large intraperitoneal mass which had an irregular margin. Here we see the mass which is present. Right, and it was a hypoechoic mass lying adjacent to the pancreas, and the size was approximately 4 into 3 centimeters. The workup of the case: evacuative paracentesis was performed to mitigate the patient's symptoms. We received ascitic fluid, which was straw colored, and around 150 ml, and conventional cytosine slides and cell blocks were made. The cytospin technique is given here, and we also made the preparation was done for cytospin, and the unstained slides were kept for IHC. So this is my slide for my postgraduates. As reported by COS, a cardinal step in the mastery of aspiration cytology is the ability to translate the cytological patterns into histological tissue patterns of diagnostic value. I have specifically put this slide because my residents have a habit of, since it is cytology, so they feel that it's the cells they have to observe, and they have this habit of rushing from 10x to 40x. So my request is, the most important thing is first focus on the pattern. So we have various patterns in cytology. I won't go into the details, but just a message for my residents: look for the pattern which is present in the cells. So coming to our case, we saw this pattern of small nests of tumor cells. Also larger clusters were there, and at places we also saw the palisading pattern, and there were large tumoral cells with moderate amounts of cytoplasm, eosinophilic cytoplasm. Occasional short cars of tumoral cells were present, and cell windows were also appreciated in between the cell population. Again, cell block preparation showed a aggregation of these cells, and presumably they looked like vague glandular formation at places, and it mimicked a adenocarcinoma. Now the cellularity was high, as we can see here. There was overlapping, there was crowding, and in between there were lots of atypical mitosis which were present. The cell cluster showed marked pleomorphism. High NC ratio was present. Cytoplasm, the nuclear membrane was irregular, inconspicuous to prominent nucleoli present, and we saw moderate amounts of eosinophilic cytoplasm of the cells. Further, the cell population consists of polygonal cells and occasional. This was in fact, I would say, a retrospective finding. When I got to the diagnosis, I reviewed the case, and then we did notice that in between there were some plump spindle cells which could be made out in between this round to polygonal cells. The nuclei were mostly round to oval with pleomorphism, irregular contour was present, and no intranuclear occlusions could be made out. Special stains were done, and the AB pass stain failed to show evidence of mucin or hyaluronide because, as is evident, the most probable diagnosis with the USG findings, we were thinking of a adenocarcinoma, but it was not a classical adenocarcinoma, and the AB pass stain came out negative. So, looking at the most probable differential diagnosis, we are getting a malignant ascites with round to oval polygonal cells which are present in clusters, somewhere acini formation, somewhere palisading. Cytoplasmic vacuoles could be appreciated. So definitely our first diagnosis was a metastatic adenocarcinoma. Malignant mesothelioma I have kept here because it is not a probable diagnosis in ascitic fluid. But with this kind of morphology, we have to keep it in the differentials. The next similar morphology can be seen in amelanotic melanoma, and a rare possibility could be some metastatic epithelioid sarcoma, which could have been present in this case. Immunocytochemistry was done on the cases, keeping the whole panel in view. And what we saw was that the cells showed a strong immunoreactivity for vimentin. When we were evaluating the case, we had just put vimentin, and later, after we had preserved some slides for IHC, and later when we got the histological diagnosis, let me confess, then we did a stain for c-KIT, which came out positive. So I'm sure you all have the diagnosis here. and definitely it was negative for pan-cytokeratin markers. Endoscopy of this patient was done, and a multinodular submucosal mass, tumor mass was seen, which tortuous dilated vessels on the surface. Very characteristic of, I think I should be having the answer from the audience now. Most likely the tumor is a submucosal tumor with CKIT positivity. What can we think of? Anyone? Yes? Vimentin positivity? Yes, someone loudly, you're right. It was a GIST. So, the surgical resection was done and we got the gross specimen. A resected loop of intestine, jejunum, measuring 20 centimeter in length was received, and we saw a large fleshy tumor measuring 10 into 8 into 5 centimeters, and there were central areas of necrosis which were present. Histopathological examination revealed a encapsulated, well-defined mass arising beyond the muscular mucosa and almost from the serosal surface, and a vague storiform pattern could be appreciated, and there were large epithelioid to spindle cells, plump spindle cells, which form the majority of the tumor cells. Further, on high power, what we saw, these cells were epithelioid in shape with a high NC ratio, moderate amounts of cytoplasm. Nuclei were round to oval, hyperchromatic, and the nuclear membrane was irregular. Nuclei at bases were very prominent, but the mitotic count was not very high. It was less than 5 mm square, and I think our PGs know now that this is the way you have to express your mitotic counts, because the prognostic factors in GIST are now in mm square, and it corresponds to around 20 to 25 high power fields in a standard microscope. And we also saw some ominous features like a capsular invasion was present and a large tumor emboli was seen going into a vessel. Again, a panel of antibodies were then rushed in on the mass, and yes, we did see a CKIT positivity. Here we can see very well the tumor was CKIT positive. Foci of capsular invasion could also be appreciated by CKIT staining, which was a diffuse membranous and cytoplasmic positivity. Also, CD34, which usually is positive in GIST, came out negative. And let me point out, CD34 in the small intestinal tumors is positive in only 60% of the cases. And DOG1 positive, which is a new marker, was positive. It showed a nice, in epithelioid GIST, it shows a nice paramembranous dot-like positivity, which was appreciated in our case. Right, so briefly, we have to know that what are the ISC markers which we have in GIST. We have the KIT, and if you go into the pathogenesis, it is a tyrosine receptor kinase transmembrane protein, a growth factor receptor for the stem cell factor. It is specific for GIST, but yes, it can also be detected in mast cells, melanomas, skin and nexa, and breast tumors. Then 3 to 5% of GIST are negative, and these are positive with PDGRFA mutations, and these are characteristic of epithelioid GIST rising from the gastric mucosa, not from the intestinal mucosa. Then DOG1, which is the full form is discovered on GIST, another IHC marker. It's a transmembrane protein regulating the chloride transport, and this also is specific for GIST, but it can be expressed in some leiomyomas and many GI squamous cell carcinomas. Then CD34, it is present in GIST, but it is less specific than KIT, CKIT, and DOG1. Other smooth muscle markers, alpha smooth muscle actin, heavy caldesmon, and desmin are also expressed in some of the GIST. So, looking at the clinical picture, looking at the histology, looking at the cytology, the final diagnosis we rendered, looking at the size of the primary tumor, which was more than 5 centimeter, mitotic count, though it was low, the final diagnosis was the epithelioid GIST with highly malignant behavior and peritoneal dissemination. So just briefly about, we'll rush through the few facts about GIST. GIST developed from the pluripotent stem cells, which are programmed to differentiate into the interstitial cells of Kajal and the smooth muscle cells. They constitute only 1 to 3% of all GI tumors, but they are the most common mesenchymal tumor of the GIT. The age of presentation is usually more than 50 years, and the median age is 62 to 63 years. Location, most common in the stomach, 60%, followed by the small intestine. Cysts which present at different sites and segments of the GIT have got distinctive clinico-pathological features. If we come to the morphology, 70% are spindle cell and 20% epithelioid, and the rest 10% are mixed tumors. Prognostic parameters, as I've already said, is the mitotic count, the tumor size, and the location where it is present. Then IHC is testing for this c-kit, and sometimes for DOG1, which is also known as ANO1, is essential in confirming the diagnosis. So this we know that cysts are driven by the oncogenic KIT or the PDGF-RA mutations, and this is very important because KIT tyrosine kinase inhibitor drugs are now available, and we have treatment for them, that is the imatinib mesylate. And also we have second and third generation inhibitors which can be used in the treatment of metastatic and unresectable cyst. Risk assessment, I'm not going into the details. All of us know that it depends on the mitotic index, the size, and also if it is present in which part of the GI tract. And as we can see here, there's a different criteria for gastric cyst and other cysts. Then they can show, malignant cysts can show liver mets, peritoneal dissemination, less frequently lung, bone, brain, parenchyma, and lymph node involvement. A point to be noted here was ours was a case of jejunal cyst, and most of the small intestinal cysts are serosal in location. So they are mainly protruding outside the serosal lining, and hence they have a higher incidence of dissemination to the peritoneal surfaces, and this could explain our pathogenesis, that they were shed into the ascitic fluid. Now let me tell you that reports and cytological aspects of cyst infusions is very rare. Ours, extensive literature search shows that ours is the 4th case of cytological diagnosis of cyst in ascitic fluid. And the important point to note is metastatic cyst cells acquire an epithelioid appearance in ascitic fluid. Though ours is an epithelioid variant of cyst, but otherwise also if cyst disseminates, the rest of the case reports show that they acquire a epithelioid morphology. The differentials we considered, number 1, it was adenocarcinoma because of the nested pattern, intracytoplasmic vacuoles. However, the positive immunoreactivity for vimentin and negativity for cytokeratins and also past negativity helped us in clinching a diagnosis. Mesotheliomas, here it was not to be put in the differentials, but otherwise they may display past negative or past positive intracytoplasmic vacuoles, but in contrast to this, pan-cytokeratin positivity is characteristic of mesotheliomas, and here the cytokeratin was negative. Then amelanoic melanoma comes into the differentials. Why? Because they also have large nuclei and prominent nuclei. However, the melanoma cells usually grow as single elements, and they won't show the clustering and the glandular pattern which was present in our case, and they all stain for S100 positive. Leiomyomas and leiomyosarcomas are also unusual sarcomas which may be present in ascitic fluid, and these will show you smooth muscle differentiation as SMA positivity, Zespin positivity is typical, but they will show non-reactivity for CD117. So these were the other case reports where they have shown present the dissemination of cyst into ascitic fluid, and like this case, in this it was a rare presentation of cyst, and this was the sole presentation. There were no primary symptom of cyst, and the tumor was discovered incidentally. That was the only presentation. In another case, in these cases which we see, either the tumor, the ascitic fluid, usually dissemination to ascitic fluid, followed resection of the primary tumor, means it was a sign of recurrence in these 3 case reports. So the take-home message, cyst in ascitic fluid is very rare, and hence I said for your eyes only, our residents should not keep this as the first differential diagnosis. They may closely imitate adenocarcinoma cells because just even the spindle cells disseminate to ascitic fluid, they take up a epithelioid appearance. Then wide range of malignant neoplasms enter into the differential diagnosis of cyst. Caution should be used in making diagnosis of cyst infusions by morphology alone, and we emphasize the central role of cytochemistry and immunocytochemistry. Misdiagnosis of GIST may lead to inappropriate therapy, since conventional chemotherapy and radiotherapy are not effective in treatment of GIST. However, these tumors have been found to be very responsive to treatment with imatinib, which we know is a selective inhibitor of tyrosinase kinase activity. And in this context, correct diagnosis is essential for proper clinical management, since this is the first model for targeted therapy in oncology. So these were my references, and definitely this is a team from MLN Pathology department. And I would like to thank my colleagues and definitely my HOD, Vatsala ma'am, for her continuous guidance. Thank you.
Okay, thank you, Krishna, for presenting this nice case here. I think this will give a message to the PGs so that they can take care for this. Any question from audience? Any query, any question? Now I think everybody is getting exhausted now. So our third.
Last but not least, our third speaker is Dr. Palvi Prasad. She is a young faculty. She did her MD in pathology from SGPGI. She is a PTCC reader pathology. She is at present assistant professor in Department of Pathology, SGPGI, Lucknow. She had 28 publications and oral presentation is 8. And her area of interest is renal and genitourinary pathology, breast and endocrine pathology, oncopathology and cytopathology. Welcome, Dr. Palvi Prasad.
Thank you, sir. Very good evening to one and all present here. And I extend my heartfelt gratitude to the organizing team for giving me the opportunity to be here. And after having gone through an exhaustive day of nice lectures and case presentations, I'm here to present the last case for the day. And it shall be very crisp, very short. So my patient is a 58-year male who was a smoker, diabetic and hypertensive patient. And he was a known case of coronary artery disease. For this, he was on continuous medication. And for the follow-up, he visited in 2021. And at that time, he was diagnosed as a case of aortic stenosis. And on that very visit, he was incidentally diagnosed as having ascites, which was high ADA, high SAG, and high protein. However, the ascitic fluid examination at that time revealed benign mesothelial cells only, and even the imaging did not reveal any lesion. There was non-FDG avid peritoneal fluid collection in the pelvis with mild mesenteric and omental stranding, and no other hypermetabolic lesion was noted. And coming to the history of his present illness, in last month, he presented with complaints of abdominal distension and high-grade fever. So he was admitted and worked up for the same, and he gave no significant past history. On examination, he was conscious, well-oriented, his vitals were fairly stable, and on examination, he had a distension of abdomen with presence of free fluid in the abdomen. As far as the lab parameters are concerned, all the values were fairly within normal limits except for TLC, which was towards borderline high values. Then for the workup of fever, his blood was sent for culture and urine was sent for culture, both of which came out to be sterile. Chest X-ray showed minimal right-sided pleural effusion. The ascitic fluid examination showed raised TLC count with predominance of lymphocytes, low SAG and high protein levels. ADA was borderline high. The ascitic fluid was at the same time also sent for gene expert and culture, both of which came out to be negative. So at this point of time, the clinicians were strongly suspecting a diagnosis of tuberculosis. And then the ascitic fluid was sent for examination to us. We received around 120 ml of ascitic fluid, and as we can very well see here that the fluid smears are hypercellular, and we have a variable cell population here, and few of which are small in size and the others are quite large in appearance. At the same time, we can also see here sort of a tubulopapillary structure, that is a ring-like formation by these cells.
And these arrows here highlight the, if we can see here, there is presence of cell within cell formation. That is, one cell has engulfed the other cell. And here we can see there is presence of multinucleated cell. Then again, these were other structures similar. All these mesothelial cells were forming sort of morules, and they were also present as scattered population in the background. So this is the formation of morules. And this, again, we have a cell within cell phenomena here. And so the prominent finding is there is a wide variation in the size of mesothelial cells, which are ranging from small to quite large, gigantic size. And this is a high magnification where we can examine the nuclear and the structural details of the individual cells, where we have single to multinucleated cells, and some of which show prominent nucleolus. The cytoplasm shows fine lipid vacuolization. And the pyritic acid shifts after diastase stain was negative. Then we also prepared cell block for the same smears, and the cell block's findings are reiterating the findings of the cytosepin smears. The cells are enlarged and they have a maintained nucleocytoplasmic ratio. And again, we can see the cellular details. Of course, there is definite ATPR present here. And again, we find that same peculiar formation of this sort of tubular structures, which are defined as hollow rings lined by cuboidal cells with central nuclei. And this is smeared from just another field to show the similar findings. PAD stain was again negative. And so with the diagnosis of mesothelioma in mind, we went ahead with the immunostaining panel. CK7 was diffusely positive, CK20 was negative. And when it was conveyed to the clinician that we are thinking of a malignant lesion, they wanted us to rule out the possibility of metastasis from all possible organs. So that is why we applied the complete panel of CK20, that was negative. Then for the colon, we ruled out the primary by applying CDX2 and SAT-B2 immunostains. And calretinid was positive, and so focal positivity also was seen was for WT1 stain. Then when this was communicated to the surgeon, again a CT scan was done. And this time, after the ascitic fluid has been, it has been drained off, then the radiologist could very well appreciate a heterogeneously enhancing lesion, which was attached to the peritoneum. And this lesion was around 3 into 2 centimeters in size. And if we can notice here, there are fine nodularities. And this is the peritoneum, which shows fine peritoneal deposits, which was more apparent on the right side. So to summarize, there was a soft tissue lesion, which was found out at this point of time after our cytology report, which was present in the right hemithorax with extension into the subphrenic space, and focally thickened peritoneum with few enhancing nodular, omental and peritoneal deposits were noted. And the imaging impression was that of a primary peritoneal carcinoma and lymphoma, less likely infective. The patient was then taken up for FDG PET's CT scan. Again, that lesion was highlighted. It was FDG avid. And their impression was that of also of a metabolically active deposit, likely to be metastatic. And a PET guided biopsy was advised. So we have the biopsy tissue here. This is the low par view. On high par, we can appreciate that the tumor cells are disposed in sheets, and predominantly they are showing considerable degree of pleomorphism. They are epithelioid or polygonal in appearance, and also some of which are bizarre in shape, and many of them exhibit prominent nucleoli. And they have moderate to abundant amount of cytoplasm. And the tumor also showed areas of necrosis. So again, the morphological findings are consistent with that of a mesothelioma. CK7 stain was positive, WT1 stain was focally positive, and the other panel was like CK20, TTF1, PSA and CDX2 were negative. At this point of time, having made the diagnosis of malignant mesothelioma, the patient opted for referral to a center of his choice for further management. So he went to New Delhi for further management. So just in brief about this lesion, malignant mesothelioma, it is a rare tumor of the mesothelial cells. Predominantly it occurs in males, and the most common site is pleura, which is affected in around 80% of the cases. In around 10% cases, peritoneum is affected. In this case, it was a peritoneal mesothelioma, And the implicating agents are usually, the known implicating agents are pollutants, asbestos, prior radiation, or genetic syndrome. The important point here is that these patients usually they present with non-specific symptoms. Like suppose if it's a pleural lesion, then patient will just come with the complaints of chest pain or cachexia or weight loss. And if it is a peritoneal lesion, the patient will obviously come with complaints of abdominal pain. So it is in such cases, the diagnosis is established late and patients usually present to us in advanced stages. And traditionally, we accept histology as the gold standard, but recent studies have shown that effusion cytology is, in fact, it is also a very good technique to establish the diagnosis of this lesion. And the question arises whether should we rely solely on the cytological findings, or we should also take the radiological findings into account. So the answer to that is yes, we can rely on the cytological findings, because in most of the cases, the effusion masks any lesion on imaging. So we may not be able to find a particular lesion on imaging. And so how to approach a case? So obviously we look for the cellularity. If the smears are hypercellular, that is a pointer towards malignancy. We look for the architectural features like formation of aggregates, morules, or papillae. Then we have to establish the cell type, whether it is mesothelial or epithelial in origin. And this has to be further supplemented by appropriate ancillary tests. And the diagnostic difficulties which we face in cytopathology is how to differentiate these atypical cells from reactive mesothelium, and how to differentiate these from adenocarcinoma. So apart from the morphology, IHC plays a vital role in distinguishing the origin of both these cells. In our case also, the patient had a history of over 1.5 years. So it is unlikely for the patient to be a case of adenocarcinoma. So secondly, how to know if the mesothelial cells are malignant. So this is an image which was shown earlier in the day by Nalini ma'am also. The malignant mesothelial cells will show the formation, they will show a wide variation in the cellular shapes, cellular sizes. They will show formation of morules. Then they will show cell within cell appearance and presence of micronuclei. And again, a cytoplasmic vacuole will be appreciated in some cases. And these are the findings which we can see in such cases. Like either the smear can be richly cellular and it can show a disc-cohesive pattern of enlarged cells with wide variability in size, or it can be in the form of cell aggregates as well as scattered population, or it can be present in the form of sheets and papillae. So our case showed this pattern, that is the first pattern. And these are just a list of markers which we all are well acquainted with. The list of mesothelial markers, that is calretinine, D240, WT1, GATA3 and CK56, and then of course we have a panel of markers to rule out carcinomas. So coming to the treatment and prognosis, we all know it is a highly aggressive tumor of the serosal cavity and it has a very less median survival. Usually the bad thing is that these tumors are usually diagnosed late because of non-specific symptoms. In earlier stages we can go for surgical resection, but in late stages the patient has to be taken up for palliative surgery. So just to, this is my slide for the take-home message of the day, that why this case has been presented. It is because cytology provides a crucial window for early diagnosis, with effusion being the first clinical presentation. So if we diagnose the case then and there, the patient obviously will, the need for biopsy will be obviated. Then the International System for Reporting Serous Fluid Cytology states that if the cytomorphology is quite convincing, then the diagnosis of malignancy can be satisfactorily given, and the more the better if the cytomorphology is also added on by the ancillary studies, then it is quite definitive and as actionable as histology. So that is all for my case. Thank you for your patient hearing.
Very nice case presentation, Dr. Pallavi.
Thank you, sir.
I think ISC has a better role as adjuvant to histopathology. I think ISC
Sir, with
for
each
diagnosis.
IHC, sir, every step will add on to a diagnosis. It can be picked up by cytology alone. And if we go for biopsy, then of course, if we add the IHC panel, that will like be a stamp on a diagnosis. So IHC will be definitely be confirmatory.
Okay, thank you.
Any question from the audience? Because this is really very interesting and important topic, especially for PGs, to differentiate between mesothelioma, adenocarcinoma, benign proliferation, malignant mesothelial proliferation. These are the problems which we face in a day-to-day practice, or you can say day-to-day studies in the department. These are the common problems which has been very well discussed by, let's say, Dr. Pallavi. In short, and she has given every point. So from PGs, any question? So thank you, Pallavi.
Thank you.
Presenting so nicely.
Thank you.
And thanks to organizer, especially Dr. U.S. Singh, Dr. Madhu Kumar, Dr. Suresh Babu, Dr. Rasmi Kuswa, for giving me opportunity to come on this dais as a chairperson. I am alumni of this university. I have a very long association. I think the department is doing very well, and the whole session is on live. The YouTube channel is already on air. I have observed so many people are seeing this session. I think it is a good management of organizing committee. Thank you very much.
I now request the chairpersons to please present the memento to Dr. Nidhi Verma, ma'am. Sir, ma'am, please present the memento to Dr. Kachnar Verma, ma'am. Ma'am, please present the memento to Dr. Pallavi Prasad, ma'am. I kindly request Dr. Amit Rastogi, sir, to please present a memento to Chairperson, Dr. Vatsala Mishra, ma'am. I request Brigadier Nikhilesh Kumar to present memento to Dr. P.K. Gupta, sir.
We have nearly reached the end of today's academic extravaganza. We shall now be having the general body meet that would be followed by the valedictory function,
And for the same, I request all our delegates to please stay back as we would be distributing the prizes for oral presentations and poster presentations. Before we begin with the general body meet and valedictory function, on behalf of the entire organizing committee, I want to express my heartfelt gratitude to all of our presenters for the didactic lectures that brilliantly encapsulated the crucial nuances of diagnosis. Thank you so much. And now for the general body meet, please may I call the President of Indian Academy of Cytologists, UP chapter, and Secretary, Professor Ramnaval Rao sir, the Indian Academy of Cytologists, UP chapter. Thank you.
Hello, good afternoon, good evening, everyone. So as we are moving towards the end of the sessions, so now we are going to conduct the GB meeting. So we have discussed few agendas in the Executive Council meeting, which we are going to present in front of you. And we are also going to present the development in the last 1 year. There are lots of development about the society, some changes, some renewal. So everything will be discussed in front of you by our secretary, Dr. Ramnaval. So I welcome Dr. Ramnaval to present the development and the agendas of the executive body committee, which has been discussed a few minutes back now.
Good evening, everyone. Now, the last year agenda was, first agenda was renewal of registration of society. The registration of IAC UP chapter got expired in the December 2021, which could not be renewed due to the COVID-19 pandemic situation. It was suggested by all the members to get the renewal of the registration of society at the earliest. First point, and second point was the PAN card application. The PAN card was expired, and due to the unavailability of the PAN card, society bank account has become inactive. Now, third point was to start a website of association. Now, okay, no problem. Now I have given the application for the renewal of the registration of society. First of all, we have take the permission for the renewal of the expired registration. So we have given the application in our format. So we have taken the permission to renewal of the expired registration. So I got the application for renewal of the registration. This is I got application to the renewal of the application. So for the renewal of the application, we need the audit of our account. And so Indian Academy of Cytology UP chapter, these are the balance sheet. This is required for the registration of the expired renewal of expired registration. So we also need the audit of the account. So we have audited our account. These are the every year auditing of the accounts. After the auditing, they have also required all the members every year, whatever they have changed in the members. So we have all this every year member changes, a list of this, and signed by the all authority, president, secretary, and treasurer, and any other members. So these are the every year members, executive body members. So we need the copy of the procedure of the general online meeting confirmation. This is the formatting. So we got the registration after filing this. So our society UP chapter has been renewed for another 5 years. So this is the expired registration and then the renewed. So second is the PAN card application. So PAN card application was submitted initially after registration of the society. However, the PAN card application got some query from the NSDL, which could not be followed up due to the various reason. Due to inability of the PAN card, society bank account has become inactive, which need PAN card for the KYC of the account. It was felt by the member to look into the above matter, ensure availability of the society of PAN card. So PAN card activated right now. This is the PAN card. We have issued the PAN card. Now to the third agenda was to start the website. So it was felt by the member to have the website of the society, to communicate all the update of the association, to provide the teaching material for the members on the website, and provide a portal for the online membership application. So our website is also online activated. So this is the website. This is our website. This is the executive body of official VRS, executive members and the scientific committee, and the past and president and secretary. We have also linked the UPCYTOCON 10th 2013 also in this website. हैंग कर रहा नहीं, ये इसमें वाईफाई से नहीं छोटा कर रहा था, कुछ प्रॉब्लम होता है. Now the following agenda was discussed today in the council committee meeting. The registration member fees was increased from 1500 to 3000 for the each membership. That is approved in the for life membership. The temporary membership fees is the 1000 annual fees. So that is approved in the executive body. For the oral and poster presentation, the membership also required. It is also approved. So next venue of the UPCYTOCON is BHU. That is approved in the general body meeting. Any other agenda from house?
Traveling ka bhi, it has not been finalized. So basically the venue for the next conference has been decided, the BHU in the Varanasi. If there is any other contender or wants to organize conference, they can also.
Dr. Amrita, the venue of BHU, it is confirmed by your HOD, Dr. Sandima. That is finalized.
Any other agenda? So basically, the fee has been raised from 1500 to 3000 rupees for the life membership, and there would be an annual membership which will be charged 1000 rupees per year, and if somebody is annual member for 3 consecutive years, he will be allowed life membership after paying 1500 rupees. And the PG students, they will be allowed affiliate membership, and they will be charged 500 rupees for the same. And everybody whosoever is interested in oral or poster presentation will have to be member of the society first, just like many other recognized bodies. And the tenure of the secretary, joint secretary, come treasurer, co-treasurer would be for 3 years. The president tenure would be for 1 year, and the president can be re-elected if there is no other contenders. So these are the decisions which has been made in the executive body meeting. If there is any objection or any issues regarding these decisions, that can be challenged or can be discussed. Everybody please sign your attendance with your phone number, email ID, so that we can contact you, we can circulate the GV minutes with you. Thank you so much. So, the society, the KGMC, basically they have decided to felicitate Dr. Ram Naval for such a wonderful job he has done in the last few months. He has got the society registration renewed in a very short span of time. He has got the PAN card, and he has also contributed a lot in developing the website of the society. So they want to felicitate Dr. Ram Naval. May I request Nujat ma'am to come forward to, yeah. Is there any, yeah. Yeah. Yeah, for students, that will be affiliate membership. And they will be charged 500 rupees, and they have to be member to present their poster or oral presentation. Yeah, for presidentship, at least 15 years, either if the person is faculty in a medical institute or medical college, he or she should be of professor, yeah. And if somebody is from private sector and working as consultant pathologist, he or she should has minimum 15 years experience in pathology with the, yeah, work in cytology as well. So may I request Nujat ma'am please come forward to felicitate Dr. Ram Naval. A big applause once again.
Very big job done, yeah.
Thank you, ma'am. So now, so thank you everyone for joining us for this GVM. So next year we would be meeting again in the next annual conference at BHU, Varanasi. Award excellence. चलिए हमारा बैग
सर कुछ नहीं बस ये आपको लैपटॉप हाँ ये मेरा है हटा लेते हैं यहाँ से हाँ मोबाइल हमारा है
Same, I request Professor Riddhi Jaiswal ma'am to please come on stage.
Thank you, Isha.
हाँ बहुत यहीं खड़ी रहो, सेटल हो जाने बस।
चलने दीजिए
बैकग्राउंड। So half of the valedictory has already begun. Residents, please settle down so that we can just announce the names, and if you are the lucky ones, you can come up on the stage once again. May I call upon the stage the judges, the honorable judges of the oral presentations today held in the morning. Dr. Suresh Babu, sir. Dr. Rashmi Kushwaha, Dr. Ram Naval, sir. And Dr. Zakaria Chaudhary. Is he there? हाँ, sir आइए.
सर कहाँ गए? बाबू सर कहाँ गए? वो आ गए, वो आ रहे, डॉक्टर चौधरी आ रहे।
राम नवल सर खड़े, उनको बुला।
उद्यमेन हि सिद्ध्यन्ति कार्याणि न मनोरथे न हि सुप्तस्य सिंहस्य प्रणिनन्ति मुखे मृगः. Without hard work, nothing can be achieved. The deer does not come to the lion's mouth. And you all have just proved it since the morning. You have been attending the lectures, attending the classes. Whatever academic feast you got here, we are so happy to see you. And your hard work really showed up in the oral and poster presentations. I'm proud to announce the names. The first prize for the oral presentation goes to Dr. Vibha Tripathi. Oral presentation 24. She is from HIMS, Barabanki, and the title of her presentation was Discordance Between Imaging and Cytologic Findings of Breast Lesions. What next? Congratulations. Vibha, please stay on the stage. The second prize goes to oral presentation number 10, Anshima Singh from SGPGIMS, Lucknow. And her title was Diagnostic Utility of Squash Smear Cytology in Cordoma, a tertiary care center experience of more than 10 years. Anshima, stay back. The third prize goes to oral presentation number 13, Ajit Ojha, again from SGPGIMS, Lucknow, and his title was Cytohistological Correlation and Risk Stratification with the Application of Milan System. Now, we already have the oral presentation judges here. May I now invite the judges of the poster presentation. Dr. Subrat Chandra has left. Dr. Aarti Bhattacharya, ma'am. Dr. Ajay Kumar Singh. Dr. Mala Sagar. Dr. Vineet Tandon, ma'am. Dr. Sudhir Srivastava, sir. Dr. Atin Singhai. Dr. Nidhi Anand. So the first prize in poster presentation goes to Dr. Shashank Pandey from Allahabad. After n number of mails that he sent to us. Correction and correction and correction, but he was so adamant and he presented very well. And his title was Diagnosing Urothelial Malignancy via Urine Cytology. The second prize in posters goes to Dr. Richa Singh from KGMU. Is anybody else? Any of the residents? Oh, Arina, come. Her title was Audit of BAL Cytology in a High Throughput Hospital. The third prize in the posters category goes to Dr. Yashika Sharma from Meerut. FNAC of breast lumps by IAC Yokohama system, a study of 100 cases. Do we have her here or someone in place of her to collect it? From Meerut? Okay, so we'll just keep it with us. We'll inform her, okay. I would like to extend my thanks to Dr. Geeta Yadav, Dr. Millie Jan for cooperating, Dr. Rashmi Kushwaha, Dr. Malti, और कौन-कौन थे आप लोगों के साथ? Oral में Dr. Sumaira Qayyum,
Dr. Malti,
and the judges, of course, we have here for making it a great success. Thank you so much. And we can, now the winners may come in the front to have a photograph with the judges. ये जजेस वाली इनकी वो जान लीजिए जजेस और बच्चे अभी बुला रश्मि जी अभी हम बुलाएंगे पाकल जी
खिचड़ी पकाने के बहुत
बच्चे उतर गए हैं बच्चे उतर गए नहीं बच्चे बैठे हैं हाँ ये तो उसमें थी ना पैनल में जिसको
ये पैनल में थी तुम आई
पैनल वाले तो
खड़े
यार अरे ये बात में
हम लोग यहाँ हम लोग खड़े हैं पीछे से आ जाएंगे सुनिए अनाउंस सुनिए डॉक्टर दीदी सुनिए अनाउंस कर दीजिए देखिए अतुल गुप्ता सब लोग जा रहे हैं अनाउंस कर दीजिए
Before we disperse for the banquet to begin at 7:30, judges to stay please. We have to honor you as well. Judges please stay back on the stage. Sudhir sir please वापस आइए.
सुधीर सर
May I now request Dr. Vinay Kumar, Professor and HOD, GMC Almora, and Professor U.S. Singh sir, our HOD, our dynamic HOD, to please come on the stage and present mementos and certificates to our judges for giving their valuable time. जाते जाओ सर आप आगे आइए ना आप लोग के पीछे खड़े हैं आप आगे खड़े हैं डॉक्टर सुधीर श्रीवास्तव है ना हाँ बोल रहे डॉक्टर विनय तो डॉक्टर अतिन डॉक्टर माला सागर यहाँ से दिख नहीं रहे
सुरेश बाबू सर भी
कहाँ हैं
ये क्या आ गया
सर सुरेश बाबू सर प्लीज कम ऑन द स्टेज वी वर वेटिंग फॉर यू वी कॉल्ड आउट योर नेम आइए प्लीज डॉक्टर विनय सर टू प्रोफेसर सुरेश बाबू सर to Dr. Aarti Bhattacharya, ma'am. To Dr. Atin Singhai. To Dr. Zakaria Chaudhary. To Dr. Ram Naval sir. माला जी कोई और नहीं हमारा अरे To Dr. Rashmi Kushwaha. ये बैठी महारानी तो ये मॉडरेटर थे कि जज थे जज थी ना पोस्टर की जज थी ना टीचर तो डॉक्टर मालती मौर्य।
अपने लोगों के लिए भी, सब लोगों के लिए नहीं तो करा अपनी गीता मिली शिवानी सबको करा।
अच्छा, अब हम सारी फैकल्टी को वेट कर रहे हैं। हम सारी फैकल्टी को,
हाँ वो सब पूरे वो बैठे हुए दोनों। क्या बोल रही थी मैं? बोल ही नहीं चल रहा है।
हाँ, अब बुला रहे सर। हाँ, thank you so much for judging our competitions. Now we invite all the faculty members of our department as well as those who are guests to please join us on the stage for a group photograph and for memento as well. हाँ बिल्कुल बिल्कुल सर, आइए। शालिनी मैम, मिली, और कौन? सर देंगे। हाँ वही वही सर, इसीलिए डॉक्टर मिली जैन सर प्लीज। हाँ ये सब एवरीथिंग इज म्यूचुअल हियर। हाँ डॉक्टर शिवांजलि रघुवंशी। थैंक यू बोलो, नीचे उतारो जाओ। आओ वेरिडिक्ट्री में हो गया। अजय सर कहाँ हैं तुम्हारे? वो घर पहुँचे। डॉक्टर अजय सर चले गए। डॉक्टर शालिनी भल्ला मैम।
अरे नाम
तो चुका
आप बोल नहीं रही है।
आ रही है अब बुला लियो। वो तो जज मतलब उसमें भी थी तो कोई बात नहीं। अब कितने लोग बच रहे थे?
ये लो
डॉक्टर सुमेरा कयूम।
मैं अंदर रख दे।
तुम बचो। डॉक्टर गीता यादव। मेरा नाम कौन बोले?
मैंने जमा कर दिया।
अरे मेरा नाम कोई बोले?
हाँ मैं बोलूँगी बिल्कुल। आप जाइए।
तो वो भी तो दो, ये भी तो पास करो पीछे से।
हाँ कर दिया कर दिया। कहाँ का नाम?
अब सर आप
and for sure Dr. Riddhi Jaiswal ma'am. And it's a pleasure to finally invite Dr. Madhu Kumar, our organizing secretary, जिसने शुरुआत की। उनके लिए एक राउंड ऑफ अप्लॉज थोड़ा तेज वाला बनता है भाई। अरे हम भी बजाए तो
कोई नहीं रहा सर, हो गए। फोटो खींच गया
सर तो फोटो में तो सॉरी
सर वो भी नहीं है, उनका भी
बन पाएगा जितनी अभी टेक्नोलॉजी डेवलप नहीं है।
अच्छा सुनिए, एक कॉमन फोटोग्राफ। हाँ आइए, आओ सब लोग आइए। अब इधर से बुला लो बच्चों को सबको।
अरे कैसे? आपको तो हम लोगों ने वो कर लिया है। हमारे डिपार्टमेंट के। आइए वो फोटो वगैरह वो साथ में आइए। आइए वो बेटा सब लोग तुम लोग डिपार्टमेंट सब आप डिपार्टमेंट में आइए। आइए अच्छा रखो। आइए
So everybody is requested to gather again at 7:30 for the banquet and cultural program. Thank you so much. At the same place at 7:30 for cultural program to be followed by dinner. Thank you so much.